del procedimiento o al final del tiempo de seguimiento. El tendón cuadricipital está últimamente de moda, es fácil también.
So it's recently in fashion. It's easy subcutaneous, but because it's less used, it probably requires more of a technique for a surgeon. It's very powerful, either 3-layer or 2 layers. 1 layer is more than enough. There can be variability depending on the individuals. Sometimes they don't have so much anterior pain. In the end, we have a strong tendon, but the less it's used, and obviously that depends on the surgeon's experience. The extraction may or may not include bone. We may leave a capsular effect because of the 3 layers, and we have the tendon and the capsule that is exposed. There may be liquid loss during the treatment, and this may be a problem, but the greatest weakness is that there is only bone on one hand. That's one of the main advantages of this tendon. We have bone on both sides. As for allografts, as we all know, 50,000 types in the market, and we can avoid the lack of donor site morbidity. We have a lot of, it's quite a strong graft, and it can also reduce surgical time from the point of view of the different problems, and obviously the risk of transmitting diseases persists. It's of slow incorporation, and it can lead to immune response, and there is a higher re-tear rate. So those are the kind of disadvantages, and we will also talk about what's in fashion. Repair versus reconstruction. This is what we've been doing over the last 60 years practically. Repairs are very well known. There are many different publications. There has been a revival of this due to Martha Murray, who is the American researcher. She has been using small scaffolds with internal breaks and grabbing the stump well, tying it back, and she has created a comparative study showing that there are no differences, at least with the hamstring in a short term, so 2 years when compared to reconstruction of the ACL, and in terms of the anterior posterior aspect. As for augmentation, we have a small contribution that has also worked. We have published a lot over the last 2 years, and we look at that over a 5-year period, looking at parts of the ligament that haven't torn, and we've added value. We've seen that the rate has been very good, and this is a cumulative failure rate, which is 2.6 for 5 years. This is more than acceptable for the ACL. As for the reconstruction, and this is the last aspect, it has been known from the beginning of the last century. We have debated whether it should be anatomic or non-anatomic. We have been using non-anatomic technique, then we passed to more anatomic techniques from the anteromedial portal, which gives us better ability to control the knee, and there is a low prevalence of arthrosis as well. And as for the non-anatomic ones, especially when we use over-the-top techniques that for some reason or another behave similarly kinetically to anatomic reconstructions, this preserves the knee over time. Therefore, these work quite well. Single versus double bundle, they're better for rotational stability, but we've also seen that the results are very similar in both, and therefore it seems logical to use one bundle because two don't contribute too much. In recent times, there's been a lot of interest to understand whether there should be peripheral reconstruction. We're going to be talking about this later, but at least in my opinion, it seems that on the lateral side, the iliotibial band is much more important to control internal rotation, and this is why it makes sense if it's done in an individual with high degree of pivot to use these techniques. This is without a doubt one of our favorite techniques, whatever you wish to call it. We have surgical tech anatomic ACL, so we have to design our tunnels really well to approach the medial face of the contralateral, to look at over the top and the anterior part. And remember, in almost all of the images, we see an extended knee, but here we're going to see the flexed knee. So the anatomy varies a little bit. The posterior femoral part allows us to locate the exact part, and it's a little bit more posterior, probably 60% than anterior. This would be the area. We can observe it from the anterior medial part with the high portal as shown by Freddy Fu. This allows us to drill adequately, creating a tunnel and approaching it in a correct way in this case. I think this is well known by you all. At the tibial level, we act as anatomically possible, and therefore we look for the most anatomical insertion. If there's a stump, the stump will guide us. If not, the anterior part is probably the best reference, and we can move it and drill our tunnel as required. And we have a high success rate. This is well known, between 75 and 90%, based on the stability that we obtain and the relief of symptoms, as well as a return to pre-injury level activities. But the revision rate is not low. So there are many revisions of the ACL, and it seems that there are some factors that contribute to this. Between 10 to 15% need revision, although out of these errors, 70% are due to errors of the surgeon. Therefore, it's very important to really pay attention to the technique and remember that the younger age, higher activity level, especially when it implies pivot activities and also the use of allograft, are probably the most critical factors. So to end, we could conclude that it is highly prevalent. We're going to see that in the morning. There's very little difference between graft types. Maybe allografts are the worst. We need to be careful with them. And then the anatomy also is very important. The take-home message is that most causes of graft failure are avoidable. They're due to our incompetence rather than the lesion or the injury, and therefore we need to control the technique anatomically. This is very important. We'll be in Paris and we'll be expecting you all there. Thank you very much. Okay, the next speaker will be Pablo Helvet, who's going to talk about a very important aspect of repairs. Thank you, Jean Carlos. Okay, so I've been asked to talk about peripheral structures, but I preferred, because I didn't understand it as much, I wanted to talk about something very similar to Jean Carlos in a very complementary talk. And basically, in the end, what we should take into account as surgeons is how we can have an impact on the results of our patients. And evidently, there are many factors where we cannot act, but there are cases where we can act. And many of those have been mentioned by my colleague. And this is what we should emphasize and understand, how we can have a positive influence or neutral influence on the results. There are many factors, and each one could be have its own congress. I will not be able to focus on all of them, but I'm going to focus on the ones that are being highlighted here initially. There is a little bit of controversy about whether we need to operate quickly or not, acutely or urgently, but I think I'm asking the question about whether there's any difference between operating 3 or 4 months later or a year later. There's an article, this article here, that was issued a few years ago, and it created a lot of damage for surgeons because the conclusions, and obviously there are sometimes mistakes in articles, is that you didn't have to operate because you only operate about 30 or 40%. There were 2 groups, one that was operated immediately and others that did rehab. And if they needed surgery, they would have surgery at a later date. And they said that this helped avoid 60 or 70% of surgeries. But this was published 5 years later with 5 years of follow-up, and they saw that 66% of the patients that hadn't had surgery required surgery, and there were greater lesions there. So before we conclude prematurely, we should wait for longer-term results. Why does this happen? If we let time go by, as also shown in the second article of the previous series, this increases lesions, especially those that are most recognized. The medial meniscus with the ACL that increases pressure on the horn, and therefore it's logical that these tears will increase. That's almost double over time. With the lateral meniscus, this is not the case. We can see that it can basically be attributed to the type of lesion or lesion mechanism because the incidence is rather stable over time. And it's quite different when we look at cartilage lesions. Clearly, as in the medial meniscus lesions, the trend is to increase exponentially if we have an unstable knee. And then also at the end, another factor that we should take into account is whether there is greater tear or less tear. So it's logical to think that if it's left over time, it tends to stretch, and the plasty may tend to rip or tear more, but this hasn't been shown when we look at whether it's operated chronically or in the first few months. It doesn't really show a difference. Focusing specifically on having less lesions in the cartilage and meniscus if we operate quickly, and there are some reports that are more controversial, so it's not unanimous, where they say that function is higher if we operate sooner, but that's also a little bit arbitrary. There's quite a lot of controversy there. What does that mean? Does it mean 1 month? Does it mean 3 months? Does it mean 12 months perhaps? There is more consensus, not robust experience, but many say that we should operate between 6 to 12 months instead of postponing it even more beyond that time. Let's move on to the next topic, highlighting Jean Carlos's comments from earlier. I completely defend the fact that you can choose a kind of plasty. So saying that one is better than the other, I mean, isn't great. In the end, they all work quite similarly. What we need to do is adapt to the patient rather than the other way around. I'm not going to use the same for each patient. We should use all of the techniques to make sure we choose the right one for the patient instead of the other way around. So the patient adapting to the only thing that I know how to do. As for the failure rate, which is perhaps the most important endpoint when we are choosing the plasty, except for the allografts, within the allografts, there isn't great difference. It just depends on the article that you read and what you believe or how you interpret those articles, and depending on that, you'll have different conclusions. Therefore, we can't say that one graft will break more easily than another. By contrast, there can be differences in millimeters or very small percentages that aren't very relevant. So if we consider the 3 most important grafts, the most important ones, the hamstrings, and the others, if you have a hybrid fixation, all 3 of them are comparable in terms of functional results and the stability that they perform objectively or create, and also the failure rate. So it's not so much about the kit as such, where we can really have an impact, and this is also what my talk is about in terms of the results for the patient, is in helping that plasty with clearly higher results and better results if we apply an anterolateral technique or if we don't apply it too. So that's a whole other topic that we could address in a conference, but as long as I mean, this does not create damages for the knee, but it may create benefits. In the end, the plasty that we choose depends on the patient. The patient should decide or help us define which plasty to use. Let's say if you have a football player that's always jumping around, you may use the tendon, but for example, in football, you wouldn't use that because of the flex and the strength and the flex and the amount of grace we need to adapt to the needs of the person. It's very different if it's a sedentary patient. Perhaps an allograft would work better for them. So we have to fine tune that, and depending on the preferences. Then I'm going to talk about fixation. The type of fixation is not very relevant in terms of how we have an impact on results. There are many different results, beautiful results, transfixing, also iliotibial strategies, and there are cortical attachments as well, but they're all quite comparable. They have very reliable results. And where I think that perhaps the weak point of the construction of the plasty and its attachment is probably at the level of the tibia. The tibia is quite weak. It's more porous, and that's where we need to have greater influence, especially when we're talking about grafts in soft areas using what's most used at the global level. And as I said before, I fervently defend the fact that the soft tissue, so hamstring tissue, grafts at the tibial level, we need to have hybrid attachments or fixations or double fixations, because in many biomechanical studies and some clinical studies that I will show later, they have shown benefits at the level of objective stability, basically for the first 2 or 3 months of rehab until that physiological stability is achieved. So the initial or primary fixation with the grafts should reach almost 500 newtons, so that can adjust to the time. And so there are some mechanical studies like this one where we can see that with an isolated fixation, we will not reach that minimum. The cortical one comes closer to that, but where there is really an impact is when we use both types. So this, we don't have to think about increased cost. I like to use an interferential screw and paste, but we can use normal screws plus a cortical screw that is basically free. We don't have to think about extra cost because there are other alternatives that we can use that are completely accessible. In another study, it's the same. So we can see quite similarly, as we saw before, the extracortical isolated one is a little bit better than the interstitial, but they obviously not as good on their own as they are when we have double fixation above those 500 newtons in the first 3 months. So the result is that we have a stronger graft that is more rigid and less laxity, and few studies say they're superior, but it's very similar to the hamstrings, where functionally there are no differences when we have simple or single fixation, but we know that there is greater objective stability, and this is why we promote the superiority of the tendon versus the hamstring, but we discard that if there are problems with the kneecap. So this is all very in fashion. This is another factor, the orthobiological factor. So in this case, there's a lot of false myths and voodoo, magic and acts of faith, especially, well, I'm not going to talk about all the limitations, but it's very similar to what we were talking about now. If we look at the biography for the ACL, not just in the previous context, but also when we look for these words in Google, there are beautiful sounding words and beautiful words for patients, so potential enhancement, regeneration. All these words are very attractive. No one likes to hear cut or operate. Everyone likes the word implants and Botox and hair implants. This is far more attractive than surgery, of course. Therefore, we are at a disadvantage. We're managing a disadvantage when we don't believe in this, because from the media point of view, we are at a clear disadvantage.
Ahí está. Sin lugar a duda que la biología es importante.
Without a doubt, biology is very important. The ACL and its biological integration, as well as the main cell of the fibroblast plasty. There are many targets where it can be used, and this is obvious. Obviously, the PDGF, the growth factor, is something that promotes collagen from that theoretical point of view and experimental point of view. It does make a lot of sense, but from the clinical point of view, there are quite low reputation studies with little scientific rigor that say that there could be an improvement at the level of the biology of the ligament, and the results in the MRI could be better. But I insist, these don't have great scientific quality, and there are very few articles that say this. From the functional point of view, there are no improvements if we are to use orthobiological products. Therefore, I'm not saying that you can't use them, but we should be honest. We shouldn't lie to the patient saying that they will have better results or better biology. We can perhaps generate an anti-inflammatory effect, perhaps, but we shouldn't deceive them saying they will have better results, because if we do that, then that's simply dirty money. And the final factor that I would like to talk about is returning to play, which is quite at our reach. It's controversial to state when they can go back to do the sports they used to do before the injury. Within all the different factors that are important today, or not important, but perhaps necessary, one of the factors is time. So we can't give them a threshold where we say, as of this day, everybody can go back to sports, because that's simply not the case. What is necessary is to have a prudent amount of time for the biology to allow us in a very complementary way with lots of different factors to allow us to allow the patient to return to sport in a relatively safe way. So we can see here different patients, especially ones who are fans of sports, who find it hard to follow our instructions. And being honest, I've never really found a bibliographic source on the internet. I've used one that perhaps doesn't adjust 100% to the truth, but I think that it's the visual impact that we can take into account for the patient, because evidently when the patient has just been operated, they're in a lot of pain, even with resistant grafts, but we all know that these grafts lower to about a third of their initial strength, but patients start to feel much better, there's less pain, they're recovering, and they're tired of a conservative process, and that's why we need to be careful, because 6 months have passed. So I would say that maybe 8 months is better, so that they have a respectable amount of strength. So in terms of time, I rarely allow them to go back to sports before 8 months. Obviously, there are some people who can go back 4 months later or 1 month later, but there will obviously be a higher failure rate. And in our own case, you know, if 10 or 12 months go by, I think it's okay. And that's what we do in children. We try to be more conservative, and we ask them to go back to sports about 10 to 12 months later. There are other factors that are complementary and necessary. They are also at our reach. So these are strength, and also the perimeter. We can see the image of maturity here on the MRI. Functional tests are very easy to do in the clinic, but it also allows patients to self-assess within the rehabilitation area and add targets in terms of when they can go back to sports. So these very simple tests. Muscle deficits are very, very important, especially at the level of the hip. I obviously going to explain to you the importance of this to have a functional valgus. These are things that are within our reach, and we have functional scores as well. And without a doubt, I'm a fan of the ACL-RSI that allows us to assess not just objective factors, but also psychosocial factors in the patient, so that they can really feel safe to go back to sports. That's another score that I really recommend. And then finally, we need to be honest, they can't do all kinds of sports, or they won't have the same possibility for each sport. So in terms of returning back to sport, these are the resources that I use that are easy to use: isokinetic, strength, functional test, and the ACL-RSI. So I insist, complementing Giancarlos's comments, there are many places where we can have an influence or try to influence some functional results, and we should focus on this rather than sterile matters where there will not be any clinical implications. Thank you very much.
Thank you, Pablo. We'll move on now to the bone morphology and the influence on ACL reconstruction. David Dejour is the past president of ESCA. He's coming from Lyon, and he's spreading the words of the Lyon knee school.
Yes, I try to. Thank you, Jacques. Very happy to be in Cartagena, and muchas gracias por la invitación. Somewhere. It's not exactly my presentation. So you want to speak? Okay. See you later.
Bueno, lo hará el doctor Jacques Ménetrier, perdón, pequeño cambio para ir más rápidos.
Sorry, just to be quicker because we have a different presentation up. We're going to listen to Professor Jacques Ménetrier.
Point on the factors that can optimize your ACL reconstruction. I'll try to convince how important meniscus are. But before that, I would like to invite all of you to the ESCA Congress in Paris in April, where we have really an outstanding scientific program with highlight lecture and keynote lecture. You know our format on the condensed 3 days, but you will have also the opportunity to hear about consensus. ESCA consensus is a huge amount of work. It lasts 2 years and it goes to standard professionalization. And you have heard about PRP, for example. So we have one consensus of the use of PRP in our sports orthopedic field. We will have also a consensus of ACL revision and a consensus of indication and technique of osteotomy. So I really invite all of you to join us in Paris, and please register. This is the time. France is wide open. You can now gather together as you want. Probably mask won't be mandatory from next week. Therefore, we are safe to travel and safe to gather together and celebrate the 40th anniversary of ESCA. Those are my disclosure. Well, just as a reminder, and especially for the youngest, the meniscus is probably the greatest absorber human nature has created. Is really, I would say, a load distributor, is a shock absorber, and is a stabilizer. And this function we will perfectly look at this morning. But not only. Between the cartilage and the meniscus, there is really intimal couple. And you see on this nice representation coming from Henning Madrid that where there is meniscus, there is no much cartilage. And probably the load sharing, the gliding of the joint is really divided in between the two structures. Well, another reminder, the meniscus can heal as long as the lesion is at the periphery of the meniscus by two different processes. The first process is just the migration and the proliferation of cells coming from the original meniscus. And the second, and this is the most common one, is coming from the periphery and from the synovium. The synovial cells will migrate into the lesion and seal the injury of the meniscus. And this is two things that you have to keep in mind with the different lesion we will discuss. So you know very well the classification of meniscal lesion according, I would say, associated to the ACL. We're talking mostly about longitudinal vertical tear, but also to oblique tear. You know those very well. And we will discuss briefly about bucket handle management later. Well, now for a certain time, we have seen describe other lesion on the meniscus, the radial tear, the instability of the posterolateral corner of the posterior horn of the meniscus, the root tears, as well as of the meniscosynovial tear or ramp lesion. Well, those are, I would say, mostly seen associated to ACL injury because they require a relatively high energy trauma. Well, the way we look at that is meniscus is part of the global stability of the of the knee. And those lesions will clearly interfere with the stability of your joint. We identified the posterior belt on the medial side, including the medial meniscus. We do identify the posterior belt on the lateral side, starting from the PCL towards the hiatus popliteus, and the anterior belt that is going from the hiatus popliteus toward the ACL. And you know that the anterior horn of the lateral meniscus, the fibers fuse and merge with the ACL insertion, and this is the end of the circle. Therefore, you have to look at that very carefully. Now, for a certain number of years, we have developed a systematic review of our meniscus within an ACL reconstruction, and one of our fellow, Kazu Goto, looked at that recently, and he found more than or close to 80% of the lesion, and therefore isolated ACL tear, at least in the type of population we have, where we have a lot of alpine skiers and footballers are not, I would say, so frequent. Very often you have an associated lesion, and this lesion has been also found by another group that is looking carefully to those meniscus, the group of Romain Seil in Luxembourg. Well, what did we find? We found more than 78% of lesion associated to the ACL, and you see 40% were on the medial side, close to 60% on the lateral side in this ACL tear. On the medial side, most of them were meniscosynovial lesion. We have a couple of Beckett Handel, as everyone, and some root tear, but root tear are more scarce on the medial side compared to the lateral side. On the lateral side, we had I would say a few amount of root tear associated, complex one, meaning instability plus tear in the root, as you see here, and a lot of posterolateral instability in this series. Well, as you see, the management in more than 80% of these injuries are suitable for repair. And this is what we try to do associated to the ACL. And actually, our ACL reconstruction lasts much longer than before, since we have now to address all these injuries. I'll say on the medial side, you have to look at all these different injuries, like sort of a systematic checklist, if I may say that. We have to know that on the medial side, the Beckett Handel tear, if you have a really central tear, those will not heal. And probably, especially in athletes, it will not be worth to try to repair it. You may face a high level of failure. And in the professional athletes, that may really be troublesome for your career. So if you have, I would say, a Beckett Handel tear that is really central, we still remove it. The rest, we try to fix it. On the lateral side, same thing. You have a checklist that you have to look at to make sure that you are not missing any of these injuries. So if we will discuss a bit of this, starting by the meniscosynovial lesion or ramp lesion on the medial, posterior medial aspect of the knee, you have to systematically go into this posterior medial compartment, either through a transnotch approach or by a posterior medial portal approach, to make sure that you're not missing this meniscosynovial lesion. Those has been classified now in different aspects. You don't need to be so sophisticated, but if you depict it, this is very important to fix it. And nowadays you can fix it with, I would say, an arthroscopic technique all inside, or from a posterior medial portal, by fixing it as you will fix with special hook and anchors, you will fix this lesion back. Once again, you can do it now with all inside technique coming from the front. You must do inferior and superior suture. Here you see the superior sutures. What is extremely interesting is that you can do a first horizontal, then you can do vertical inferior. But what is important is you have to reduce the meniscus accordingly from the front, which may be sometimes difficult to achieve, but this is something feasible. And you always pass again through the transnotch to make sure that your fixation is well done and that your meniscus is fully reduced. That has been shown by a really nice study making by the Andrew Amis group, that this is easily feasible and that your anchors can be well placed on the other side. Root tear, the root tear, we use obviously the Laprade technique on the medial side. I just mentioned it. This is scarce associated to the ACL. On the lateral side, we like to use the Peterson classification. And on this side as well, you may have the possibility to refix it, and you must refix it. So we like to use the transosseous technique when the lesion is complete. As you can see illustrated it there. But you can also look at some all-inside technique when you have a partial or a type 2 or B lesion on the Peterson classification. As you can see here represented, you will actually retense the posterior horn of the meniscus, and you can do it. How do you depict it? Usually this is an instability or hypermobility of this posterior horn of the lateral meniscus. The root is not totally torn, and you will place here horizontal sutures or X type sutures in order to reduce and retense your meniscus. As you can see, usually you have associated lesion on the posterior horn that has been compressed by the injury mechanism. Well, here again, if you fix it, this posterior root of the lateral meniscus contributes to the global stability of your knee, and therefore you will improve the global stability of this lesion. Now a more subtle lesion. Recently with Romain Seil, we have described this posterior horn instability that is usually consecutive of a lesion of the meniscotibial ligament on the lateral side. And in this case, you need to apply an inferior suture, usually vertical, to reduce the meniscus back in its place, reseat the meniscus in its proper position, and therefore restore then is a normal function. Another lesion we recently described as well is this subtle posterolateral corner injury, where you have a hypermobility of the lateral meniscus associated to a rotatory posterolateral laxity that you need to fix. Initially, we were fixing it by open technique. Now we do it arthroscopically. So you have this meniscus hypermobility. You have the classical drive-through test lateral positive. You have an increase of the size of the hiatus popliteus. And we usually can fix the meniscus back and correct or neutralize the rotational laxity you have associated to this lesion. And this again participate to the global stabilization of your ACL reconstruction or reconstructed knee. Well, radial tear, this is really a difficult one. And I don't know in your type of population, in our population now, people going in snow park, people going in skate park, people going in all those freestyle activity. We have young guy coming to the consultation with an ACL tear and this fracture of the lateral meniscus, as you can see here, represent this. Here was one of our freestyler, you know, those guys who just goes down the mountain freely and make a huge jump from a rock cliff. And the landing is just a high energy one, and you get those tears. Those are not easy to deal with, but you always have to try to repair it, because with the loss of the hoop stress effect, it's like it was a complete meniscectomy, and you have to try to restore this hoop stress effect. We know that the central part of the lateral meniscus will not heal, but we don't really care. What we want to get healed is the periphery of the meniscus and the restoration of the hoop stress effect. Well, there is plenty of literature now that really support the repair and the refixation of the meniscus. Once again, I think this is one of the critical factors that will probably optimize your ACL reconstruction. Well, to make a long story short, I will really encourage you to have a systematic examination of your meniscus integrity. Yes, you know it, but also function, and try to look at all the instability of this meniscus you may find. Repair as often as possible, especially on the lateral side. Preserve as much as you can the meniscal tissue. Use the technique you are really familiar with. This is not something that should be experimental, because you have seen it in a meeting. And in a well-performed reconstruction, we know that you can have good and durable outcomes. With that, I will once again invite all of you to join us in Paris when we will speak, of course, about meniscus. Thank you very much.
Thank you, Jacques. David, now is your turn. Yourself.
I may speak now?
Yeah.
Gracias. Muchas gracias. I may have my slides, please. So you will see now we will speak about bone. We are orthopedic surgeons, and we need to speak about bones. And when you speak about bones, and when you look at the ACL, you have to look at the slope. So when you should worry about a steep posterior tibial slope, definitely this is something important to look at. If I can move my yes. It's, I would say that it's fundamental, absolutely fundamental. And what you have in terms of bone, when you deal with an ACL, you have the notch, the width of the notch, you have the slope, which is probably the most important thing. And you have also the congruency between the femur and the tibia. The reason for an ACL rupture are multiple, extrinsic and intrinsic. And I will focus mostly on the intrinsic factors. And I will focus also on the tibial slope, which is probably one of the biggest intrinsic factor for having an ACL tear. So when you have an ACL patient, you have to look at the X-rays, AP and lateral weight-bearing lateral X-rays, and of course axial views. What to look at, the second factor, of course, you have to look at the pedal height, the trochlear dysplasia always, and also you have to measure the tibial slope. But it's also important, and you will see that later, that it's important to look at the anterior static translation. So while you're walking, you stress your ACL. So when you speak about the slope, you need to know exactly which measurement you are using, because you have probably 4 types of measurement for tibial slope, and all are different and all have different values, in fact. So when you speak about slope, speak about the technique that you are using. Probably the most reliable, the most simple one is to use the 2 proximal third of the tibia, and taking the points which are right in the middle, and then you measure the medial tibial plateau slope. The normal value using this method is 10 degrees. So about the slope, you can go also on the soft tissues. And there is a nice article by David Parker and Sébastien Lustig about the soft tissue tibial slope, which includes, in fact, the bone, but also the meniscus and the meniscus status. And you will see that it's something so important to look at. But if you speak about slope, the values that you can have using the MRI are much more, there is a much bigger dispersion in terms of numbers. The acquisition of the MRI is very short on the tibia, so it's not so reliable, but this is something that you need to look at. So the primary intrinsic factor for an ACL tear would be the tibial slope. The threshold that we are using now is 12 degrees, and it has been shown that more the slope is higher, more you have some ACL tear. So when you deal with that, you also have to look at the acquired factors, and you have seen that with Jacques, how meniscus status is important, because the slope will increase your anterior tibial translation when you walk. But if you have no meniscus, no medial meniscus, no lateral meniscus, it will also increase the strain on your ACL, and it will increase the anterior tibial the translation while you walk. So when you do that, you have some shear forces in monopodal stance, and the weight bearing constrain the ACL. So it could lead to a graft failure by fatigue if the slope is too big. For example, this lady, she re-ruptured her ACL 8 months after surgery. It was not a biologic failure. It was because the slope was too high, 14 degrees. And every time she was walking, she was putting some stress on her graft, and progressively the graft failed. So looking at the literature, you will see that there is a high and a strong relationship between slope and ACL tears. You have also a strong relationship between the slope and the strain that you have on your ACL, but you have also some relationship between the slope and the pivot shift. So you see how big and how important the tibial slope is. When you look at the static anterior tibial translation, so it means when you are walking, you put some strain on your graft. We have done these 2 studies showing that it increased with the slope and the status, the meniscus status. And we look back after surgery, after 8 months of surgery, if we were able to reduce that. And in fact, if you have a normal rehab protocol with a partial weight bearing or full weight bearing immediately, you will see that the graft alone is not able to reduce this anterior tibial, this static anterior tibial translation. So it means that your graft is over constrained in any time. So what to do with that? In an ACL tear, you have to evaluate it in detail for sure. Look at the history of the trauma, of course, the amount of instability, objective and subjective, but you need X-rays and you need also MRI, not only to look at the ACL and say, well, this is an ACL tear, but to look about the environment of your ACL, the meniscus, the slope, and the whole is around this ACL. And in the treatment planning, you will repair the ACL, of course, depending on the graft technique that you want, the placement, etc. You will add some associated procedures, the meniscus repair, restoration, the extra-articular if needed, but also osteotomies. And osteotomies could be the way to protect your graft and also protect your patient. But we have to look at the dogs when we speak about the slope, because the slope is very high in dogs, and there is an over constraint on the ACL, and it's the most frequent pathology in knee dogs are the ACL rupture, and the treatment for an ACL rupture in dogs is what they call the TPLO. It's deflection osteotomies, and it has been published in 1992. So for sure, we use that, and we use that especially in revision ACL. We used to use that in the third ACL, the second revision, and it worked so well that we moved to the first revision. The sequences is to do the tunnel placement, meniscus management, then you will do the tibial deflection osteotomy, and then you pass your graft and you fix your graft. And if you look at this video, you will see how to make it. It's not an easy surgery for sure, but it works so well. So we start to do a skin incision. We harvest the graft that is needed. We don't like allograft. You have seen that it doesn't work so much. So if you can take an allograft, an autograft, it's much better. The one which has not been taken. You identify exactly where the patellar tendon is, because this will be the landmark for your osteotomy, and then you release the deep MCL very far posterior. You release the Jurdy and the fascia lata with the anterior tibial, the tibialis anterior, like the gastric, the gastric way, as you do if you do some total knee arthroplasty with a Keblish approach. So you expose the superior part of your tibia, and you will be able to set your osteotomy. Then you put some key wires. 2 key wires are for the superior cut, and it has to go 1 centimeter below the tibial plateau and the posterior part. You need to use fluoroscopy, of course, it's mandatory. Then you put you set the amount of osteotomy that you will do. We usually use 1 millimeter for 1 degree, and we put 2 other key wires joining them at the posterior part of your tibia to have the best hinge that you could have. And then you will be able to use your saw and do the osteotomy. When you use your saw, the saw will go under the first key wire, just not to go through the tibial plateau, of course. And the second will be just above the more distal key wire, just to join and make the tibial hinge at the posterior part. So you have to go slowly. You can use fluoroscopy, of course. With the saw, you knock on the door, as we say. You knock on the cortical just to go not too far. It takes a little bit of time, but this is the way to do. When you have done the 2 cuts, you will be able to remove the 2 wedges. It's like a biplanar osteotomy, because you have to remove the posterior part of your tibial insertion. You see that you are able to move it We never do any TT osteotomy. It's not necessary, and it increases the heaviness of the surgery. So I do not recommend to do that. You remove the two wedges, clean the posterior part of your osteotomy, and then you will be able, by putting the knee in hyperextension, to close the osteotomy. So it's of course very, very, very stable, because it will be a compressive osteotomy. So you will be allowed to say no weight bearing for 3 weeks after surgery, using an extension brace, of course. And between 3 weeks and 6 weeks, we will go to partial to full weight bearing. And at 6 weeks, you are back to a normal ACL protocol. This is the way to do. Some questions are, what about the hyperextension that you will put? Of course, we do put some hyperextension, but that's the reason why we use a brace, an extension brace, for 6 weeks, 24 hours by 24 hours, except for the physio time, just to make the knee a little bit more stiff. And it works so well, and in the long-term follow-up, we have no pathological hyperextension. You use 2 staples, very simple fixation. While you have done that, you re-drill your tibial tunnel by hand, then you pass your graft and you fix your graft as you are doing usually. It's done. So what to say, we have actually 2 studies, and we will have a 3rd study published about that. The first one was, it is the second follow-up of a very small series, but now it's 7 to 15 years, so it's really important. We see that we have increased the scores, and we feel that the patients are more and more confident with their knee. We have no re-rupture, we have no new surgery, no meniscus injuries. And in terms of arthritis, it increased a little bit, but it's a very low rate, but it's a very, very small series. But my feeling is, when you are doing that, you stop the natural history of your ACL, and it is really super efficient. This is an example of a very old patient since 2007 up to 2021, and definitely it is super efficient. But now you know exactly what you will do in April. You will be in Paris with a ESCA meeting, and probably you will hear about more ACL stuff. Bye-bye.
Thank you, David. Merci. Helder, ¿en español? ¿En
Sí.
portuñol o en...?
En portuñol.
En portuñol, perfecto, gracias.
Portuñol convicto. Buenos días a todos, es un placer estar aquí hoy.
Good morning, everyone. It is a pleasure to be here to share with you this session, this ESCA session. We're going to try to share some topics related to the cartilage and the lesions that we may experience. We can go ahead. The first concept is that the lesions are not taking place only in relation. We're going to try to the cartilage lesions do not occur only with the ACL rupture. The literal, it indicates that 30 or 40% of them have control lesions, and it is not always easy to know when is it that we have a cartilage lesion, if this is a recent lesion or not. But we do know that that very frequently we find them combined, from the 20 to 40% of the combined lesions between a LCA and cartilage. In the cartilage injury can take place at the same time as the initial trauma, but this is not the most common mechanism. This cartilage lesion is due to the instability associated with the cartilage, and in this case, this has to do with the cartilage. So in relation to 90% of these lesions, we can see that the time elapsed from the initial lesion all the way to the treatment of the cartilage has an influence in the severity and the incidence of these lesions. When we treat and as indicated by Paulo, when we take more than a year to treat these type of lesions, there will be a risk that will range from 3 times higher to have associated lesions. And when we take more than 5 years, that risk can be 5 times higher to have this type of lesions. And we do know that, especially in pediatric patients, this is a very important topic due to the consequences it has, and this is why the initiative of PAMI and the ESCAS Association to know when and how to treat these type of lesions in pediatric patients is extremely important due to the consequence of these type of meniscus lesions. The suggestion is that the time of these type of original lesion, the body mass index and the patient age, these are risk factors for cartilage combined with the other lesions. So the risk factors having the worst clinical result when we're facing this type of lesion is the presence of chondral lesions. Others said that there's not such a huge difference. There's no consensus in this regard, and we're going to look at the reason or the reason to the lack of consensus. So this is a recent paper published, which indicates that the cartilage lesions found in these type of lesions is close to 80%, and it's been seen that there was not a huge difference in the outcome between the lesions of any type of lesion at level 2, 3, or 4. In grade 2, 3, or 4, the behavior has not been so different. So what we have verified is that the evaluation is the final evaluation was significant in those patients that had chondral lesions combined with the cartilage, but they had less risk of future lesions. Why can this take place? Because we're talking about this is a treatment that took a long time, and the function of that lower limb, what we lost as part of the function of the knee, may have an implication on the reduction of the patient activity, which may justify the dimension or the extent of the new lesion due to the low activity. And this is not something positive to say. In that study, in that long study or that long paper, it indicated that most of them had to do with the anterior compartment. So this is why we studied the outcomes to see the influence, but there are many comparative results in literature. In terms of treatment, there is a trend, and this is part of our experience in a context of of this type of lesion combined to the meniscus lesion, and 30% of them have received the treatment for a chondral lesion, and there has been no significant influence on the outcome of the persons with this type of issue. Once again, all of them have been treated due to microfractures and combined with the meniscus lesion. And we have noticed that the biological environment and the relation with the of the meniscus with the cartilage above and below, as indicated by Jacques, is a little bit more complex compared to the initial idea that we had for many years. But you can expect that good results, and the national trend is to try to combine in terms of in the primary reconstruction surgery and the chondral lesion that we have found among the pediatric population. This has to do with the osteochondritis dissecans. We have a cartilage that has been preserved. So the preservation of biology of that need can give us the opportunity to strengthen the subchondral bone and fixation with the compression of that fragment to try to preserve as much as possible the biology of those kids. That especially for kids, this is something that we need to think about. The most frequent method, which is due to the low cost, and this is something that has contributed. This has to do with the techniques of the bone, and we all know it can take us a whole day to discuss that the cartilage that we will have at the end of the day is not going to be similar as the original one, but at the very least in the midterm we may get a response that can be verified. There are results that have not been proven, and I know that there are options that can be implemented. There are biological membranes as something interesting to make sure that type of treatment is developed all the way to the cartilage. And I want to say that unfortunately that's not the case in practice. You can find results in the literature, but if you look at them in detail, very thoroughly, there will be some doubts raised because in the reconstruction with cartilage is not reliable under any method. But this is true, and this is based on my experience. I can use it for a physical containment for the placement of a graft underneath them or under the membrane, which will bring proteins in the hydrogel, but this is experimental. What is true is that those that are quite compatible are with collagen, which are collagen based, are not having any type of risk, but this is not the holy grail that will solve everything, and we need to look at it, and we need to keep studying it, because the worst thing that we can do for a good option is to have this a poor reputation. So we're talking about the osteochondral lesions and the reconstructions. The outcomes can be very good, but it is not. But they cannot be better if you compare with the microfractures in many series. And in my experience, and which has been supported by the literature, is that if we can approach the lesion, we may have a better percentage of outcomes, but this has been objective, because I do believe that there are no zones of no contact. And I think that this is a reality, and this is existing, and this is something that we need to bear in mind. Once again, we have the cellular scaffolds for many years, this could be the right solution because we didn't have any problems at that time, but that could be the final solution. So that's not the case. Time has indicated this was not sustainable and it was not easily integrated as was assumed. So this is being investigated because when we talk about the cartilage reconstruction, we need to consider that we have the basis, which is the combination. This is the combination of cells in a scaffold and proteins or that will represent the functional system. Only if we combine this, we can do something, which is the normal diagram that we have done. This is a sample. We can implement this in a scaffold, and then we can have a graph that could be available for the implementation. So if we can include here different types of medicine that are max complex, but they're all following the same lines. Now, the growth factors are those proteins that are capable of activating a cell but these can work in different ways and different times, and they can operate differently in the same cell in different receptors, but we need to understand the biology of the system if we want to be efficient. The same apply to the cells. This will be the future, and it will take us a whole Congress to talk about this, but apparently in basic science studies, the stem cells may be more active and we can find more cartilage. And this whole thing should be acknowledged, and this whole thing has to be the continuation of this type of techniques so that the reputation does not end up being negative. These are papers that have been published where we can find where we can find the different challenges and the osteochondral tissues with that, because we have learned that this is a huge process locally. And but we have a lot of options on the way. So the use of hydrogels is something that is growing significantly because they can be used as transporters of cells and proteins, and they can be combined. And if we talk about the nanotechnology, we can actually activate those proteins at different times, and we can improve the behavior of the osteogenic and the chondrogenic if we're talking about the cartilage or any other tissues. There is pressure by the industry. This is something that there will be a lot of scaffold options for using cartilage. Be careful. If you decide to use something, you need to have the plan and you need to follow and study the outcomes, because today nothing is reliable in order to advise this type of use. We are developing more intelligent scaffolds, because with nanoparticles and by using materials that we find in nature to be more biocompatible, we can have a next generation of scaffolds that can obtain a tissue that can be more similar to the native one, but we are testing with animal models because we have not reached the point to advise the use of it. The combination of hydrogels and a chondrogenic and osteogenic zone, and this is another study of the morphology of the adhesion of every patient, because by using a 3 bioplotter printer, you can print by combining scaffolds and cells with everything that we have been discussing to do an implant to do a graft that could be adapted to that specific patient. So I think that could be the future. Take home messages. We're talking about an entity that is quite frequent, the combination of chondral and osteochondral lesions. which are the risk factors? We are clear that the time from the original injury, the age, and the BMI are factors to be taken into account. There is a trend to be treated surgically at the same time in terms, but there's no consensus in 2022 on how to treat a cartilage lesion, and this is something that we need to be clear. It is not that we are stopping there, but we need to have a rationale. We need to know what we're doing, and we need to know what to expect and what to tell the patient, so that we can act as the Pinocchio show by Pablo. There are promising things, but let's not turn something into this concept into something negative. And it will be a party. ESCA is going to have its 20th anniversary, and you're all invited to the science party, and I hope to see you there in Paris in the following month. Thank you so much.
Please, Pablo, can you come to the stage? ¿Alguna pregunta? Nos quedan todavía 7 minutos, creo. ¿La sala? ¿Ha quedado todo claro?
Are we all clear?
¿Podemos atender en español, portugués, inglés? ¿Ningún problema? ¿No hay preguntas? Por favor.
Okay, go ahead. Do we have a microphone?
Buenos días.
Muy buenos días.
Hello, good morning. Very good morning to you. First of all, thank you. The talks were very entertaining, very good information. Many people touched upon potential complications when you use grafts. If we compare the before and after, I'd like to ask a question for all the panelists, whether they have any considerations for preoperative or kind of physio, if any of you use this when you have sports people. Do you mean for prevention? No, somebody who's been diagnosed with ACL injury, do you manage that with physiotherapy?
Surgical treatment of these patients to avoid further complications afterwards. So, any condition? Tú mismo, Pablo, empieza.
Sí que hay algunos estudios que hablan de que hay
Yes, there are
superioridad.
some studies that say that preoperatory treatment is advised or better, but for the general population, I think that beyond repairing or improving mobility, I think that rehab for the ACL is tiring enough instead of having to insist on pre-treatment. So these, I'm talking about normal people rather than sports people, so I think they should relax and prepare for the post-operatory stage, because what we've tried to recover can disappear in 12 hours, so I try not to focus too much on that aspect.
Okay. For us, there is 2 windows of surgical treatment. The first 24 hours, or then after that the patient has fulfilled 3 criteria. The most important one is the recovery of full active extension. The second one is to be rid of the effusion, and the third one is about 110-20 we can discuss on flexion. And in the same time, we do rehabilitate the quad, because it's extremely important to keep the connection in between the brain and the muscle.
Dos visiones distintas, ya ves, no hay consenso total.
Two different visions, there is no consensus. I agree with the words of Pablo and Jacques in combination. I just wanted to remind you about another topic, whether there is an unstable meniscus lesion or not, because that could change everything with regards to the target to reduce pain or to have extension. We want the proprioceptive circuit to work and to give a positive impression to the patient about what's coming after that, after a period of time. But if you do have an unstable meniscus lesion, then you need to consider that, because there may be episodes in that period of time And that can guide the pressure, so you can operate as soon as possible.
We just wait a couple. Usually it takes a couple of weeks, and then we can do everything in once, except obviously if we have a locked knee due to the bucket handle, then we have to go. And usually we go in the first 10 days, and then we decide, because I think there is still a place for 2 stages surgery, either to do both in the same time or do the meniscus first, and a couple of weeks later, the ACL.
So David,
I would say that we love to do surgery on a knee which goes well. So we start to do physio, of course, and the 3 criteria that Jacques spoke about are good. I do some emergency surgeries when I have a medial laxity, when I have a meniscus tear with a bucket handle, of course, and if we have some a root tear. And I feel that it's much better to do some fast surgery when you have that to get the best healing.
Buen día.
Bosco, nuestro presidente.
Gracias. Nice to see you, to everybody. Thank you so
Our
much.
president here. Thank you very much for coming. The question of the doctor wasn't so much in that sense, but would you consider that in sports people, so high performing athletes or recreational athletes, do you suggest using non-surgical treatment? Is that what we were saying? I think we were not referring to this question, but that is an interesting question. Anybody, would someone consider that?
Well, we do consider non-surgical treatment, but it depends upon the patient. I would say nowadays we have really an individualized and I would say a la carte approach with respect to ACL reconstruction. Just to tell you maybe a brief statistics on our internal registry, once again, we had alpine skiers population. We do probably operate close to 95% of people in between 15 and 25 years old. Then we do operate on about 60% of the people from 30 to 45. And then there is a big difference in female and male in our population. Male starts to get overweight, less active, and they do tear the ACL much less frequently than the women. The women are usually going back to ski at 40 years old with their children. And they again torn the ACL. And then we do operate, we'll say 50% of these females, according to the different criteria that now are well described in the literature.
Germán.
Gracias. Dentro de esa larga
Thank you. Within that long list, that long checklist for return post-reconstruction, for that long checklist post-reconstruction that becomes tiring and difficult to apply, to make a decision about whether they return, especially with a professional athlete or footballer, I would like to know whether on the panel you're using T2 mapping, so magnetic nuclear MRIs as another tool for decision making when you're authorizing a return to competition.
Role of MRI in deciding when to return to play, particularly T2 mapping.
No.
I never use that. The criteria. I do use laximetry around the 9 months. So we do telos. So it's a way to quantify the laxity because we need to have some objective data. We do functional testing and isokinetic tests at that time. And this is a way to validate the return to play, the final return to play.
Yo particularmente que hago resonancias normales entre los 10 y 12 meses.
I do normal MRIs between 10 to 12 months, and in none of the cases that I remember that has made me change a decision in terms of returning to sports, specifically because within the degree of maturity, there are no studies that say that if there's a specific image, then that's related to the probability of tearing. The T2 mapping has become very valuable for people that work in MRIs because the intensity of the signal descends over time and the maturity of scarring or biological incorporation reduces over time. and this simulates the native or the posterior cruciate. This is why I asked the question, because when you have high-level returns, you consider an option, so an alternative analysis. Yes, but they're very controversial results. We just published that, for example, if we do T2 mapping and we compare the reconstruction of LCA compared to tendonesis, they induce more maturity, but we do not, that doesn't mean that they return later to sports. I know that this information is irrelevant, but we don't know up to what point that would have an influence on return or have an impact on return. So if somebody wants to ask a question here, yes, forgive me, I'm also a knee surgeon.
Someone of you believe in all inside techniques or in some kind of internal brace to protect the graft?
Interesting question.
Yo soy siempre a favor de la biología, por eso internal brace.
I am always in favor of the biology. So never. All forms of anatomical reconstruction with the right amount of tension that would work in your hands are valid, and the all inside is one more.
Well, for me, all inside, as long as the tunnel are properly placed, that's okay. For internal brace, when we were very interested in ligamentization process, I mean, the stress shielding that the internal brace may induce on your graft, I'm not sure this is really as favorable as we think. And yes, you can protect it maybe for a while, but your graft we know that in human being, the graft will never get through the necrosis process that has been described in animals model. So I'll be cautious to use it, because then if you need to revise an internal brace, this is you lose almost 30 minutes to clean up the knee.
Facundo.
Pablo. Quería acabar, dar una opinión respecto a internal brace.
Yes, I just wanted to give an opinion about the internal brace. I coincide with my colleagues. I think that the all inside, in terms of open methods, there are no advantages with regards to the advantages to recommend techniques nowadays. I won't explain in detail because there are a lot of details, but there are some technical, some standard techniques at the level of the tibia that would regenerate the tunnel completely, and there are no differences in terms of the all inside, but it does offer more predictability. The tunnel and the femur in the all inside is a little bit more precise, and also the angle between the tunnel and the other part it does create greater risks. And I think that in normal patients, the inside would not have any advantages. Yes, I wanted to ask Dr. Metra if you have a routine in your reconstruction of the ACL to look for a ramp lesion, and whether you have any ideas about the impact of these lesions on the ligament reconstruction.
I'm really looking systematically to it. Some of them has healed in the meantime. Obviously, we do not repair if the lesion has healed. But if your meniscus is still unstable, usually we use 1 or 2 inferior sutures all inside to definitely fix the meniscus. The difficulty is when the ramp is really large and you have sort of a loss of tissue on the synovial side. Then I think this is reasonable to do it through a posteromedial approach and use the classical, I would say, so-called classical hook technique in order to fix it. But yes, I do look at them systematically. And in terms of incidence, the group of Santi in Lyon with Bertrand Sodricote has shown that it can go up to 20%, especially if you treat a soccer player where the lesion seems to be very, very frequent.
David, do you want to pass any comment?
Not really. Of course, it's very important to look at them, to palpate them, because you can lift your medial meniscus and you see exactly how is the healing, because quite a lot of them are healed. I go very, very very rarely on the posterior medial part of the knee to repair with a hook. For me, going from all inside from the front, most of the time is okay.
No estamos reparando realmente la rampa, sino que fijamos el menisco. Somebody, but you are fixing the meniscus to the posterior capsula.
Yes.
Do you think that's true?
Probably, but the goal is to make your tissue healing and stable.
I think you have to do it because if you look now at the nice dissection, for example, Etienne Cavagnac has made in between the interaction you have with the semimembranosus tendon that is dynamizing probably your posterior horn of your meniscus. If you have a tear in between those two structures, I think this is wise to place a sutures or two in between the medial meniscus and the semitendons. That means, yes, you go put your PET on the other side of the capsule. That's correct.
Doctor Ochoa, de nuevo.
Qué pena ser tan cansón. Yo quisiera conocer qué está
Sorry to
pasando.
be so annoying, but I want to know what's happening in Europe with the new generations of synthetic grafts. We've started to look at a lot of literature from Asia and Europe that promotes and that goes back to this idea that we had 35 or 40 years ago, the LARS, for example, these synthetic grafts. Is there any space for them? Are there any options where they can be used? Are they an alternative?
As augmentation or as a ligament itself?
I would say that in ACL, probably there's no place for a synthetic graft. The LARS is the only one who remain, and it works not too bad, especially for PCL. For PCL, for acute PCL, sometimes for knee dislocation, it will be very, very good option. For ACL, probably not. And you see, it is exactly the fashion, and the fashion is back and back and back. And we see the ACL repair. We were talking about the internal brace. It is exactly what we were doing, not me, but the generation before was doing in the 80s, jumping on the ACL, suturing them, and we all know that it doesn't work. But we have new devices. Industry is coming with new devices, so new markets, and you should be very aware about that. And look at the history, and maybe when you look back to the history, you see that the synthetic ligament or the ACL repair is not a real good option.
Cirugía experimental en cobayos, ¿no? No en pacientes, básicamente.
For us, it's very
Yes,
simple.
there was experimental surgery in guinea pigs.
I know that in China they are still using a high amount of synthetic, but the results are the one we have probably measured years ago.
Lamentablemente me informan que está empezando la siguiente sesión, debe conectarse por streaming y nos piden que acabemos. Gracias por
We've
vuestra
been
atención.
informed that the next session is starting. We must connect via streaming, so thank you very much for listening. And we shall see you in Paris. If you'd like to stay in this room, you can listen via streaming because the room next door is absolutely full. Thank you.
Were at the same or higher level of the Tegner score. There were three factors that affected return to play rate. First of all, younger players got back at a much higher rate than older players, the cutoff being 25 years. We don't know why that is. Maybe because the older players, some of them wanted to retire and they've had good careers, and the young ones are desperate to play. Also, we found that the return to play rate was reduced if there was another operation before return to play, such as a meniscectomy or a chondroplasty. If they underwent meniscal surgery at the time of the ACL, that also decreased the return to play rate quite significantly. Interestingly, there was no effect on the choice of graft, the femoral tunnel position, nor the addition of a tenodesis. So what about return to play time? Everyone talks about 6 months. Well, ladies and gentlemen, that just doesn't happen in the majority of our cases. The truth is the 10.5-month return to play on average is artificially high because we defined return to play as a competitive match, not return to training. And so some of our players were ready at the end of one season, but decided to wait 2 months to start at the beginning of the following season. So perhaps a little bit higher than it should be. We found 3 factors affected return to play time. Again, age was important, but this time it was the young ones who took longer. Maybe they're unfamiliar with rehabilitation, maybe they just took longer to adapt to it, whereas the older ones got back significantly quicker. Recurrent effusions are bad news. They cost a month and a half in terms of return to play, and I find it's the hardest part of my job. If a medial meniscal repair rather than meniscectomy was done at the time of the ACL, that also increased the time of return to play. And again, graft choice, the addition of an LET or the femoral tunnel position didn't make any difference. Now, this is a really striking picture. The overall graft re-rupture rate was 8.2%. And I was really quite disappointed with that. But we then analyzed the re-rupture rate according to the graft type and the femoral tunnel position. And I had a very bad experience with moving my graft to a central femoral tunnel position. You can see the re-rupture rates here. This is hamstring in a central femoral tunnel position, the so-called anatomic position, 18.5% re-rupture. I can't live with that. If you put patellar tendon there, it was 11%. But if you use an AM bundle position in the femur, the re-rupture rate for hamstring is 10%, and it's 7.5% for patellar tendon. But if you then add an additional tenodesis, I now have my re-rupture rate down to 2% for patellar tendon plus a tenodesis, and the tendon's placed in the AM bundle. We can't really comment on hamstrings in the AM bundle position because we only had 4 cases and 1 re-ruptured. So I think that's not something we can take very seriously. So in conclusion, I would say that the game changer here is that never-ending study of our work improves results because we start to learn about it. We can get a high return to play in professional athletes. Joe Public, it's 50-50, but these people want to get back and they do. And we delay our return to play with synovitis, additional surgery, or young age. And you can see with the right choice of graft, putting it in the right place and adding a tenodesis, the re-rupture rate is low. Thank you very much indeed for your attention.
Yes. Thank you very much for your conference, Dr. Williams. Now we have João Espregueira Mendes. He's connected by Zoom, I think, with his conference about risk factor for ACL injuries. Thank you, Dr. Espregueira.
Buenos días a todos. Muchas gracias.
Good morning, everybody. Thank you very much to Slard and to all of our friends in Colombia for this kind invitation. Thank you to you all. It's a pleasure to participate. I am lamentably not there physically with you, but I have the great honor of talking about risk factors for the future LCA. This is my place of work in the north of Portugal, in Porto, at a clinic, a sports medicine clinic. You are all very welcome if you would like to visit us. There are issues or questions that still do not have an answer for the future of the ACL. We still do not know why we have isolated tears of the ACL, which in some patients do not cause instability, because when a surgery is correctly done, some patients have or why some have pain and instability, or why we are unable to fully correct biomechanics and provide a normal function for these patients. Is there perhaps a set of patients where we can have conservative treatment without a risk of arthrosis and without a risk of instability? For this, we need to look for more information about the anatomy. So we need to really understand the risk factors for the LCA. These are factors in biomechanics, neuromuscular factors, environmental factors, anatomical factors, and genetic factors. We all know that there are certain factors that can have an influence on lesions in the ACL. Here we have provided a few references that can either increase or reduce the risk of lesions or injuries in the ACL. In these, in this paper that we published in June, that we also mention that the valgus, the external rotation on landing, is crucial when it comes to risks for the ACL. If there's a delay in the activation of the knee flexors and extensors, then there will be an increased risk. When there is a landing, we need to look at the patient to see if they cannot land in this position. If they can, then we need to correct this position, otherwise there will be an increased risk. There are also studies that have become clearer over time, showing that genetics can also have an influence here. So there is a risk in certain types of genes, and there are risks at the hormonal level. So the ovulation phase or post-ovulation phase, this affects the risks of the ACL. Women are at higher risk, either due to hormones or biomechanical reasons in the valgus. This is clearly a risk factor for the ACL, and we are particularly impressed by the risk related to the morphology of the bone, and therefore we study this in some detail. First of all, the varus and the valgus. We know that the valgus is a risk factor, and also clearly in the systematic review that we published in ISACOS, we can see that the shape and the size of the tibial slope will play an important role in risk. So if we have a tibial slope in an A shape, there is greater risk. If it is narrow, there is more risk as well. And if we have more than 12 degrees in the tibial slope, then that is a higher risk as well. This also has an impact on the gender differences when it comes to their bone morphology, which differs. Here we can clearly see the importance of the notch and the length of the notch, which plays an important role in risk. And it's also important to look at the index because we need to relate that to the size of the individual. So the index does play an important role. The tibial slope, so most of our work shows that there is a variation, and if it's longer than 12 degrees or bigger than 12 degrees, all the work published shows that this is a risk factor. And also, as we have seen before, shown by Freddie Fu's group, if a notch is shaped like an A, there is greater tearing risk, and also the length of the condyles, the condyle width, can also predispose them to risks in ACL tears. The morphology of the tibia with regards to the tibial plateau, That's also a risk factor. We were very interested in studying the morphology of the external femoral condyle because here we can see the most abnormal movement of the knee, the instability on the external face of the knee. So the flat part of the femoral condyle, so the yellow part here, the bigger the yellow line is, the more stable the knee is. Then we also studied the relationship between this flat yellow part with the distance from B. So the anteroposterior part of the tibial plateau. So the shorter that is, from the posterior point of view, the shorter it is, the greater the risk of instability is. In the new article that we published in ESTER, we compared the 200 previous ones to understand the ratio, to see the condylofemoral ratio. If the ratio is higher than 0.8, then we have greater risks for the ACL. So it's important to define a measure that is useful to understand the risks. And the flatter the surfaces, the more stable the knee is. And that's why Elizabeth Ferenc says that perhaps this study is or demonstrates that the femoral lateral condyle is the trochlea of the ACL. We knew this from the past as well, because when there is a lesion in the knee or in the bone due to compression, as we can see on the left-hand side, the anteroposterior size becomes shorter. Therefore, the take-home message would be that we need to measure instability and identify risk factors so that the therapeutic decision can be the right one. When we increase the risk factors, maybe we could add lateral tenodesis, and this would clearly diminish or reduce the risk of failures in the ACL and also stability. So thank you very much. It was a pleasure to be here. A warm embrace for you all. Thank you very much, Dr. Mendes. Now we will listen to Dr. Manuel Mosquera with his conference about ACL repair, with what is suitable and what is the evidence. Thank you.
Buenos días. Muchas gracias por la participación.
Good morning. Thank you for allowing me to participate. Thank you to Guillermo, the president of ISACOS, for inviting me. This is the subject I'm going to look at today. I have no conflicts of interest for presenting this work. This talk is not based on the kind of tears that you can see in the image, but despite that, Dr. Murray in 2020 published her Burr technique and showed very similar results when we compare suturing and reconstruction. But my talk is based on these kinds of lesions. Type 1, Sherman 1, proximal tensioning. So I'm going to talk about whether it heals, whether it's valid to repair an acute injury, whether it's valid to repair a chronic injury, my own experience, and a few take-home messages. So scarring for the ACL, the studies that were performed initially compared the ACL with scarring from the collateral medial. So obviously in the collateral medial, a coagulation is formed, a clot, and that's where you have this whole waterfall of scarring. But there is a liberation of plasmin, and so scarring is not good when we're talking about the medial, the third middle. But this study has showed that the cells that can be found in torn ACLs and the fibrosis that I've showed you here are similar to the cells in the lateral medial ligament. So does it scar? Yes, it does. There is great evidence to show that the ACL can heal. What has been published in literature with regards to repairing type 1 lesions? This is the initial work of Dr. Di Felice, 11 cases published in 2015, all fixed with knotless, showing 10 of the 11 cases. If we compare IKDC A and B. So he added 25 more cases for a total of 56 cases, showing a failure rate of only 7.8%, 3 years later, obviously. In this work, we had, in this piece of literature, we had 12 patients with the same knotless technique. Only one patient had a re-traumatic rupture. One failure was reported only. So this is an option. It is based on literature. And in Sherman 1, the results are more or less 85% in terms of that which has been reported in literature. This is a systematic review, 8 clinical studies. In the beginning, they included the third middle, so the results were bad, but in the next decade, the results are similar, comparing 1 to reconstruction. This is another systematic review that says exactly the same. It is controversial to understand whether you need the internal brace or not. So, I mean, there has been work done on specimens, 5 with the internal brace, 5 without, where there are no differences in draw test gap. This other work is done on 20 pigs, where they find that when you use an internal brace, you have less of a gap and greater resistance to failure. This is clinical work where they suggest that there will be better results, include the internal brace. What has been written with regards to chronic lesions? The literature is quite poor. This is a case report, 2 cases with 2 years of follow-up in which the patient had good results. This is an article with 11 chronic cases with good results 2 years later. And this is my own experience that I'm going to show at 11 a.m. with 88 patients. I was able to follow up on 48 of those, of which on average 85% had good results. And out of those 48 patients, 35 had arthrometry, and in 34 the difference was lower than 2 millimeters 3 years later. So the question here is, if we have this lesion, is it worth leaving it there and suturing, or is it worth removing it and adding a cruciate ligament? My opinion is that you shouldn't, because even if we use the best graft, the most powerful and strong one, we will never be able to replicate the microstructure and the anatomy of the ACL. This means that I'm referring to collagen, the blood vessels, and the fibers, proprioceptive fibers. So I always talk about this. I'm talking about my own experience. I've had 2 failures, one in a young patient who thought she was okay 5 months later, so she started playing football again and it ripped, tore, and another patient who had an infection with arthrofibrosis and after surgery had a bad result, but not due to instability. There have been 2 infections as well. The interesting thing here is that they were diagnosed 10 days later. So what usually happens to the graft when it's not diagnosed early? It simply fails or is lost. So the interesting thing here is that in these 2 cases, the ligaments did not have issues. One of them ended up in arthrofibrosis. The other one improved after washes. So it's interesting to analyze this. Someone had hemarthrosis. They had to have a second surgery, and 2 patients had anterior knee pain, but they had good ligament scarring. Nevertheless, they had pain. This is a technique. So fundamentally, you have to really have a good look at it, understand the fibrous parts, understand where the lesion is. In the beginning, I used to have micro fractures. Now I use burr and footprint. And in 99.9% of the cases, I have used the knotless method. I use tension on both bands, as you can see, posterolateral and anteromedial, both of them. So I tense those. And in this particular case, I used fiber tape to create the concept of the internal brace. And you can see in the image, there are no reports from the people who have more experience than I of internal braces causing issues. I haven't had to review or revise any patients with internal braces due to inflammatory reactions. Why not to do this? So in this particular case, this is a lesion where we have the posterior cruciate and you don't suspect it, but this is what you find and you think that the insufficiency or the weakness is in the ACL. In this case, you have to reconstruct the PCL. The limitations when you're using an internal brace, I limit it first during the first month, but when I use the internal brace, I have aggressive rehabilitation without restrictions in support. Thank you very much. Or in weight bearing.
Muchas gracias, Mosco. Para continuación, invito a.
Thank you, Mosco. I would like to invite Dr. Bertagoy from Mindan with his presentation on enhancement.
All the ISACOS leading team is here. Thank you, Mosco, for fantastic hospitality. My topic is the biological enhancements of ACLR. How can I advance? And well, I think that the key of my talk is all in the R, because ICLR can be ACL reconstruction, but can also be ACL repair, as Mosco demonstrated. So I don't want to repeat what Mosco just explained, but it's very important to understand the pathophysiology of the rupture ACL, the cellular factors, the migration of leukocyte, the erythrocyte invasion. And so we should understand why ACL can heal or cannot heal. What happened after we have an injury to the cells? What happened to the blood supply after ACL rupture? I think this is the key to understand if we can help healing, because we should for sure interact in the first period when they have the inflammatory cell infiltration. What is the role of bioorthopedics in 2022? This is a book that we prepare with ISACOS, because today biotechnology is proceeding at a rapid pace, exploring new horizons. If we talk about biological enhancement of ACL reconstruction, we can consider that it's a different issue to enhance healing of a reconstruction. We can work on the modulation of the inflammation because there is an important role of macrophages. However, we can try to help with growth factors, PRP, cell-based therapy, mesenchymal stem cell or gene therapy. Briefly, I will try to go through this, going through the literature. If we use PRP, there are several articles showing that probably we cannot improve objectively the outcomes of anterior cruciate ligament reconstruction. So we cannot improve the ligamentation, we cannot improve or lessen the knee stability. If we use bone marrow cells, there is a role. Well, there are some studies, but they are controversial. We have very short follow-up. We cannot say today that we can improve it. However, there are some studies showing that if we use allograft, we can probably improve the results and diminish the rupture of the allograft. We can also use adipose-derived mesenchymal stem cells, but again, there are few controlled clinical trials, and this improvement was not statistically significant in many studies. So at the moment today, we cannot say that with these cells, we can enhance ACL reconstruction. We can also have a cellular augmentation of ACL surgery with different cells. There are some studies. But again, we don't have any support of clinical evidence at this time. We need more research. What about stem cells? Stem cells, again, we found some articles, but with very short follow-up, we can have cultivated stem cells and as well as gene therapy. The principle is that probably we could enhance, but today we cannot say that with gene therapy, we can enhance ACL reconstruction. My vision started working with Dick Stedman in the early 90s, because I think that, as Mosco said, we must help the primary repair. That is not a new thing. However, with the new biology treatment, we can improve what Stedman demonstrated with the healing response many years ago. So I started using the healing stimulation more than 25 years ago. And step by step, I learned how I can improve this healing. There are, first of all, strict indication, because young children with open physis are probably the gold standard for this treatment. However, patients less than 40 years of age with incomplete tears are a good indication, but the surgery should be done very early. The best is to do it in the first few days after injury. I started using no transosseous fixation. Now it's different. We have a new system, as Mosco demonstrated. But at that time, we were simply suturing the bundles and helping the healing with injection of bone marrow and growth factors. Intraoperative examination is very important, because if we have a 3+ laxity, probably it is not an incomplete lesion. So we inform the patient, and usually 25% of the ACL acute injury can be treated with this technique, not all the complete lesion at the moment. We prepare bone marrow using a simple system, spinning and aspirating from the ipsilateral iliac crest, and then we centrifuge, and we have the possibility to have a concentrated bone marrow aspirate, and we mix with growth factors with a PRP in order to have a clot. Then we can suture the acute injury and inject the bone marrow. I want to show you some example. This is a ligament injured, and here you can see part of the ACL is still reattached, and we suture it, and we do bone marrow perforation on the notch, and we remove the fluid, and this is our growth factors. You can see that it clots on the ligament itself. The functional phases of rehabilitation are very important. As Mosco said, is different from ACL reconstruction. The first phase is slower. We have a progression between the phase. We use a bracing extension and partial weight bearing for the first 3 weeks. But I want to show, this is interesting. We have several second look during the years. This is 4 weeks post-op, and you can see the suture is still in place, but we have a good attachment of the ligament, and the ligament is really healing. This is 2 months post-operative. We start with the neovascularization. The ligament is attached. We can see the blood, the suture is still in place, and we have neovascularization of the ligament. This is 5 months post-operative. The ligament is moving towards a more normal ligament. We can see the posterolateral bundle, the anterior medial bundle, good tension of the ligament. We are doing some tests in Lachman test, so we have good tension of the ligament. This is 12 months post-operatively, and the ligament appear as a normal ACL. And this is the posterolateral bundle. This is a Lachman test, testing the stability of the ligament. This is a post-operative MRI, 2 years post-op. We published our study with 14 years of follow-up So long-term follow-up in a group of athletes treated with this technique on American Journal of Sports Medicine in 2018. And we think that the repair of ACL acute lesion can offer several advantages. First, we don't have our graft harvest complication. We can preserve the proprioception. We don't have deterioration of the knee. It's a simple surgical procedure, and we don't have any implant-related morbidity. But again, we cannot do in all the ACL lesion. What is the next step? The next step for us is not next, but is present, because we are working on some bioactive and biocompatible scaffold that we can implant into the ACL acutely. And this is a sort of hyaluronic acid scaffold that we fill with bone marrow and growth factors. It is a few millimeters of width, and we implant into the ACL, and this will be absorbable. So I don't like so much the idea of the internal brace, because it's something that will last forever, but this will be absorbed. So in a few months, they will disappear. So in conclusion, today, we don't have any evidence that we can improve the healing of a tendon that we transplant in a reconstruction. There are limited evidence that we can have superior results if we use biologic enhancement. However, if we use biological enhancement, we can really improve the primary acute ACL repair. If you want to know more, again, go to this book from Isaac's library, Joint Function Preservation, and you will find more. Isaac's has been very, very active. We have 12 new books available. And my last message is that scientists should say, let's stop the war in the world. Thank you very much.
Muchas gracias, Dr. Gobi. Ahora invito al Dr. Juan Pablo Previgliano.
Thank you very much, Dr. Gobi. I'd like to invite Dr. Juan Pablo from Argentina, who's going to talk about supplementary procedures to reduce frequent instability. Thank you very much.
Okay. Buenos días a todos. Quería agradecer a Isacos y a Slard.
Good morning, everybody. Thank you to Slard and Isacos for this invitation. This is our place of work in Buenos Aires. I have no conflicts of interest in this talk. If we're going to talk about the things we can improve in the ACL in our results, we need to talk first about the failure records. And failures at present, if we were to look at different records around the world, are between 3 and 5%, although there are some pieces of work that publish up to 10% in terms of failure rates. Now, when we think about the situation and what we can improve, we also find a situation in which we need to understand why a revision needs to be done. So, with these failures, we look at the etiology and what we need to revise in what we've done. But in reality, my concept, especially when it comes to young arthroscopy surgeons, is that we need to rethink the initial situation during the initial situation. Because if we don't look at the slope and whether it was okay when we are first reconstructing the ACL, that's where failure rates come in. So I think we need to really reconsider protocols where everything that we propose to do before a revision is done in the first stage, in the first situation that needs resolving. So going specifically to what I'm going to talk about here, we know that residual instability in modern arthroscopic procedures alongside failure rates have led to a revision of lateral structures, and there is multiple work being done since the first studies came out, and the latest studies from the French group and more modern studies that have studied once again lateral structures, and they have come to a number of conclusions, and they've seen that these techniques really improve our results. As an example, we have the work that is for which results are being assessed. So not just studying lateral structures and their functions, but also the results themselves. So here we can see work looking at the reconstruction of the anterolateral area, and there's a 10% improvement in 2 randomized groups, so both improvements in clinical scores as well as in the failure rate, almost with a difference of around 10% between the group that had the reconstructions performed and the group that did not have reconstructions performed. Now, this other article talking about what I'm going to refer here, so lateral extraarticular tenodesis particularly, this shows 2 randomized groups where there is a re-tear rate of 11 versus 4% in those who we add the reconstruction of or the extraarticular tenodesis to. This goes hand in hand with this morning's presentations by Dr. Andy Williams that showed us results in football players with a lower re-rupture rate where there was an extra-articular tenodesis performed. Now, adding to these articles that already talk about the benefits and the protection provided by tenodesis and lateral work and reconstruction, we can conclude that studies are demonstrating that lateral augmentation, either through anterolateral reconstruction or tenodesis, will improve results, reduce re-rupture rates, improve clinical scores, and also have protective action and favor reincorporation. When our group, or when we performed extraarticular, when do we perform extraarticular tenodesis? We do that when there is explosive pivot shift, what we call grade 2 or grade 3, also in young patients who are in competitive sports with great pivot, and in those who show high levels of laxity or increased laxity. We also do this when there is residual instability in intra-articular reconstructions as a good modern technique when there is a presence of the pivot shift that we mentioned before. And chronic tears and ACLs and in ACL revision. If we talk about what explosive pivot shift is, the one that we were referring to before, if we base it on the IKDC, we are referring to severely abnormal pivot shift where there is a great level of shifting and there is great sliding, so 7 millimeters. Now, the technique and technology has progressed, so we need to mention these 3 modern measurement systems that are being published over time in the different papers. The electromagnetic measurement system, so it's called EMS. Kira is the triaxial accelerometer system, and also image video analysis on the iPad. So I think this is the future because this will also allow us to unify the way we assess the ACL results.
De reconstrucción anterolateral extraarticular.
We have multiple techniques. We have a lateral technique where we proceed to do a lateral approach of 10 centimeters, and then we take a section of 1 centimeter wide. Then we carry out. We do a traction because it can be a swift shift, and then we locate the lateral ligament, and then we do a passage through it that will allow us to do the effect that I will be referring to afterwards. In our case, we normally set the tenodesis with a clamp, and we find a point close to the epicondyle, and then we try to select the zone in order to favor the effect of the new of the tenodesis. And then we see the side from it goes underneath the collateral ligament, and then it is set with the clamp. Just to give you an example, this is a control of the same patient that I showed. This is 6 months after the operation with the graft. You can see that that it is perfect with the wick signal. 6 months after, we may find that. And what I wanted to show in this image, which is allowing us to see or to visualize the new tinnitus, is that we're carrying out. What's the effect? This is what we're looking for. This is another plane. The signal is augmented, so it is accomplishing its role.
La grapa, la salida del cerdí, el pasaje.
It's going underneath the lateral ligament, and then it is going up. Just to conclude, the tinnitus this is something that we do open with profound passing. We do a graft. Then we, in the epicondyle, as I mentioned before, in a proximal point, close the epicondyle, we think of a flexion of 30 degrees with certain external rotation, and then we use a clamp that will prevent any conflict with the femoral tunnel. Then if we compare this, I think that the pulley effect that has been shown in the different works, it's improving the rotational control. It is proven that it allows traction lines and a push, a subsequent push effect for the recovery of the biceps tendon, which favors the anti-rotation effect that we want to have in these patients. And I think that the fact of having an insertion fix the pulley effect is allowing us to optimize the fixation for the tinnitus effect. That's all I wanted to share. Thank you for your attention. I want to invite you to the International Congress of the International Association of Argentina, which will be held together with Dr. Horacio Rivarola, and this is not something that we could do due to the pandemic. So we will wait for all of you. You're all invited in September to Buenos Aires. Thank you.
Dr. Stefano Saffagnini, y él nos va a hablar de planning and techniques to optimize success in revision ACL reconstruction. Dr. Stefano, benvenuti.
Good morning, everybody. Good morning, everybody. I'm sorry to not be with you in Cartagena, that I really miss this place. But anyway, we are here, and I will discuss about planning and techniques to optimize success in revision ACL reconstruction. So, ACL reconstruction, primary ACL normally has a revision rate of 5 to 6%. But when you speak about ACL revision failure rate, then the increasing of failure is increasing about 15 to 20%. Trying to improve our results, we need to know very well what are the causes of our ACL reconstruction failure. And there are many consequences. So meniscal status can have a role. Surgical mistake is probably the more important one. Then you have also to address peripheral damage that maybe you don't address in the first ACL reconstruction. And also patient factors. Anatomy is important too. And then it's a matter of residual laxity. Everything goes to have an increasing laxity in your knee. We have some studies in the last years about the meniscal role in ACL failure. In fact, we found that medial meniscectomy increased AP translation about 3-4 millimeter. Then the root tears has increasing lateral tibial translation and also medial compartment mobility. The ramp lesions are associated with high-grade pivot shift, and there is a stepwise reduction of AP laxity when you add the medial mat to ACL reconstruction. So there is important to really understand how is important the role of a meniscus in our ACL reconstruction. Surgical mistakes are the more important factors of our ACL failure. Tunnel location is fundamental, orientation, fixation device failure. All these type of factors can really determine what is the failure of our reconstruction. In the last year, also the anatomy is an increasing factors that we take into account when you consider ACL failure. In fact, there is a consideration that steep post-tibial slope or high depth of lateral femoral condyle and the meniscal deficiency are causes of multiple ACL reconstruction failure. And also we found that the lateral tibial slope increased more than 8 degrees. He has an increasing risk of ACL reconstruction failure with high sensitivity and specificity respect to other anatomical factors. So in order to avoid any failure, we need to have a very attention to our planning. So we have to consider the history, traumatic or non traumatic. The physical examination is the most important one. X-ray, you have to do long cassette to have a limb alignment of the knee, and sometimes you need to do also osteotomy. And then normally I perform MRI, and I just do CT when I, in selected cases, when I have to do the tunnel evaluation of the orientation of our tunnel. One stage or two stage it can be done. There is an algorithm described in 2020. But anyway, I think basically it depends on the tunnel enlargement. And normally, most of the cases I try to do in a single stage. And only when the tunnel enlargement is more than 20 millimeters on the tibia, I normally perform a two-stage procedure. So when I add some procedure to our ACL revision, normally when I think I add MAT, when I think that revision ACL reconstruction, when meniscus is believed to be contributing factor to the failure, I normally add MAT, and also I add lateral tenodesis when, especially in revision ACL reconstruction, I normally perform always when I can. And also when I have ligamentous laxity and I have young patients that are involved in high pivoting activities. These are the factors that allow me to add this procedure to our ACL revision. So my approach is when I have a failure of BTB or quadriceps tendon, I do my technique over the top plus lateral plasty. When I have failure of my ACL reconstruction, I do only intraarticular reconstruction. I can either use quadriceps or patella tendon. And in other situations, I go for Achilles tendon allograft. Our Achilles tendon allograft is fresh frozen, so it's never irradiated. And so we have no morbidity of donor site. We have less postoperative pain. It's possible used in every case. And we can use bone plug to fill the tibial tunnel. And I can use in a double bundle fashion or in a single bundle plus extraarticular plastic. I present here some preliminary data of my series that I just reviewed. And this is ACL double bundle plus over the top, 81 patients, 85% of no reintervention at 10 years. And if primary ACL reconstruction was performed younger than 22 years old, we have higher risk of failure. And 50% are still involved in sport at pre-revision level at the time of evaluation. And this is the other technique. So it's a single bundle over the top plus lateral plasty. And we have in this case 83 prospective allograft ACL revision with significant VAS reduction in 1 year, reduction of CUS symptoms, and improved CUS and quality of life and sport. So these are really preliminary data just to present you. I just showed two cases. This is a 23 years old male soccer player at professional level, where we perform a revision ACL plus medial MAT. And you see this is MRI at 12 months follow-up. Very good. This is a re-revision with medial MAT and lateral meniscus repair. And this is a post-op X-ray. And the results are really nice at more than 1 year now. So my take-home message is better to address all the causes of failure. Mat and lateral plasticity improve laxity in ACL revision, and so you need to add this type of procedure when you think these are an important factors to our ACL failure. But remember that in complex cases, you should keep it as simple as possible. So don't try to be so much complicated, because this will increase your failure rate. And thank you for all the people who invite me, and for Linas and Mosquera, that are really a friend of mine. And thank you to all my friends that I miss you in Cartagena.
Grazie mille, Stefano. You are with us now?
Yes, I am with you. Yes. So
Always
if you have some questions, I am able to answer right now.
Don't worry. After the whole topic, we have some cases to discuss. So maybe it's a good time for questions. Okay. Thank you very much for your presentation. We appreciate that. Our next speaker from Canada, Montreal, notre ami, Robert Max. Now he's working in the States. His topic is multiligament knee injuries, my algorithm for management. Mon ami.
Es un gran honor estar aquí en Cartagena con todos vosotros.
It is an honor for me to be here with all of you. Thank you, Guillermo Pablo Mosco. I have learned some Spanish, and I hope that after learning Spanish, I could be considered a honor Latin American. But last night, I found out that the Bobby Stank got married a Colombian. So of course, you need much more for you to be considered a Colombian. I have 2 days, and I promise I'll start working on that.
Now I'll switch over to a language I can actually speak. For the most part. Just wanted to remind everyone that ISACOS is coming to South America. This looks like it should be a great knee meeting, Arthroplasty Forum. We have some great leaders in charge of the program, so it should really be fantastic with Willem, David Figueroa, also Miles Coulacan, Steban Lustig from Europe, Philippe Neret, who's here from Europe, and David Parker. So I just want to give an overview. It's a short overview of a complex topic. So I thought I'd touch on each of the ligaments that are reconstructed in various multi-ligament situations. So the PCL absence makes orientation more challenging when we're talking about ACL reconstruction in the multi-ligament. For a few reasons, the tunnels need an adequate bone bridge on the front of the tibia if you're doing a transtibial PCL, which I think most people do these days. And you also need to leave room on that anteromedial tibia for MCL fixation if you're doing that as well. The notch is empty, so the tunnel placement's a little more challenging in an ACL. When the PCL is usually there, you have landmarks. So use other anatomic landmarks, the menisci, the cartilage on the femur, and be very careful with your scope orientation that you're aware. Now, this is what I'm talking about when there's nothing there. You have just your tunnels in the bone on the left. You see the low ACL tunnel posterior and the more anterior and high PCL on the right. So it's very important to plan the order of tunnel creation. And two things I think are important to keep in mind when doing so: the bone bridge between the tunnels and the proximal tibia, I alluded to already, and also fluid leak when you have multiple tunnels, which can impair visualization. And I'm going to comment on these in a little more detail. So between the ACL and the PCL, if you're placing two pins, you need 2 centimeters between the pins to get a 1 centimeter bridge of bone so the tunnels don't coalesce and collapse into each other. And this is not something we think about when doing just an isolated ACL. The other thing is the fluid management. I think the PCL tibial tunnel is the most technically demanding because the neurovascular structures are at risk, and proper tunnel placement is also critical for success of the graft. So what I'll do is I'll place my ACL tibial pin first, leave the pin, don't ream it because then you have fluid leak if you have a hole in the tibia, and then place the PCL guide pin with a perfect view through the posterior medial portal, no fluid leak, and then I'll ream the PCL first. So here you see 2 centimeters between the pins before we've even reamed anything. And then at the end of the case, it gives you that bone bridge so you can place interference screws if you like. After the PCL tunnel and doing a multi-ligament with an ACL, you can do your femoral socket. It's not a tunnel, so you don't get fluid leak, and then do your other tunnels and PCL, femoral tunnel or socket. In terms of autograft or allograft, there's no difference found, at least in the literature, for PCL. For 3 and 4 ligament knees, I generally use allograft for everything due to donor site morbidity, but I will consider a BTB autograft for ACL in a multi-ligament in a young contact athlete, and I'm going to guess Andy Williams would agree. Fixation is done after all grafts are in and fixed on the femur. The PCL I do first at 90 degrees. I use this boot popularized by Greg Finelli, and then the ACL in full extension, the collaterals last. For PCL reconstruction in the multi-lig, there are many ongoing controversies: single bundle versus double, graft source, transtibial versus inlay, and now maybe all inside. I think that PCL single bundle is the most reasonable thing to do, but it must adequately reconstitute the anterolateral bundle, which is high in the femoral footprint right next to the cartilage, and then low on the PCL facet centrally located. If you see here, this is just an anatomic picture. Is there a pointer here? Or? This here? Yes. Oh, I can go on this screen. Okay. Yeah, no, I just got to get back to the right slide. Thanks. So you see here the PCL up at the high in the notch, and we follow it. This is a normal knee. You follow it down through the middle of the knee. And you see how low it inserts on the PCL facet, right down very low. So that's where you need to put it at the time of surgery. This is a revision procedure I did. On the left, you could see on the left, you could see the failed ACL graft is quite high, up almost near the joint. And then at our revision, we put it down low, just at the champagne glass drop-off sign as it's described. So correct graft placement, critical. Protection of the neurovascular structures is, of course, key. And I emphasize a posteromedial portal for direct visualization and also a protector for the reamer as you're reaming. High anterior portal, sometimes you can see over the front as well very nicely. The graft must be adequately tensioned when fixed and not over-reduced, and center the knee by tensioning in full extension and then fixing the graft in flexion. And I use that tensioning boot and also backup fixation along with the interference screw. For the posterolateral corner, isolated acute repair has inferior results to repair post reconstruction in the acute multi-ligament. That's been shown by both Standard and Levy at unacceptably high rates of failure with repair alone. So I would think it's fair to say that isolated repair of the posterolateral corner is not indicated in the chronic situation. This is a technique that I published years ago with Bruce Levy. Just briefly in a cartoon form, I'll show you some pictures. First, identify the nerve and protect it, make the tunnel in the fibular head, place the graft in the popliteus socket, back through the fibular head and back up. We check isometry and make a fibular socket, and then a posterolateral capsular plication as recommended by Finelli. So here you can see the nerve protected. Now we have the graft already placed in the popliteus socket, and we pass it under the iliotibial band. We pass it back to front through the fibular head, back under the ITB. We have a guide wire in place now to check isometry, is 0 to 90. And then posterolateral capsular shift. I was fixing these just with interference screws, but now I'm using adjustable loop buttons, retensioning, and finally fixing with screws. And I find the grafts much more secure, very satisfying. The posterolateral corner graft must be a minimum of 23 centimeters on the Achilles with an adjustable loop. Now I'm using tibialis anterior, which is long and you don't have to worry about length, and then screws as well. I'll just do the medial side. I'm a little long on time because of my introduction, so I hope that's okay. Repair and reconstruction in the MCL and the multi-ligament knee, both have been shown to be acceptable. That was a study out of Mayo Clinic. And this is a technique I just wanted to show you that we published in Core 10 years ago now with Iftach Esroni, who was a fellow. He's in Israel now. We usually avoid a posteromedial plication. So I think you get less stiffness. The graft is extra articular and repair soft tissue as possible. This case example is a 33-year-old man who had 2 prior ACL reconstructions with ongoing instability. Here you can see his vertical femoral screws. I spent quite some time getting the video to play. Can you play it from over there?
¿Pueden poner el play del video, por favor? Pararse por encima del video del doctor.
I think maybe we'll, if anyone wants to see it, it's on ViewMedi. So I think we can skip the video because I'm running a little late anyhow, unless you got it. No worries. So here's the reconstruction. You can see anatomic just at the epicondyle, just a few millimeters proximal and posterior to the epicondyle, and about 5 centimeters below the joint line for the MCL fixation, reconstructing the superficial MCL. Like I said, the video is on ViewMedi if anyone wants to see the technique with the Achilles allograft. And I've also actually changed to a adjustable loop on the femur as well, retensioning and then fixing with a screw. So in summary, a detailed understanding of ligament anatomy is crucial. Strong fixation and grafts are necessary. Preoperative planning is critical. And make sure you have the appropriate equipment, surgical team for the operation. And I also don't recommend starting these cases late in the day. I like to do it at the beginning of the day when I'm fresh, and then the team is fresh and the people that I want to have help are there. Muchas gracias.
Muchísimas gracias, Robert.
Thank you so much, Robert. And now we're going to have some time for some cases where I will invite the Professor Giancarlos. Good morning, Isacos, for the invitation. Unfortunately, as Marx, although I speak Spanish, I'm not going to be able to be considered a Colombian because my only daughter will get married, and she's going to marry a Spanish guy. So I'm sorry, so I won't be Colombian. This is a case that I would like to present. Okay, 55 kilograms, very athletic. Although she's a good skier, she suffered she was skiing, she fell, she was in an improper condition, and she had a very severe lesion. So when she went to the ER, There was she had a severe injury. The stability in the emergency, there's a positive luck, but there's a Gottfried sign, and there's a valgus stress of, and it's considered, it was ranked 3. There are pulses, but there's no conflict with the vascularization, so we were not having any problem.
Personalmente que le practican de entrada.
This is the MRI done. The video should be activated. Could you please activate? Okay, perfect. So this is the lesion. You can see it. This was taken 1 week after, 1 or 5 days after the accident. Do we have any comments?
Okay. Look at the sagittal view, and it's okay, and was it's by cruciate plus. Can you see anything else? It was a bit of surprise. We'll see it in a minute. The middle meniscus was much better than expected. Middle meniscus. Sí, claro. It's not a quiz. I mean, it's not an assessment. It's just well, perhaps we podríamos esperar quizás una lesión muy importante del menisco medial.
We may be expecting a lesion. There's a lesion on both cruciates in the middle collateral. Meniscus. There's a
surprise. You'll see.
Okay.
And well, let's go. One more. Well, probably en este punto quizás.
So at this point, we have Bob here. Is Bob here? So
probably will define this injury as definiría esta lesión como una dislocación de tipo 3.
And it will be a dislocation type 3 with an affectation on the middle side. Do we all agree?
Not that big surprise. You will see. That's the. Esta es la exploración bajo anestesia.
This is.
Medial gapping, and AP motion was really huge, and you see here what is the behavior of the medial, el comportamiento del lado medial.
You can see the behavior, the middle behavior. Then we have an isolated meniscus lesion. We think that the lateral ligament should be recovered. We need to repair both two cruciate ligaments. So we go in, and then should we repair the meniscus, the medial?
Stage surgery, or what do you prefer? What will be your approach?
It depends on many factors, possibly the nature of the person, but also how the knee is. And in normal members of the public, pro athletes will need surgery early, and I do it usually at 2 weeks. But for other members of the public, particularly with the improvement in bracing, often I'll brace these if it's very inflamed, a PCL jack brace. You can get significant healing of medial and PCL, and you can do a delayed reconstruction at 3 or 4 months and get very good results with it. And it's interesting, I'm doing less aggressive surgery these days I'll stage things. So if it's a post-lateral corner with it by cruciate, then I'll just do the post-lateral corner. If there's too much inflammation, then we'll stage the ACL plus or minus PCL.
And I will agree with you, but even with standard injury, you will wait?
Apologies. With a stena, no, the indications for early MCL surgery are infolded in the joint, a stena lesion, and those need to be fixed. Yeah.
Dr. Marx?
So I basically agree with what Andy said. I think in a situation like this, you can wait to regain motion, decrease the risk of arthrofibrosis. Also, it looked to me like the MCL was fairly thoroughly injured, the length of it, and not something that you can go early and repair an avulsion. So I don't see a big advantage to going early in this situation. You can allow them to regain motion, swelling come down, and do delayed reconstructions as needed. In my experience, there are some multiligaments where you can get some healing. In this one, I'd be a little surprised in view of the severity if the MCL or PCL were to heal well enough that you didn't have to do it, but it does happen. If you're not there early all the time, you can be surprised at what you end up with.
¿Comentario más, Dr. Gobi?
Well, I think that she's 19 years of age, young. I don't know if she's a professional, amateur. Does not seem professional from the picture of the leg.
Amateur.
Amateur. And well, I think we should concentrate in helping as much as we can the natural healing. So if we fix the meniscus, especially if it is a ramp lesion, for sure the healing process will be much better than if we don't do anything. So probably arthroscopy would be important. Not all at the same time. I agree with the previous speaker, but probably meniscus should be fixed. At the same time, maybe if we have an avulsion of the MCL, if you fix it, it's quite simple, extraarticular, and you can have a good result. You can start immediately with physiotherapy, and then you will reevaluate the pivot, the PCL and ACL later on.
On the thing about stena lesions, I've had 2 cases in which an MRI with a stena, we repeated the MRI and it had reduced incredibly just by moving the knee.
Yeah.
So it's interesting. I'm waiting for the surprise.
So
I'm not good at waiting.
Yeah. I was very concerned about the meniscus situation because I believe that is almost luxated.
Yeah. So
I go 10 days after, because the vascular status was okay, I will for just repairing the meniscus and then stage surgery. That surprise was like that. Yo sé. Esta es la cirugía. Ligamento cruzado anterior, por supuesto, era ineficiente.
The former ligament was inefficient. The cruciate ligament was inefficient, so the ligament was on site. There was no apparent lesion. However, are you ready for this? Can you go back? Can you go back one?
The surprise was that while the medial meniscus was okay, lateral meniscus was, look at this. It's a complete avulsion road of the lateral meniscus. So we can discuss here if we should do anything in the lateral meniscus, because it has been said that the root tear in the lateral is not that important, but lo puedes activar otra vez. Es que no sé qué pasa, se detiene. It's completely avulsed. So Brisbane and Humphrey were gone. There's nothing in the lateral meniscus. It was absolutely free, the posterior horn. So look at this. Look at this. It was absolutely free. No connection with the condyle, no connection with the tibial plateau. So, well, then I repaired the lateral meniscus, of course. What's going on here? Yeah, well, and I repair everything. As I got ligaments, I repair everything. En diferencia de lo que ha presentado el Dr. Marx, nunca uso radiología interpretatoria.
I never use radiology because I think it is very easy to get to the most posterior part of the tibial slope, so you can get to that part. It is because if you can break the capsule, you will always be at the right place. So I normally don't use the radiography. I never drill. I drill from the lateral. So because it's absurd to have them. I do the conventional repair, we place the cartilage. We have an anterolateral part, which is extremely posterior. And this is how we prepare the tunnels. And then we repair the anterior. At the beginning, I tried to leave some tissue. I normally I don't clean up much, but we wanted to get to the right position to repair the anterior ligament, and then we place our grafts. We're preparing the tunnels, conventional from anatomic. This is the tibial tunnel, taking as a reference the notch, the stump, and then we separate this conventionally using two loops. We're using two loops and a transtibial tunnel of 4.5, and then we access the area of insertion with radio frequency, and we use a small spoon to create an area so that we could see the meniscus better. There was nothing in the meniscus.
To wait to the final credits.
Moscow can't wait either.
Little bit nervous, Mr. President. Pasamos ambos ligamentos, siempre es mucho más.
So these are both ligaments. It's good when we don't have any crushed ligament because it's easier to see, as Dr. Mars would say, identify the references, because everything is free. Where there's a clamp. So this is an Achilles tendon, and then on the upper part we have soft tissue. Then finally, we did a small cut, and there was
dislocated in reference to the pesanterinos, so we have to put it back. And then we fix it with two anchors, because I don't like tunnels here, and a screw, because sometimes it can break the structure. And that's all. Unfortunately, I have no X-ray yet, after all, but I promise you that the lady is doing very, very well. Thank you. Gracias.
Muchas gracias, Giancarles. Excelente caso. Vamos a compartir.
Thank you. That was an excellent case. We're going to share another case with you. Can you play the case, please? This is a patient, a 35-year-old patient with a reconstruction surgery 4 years ago with the cruciate ligament. He didn't know exactly what was the graft. There was a middle approach to the tibia with positive Lachman and pivot. You could see the tunnel widening, and in the arm there was no continuity of the ligament that was rebuilt or reconstructed. So the first question to the panel: these are the X-rays. We see that there's a widening of the tunnels, more than 11 millimeters, and more than up to 22 millimeters. And
answering questions, one step or two step, and if you performing one step, which is your preference technique?
So first thing, on the lateral X-ray, you see the horizontal joint line, but if you think about the position of the tibia, he's got a really steep posterior slope. So he's a high-risk patient, and I would certainly do tenodesis as well. The vast majority of my revisions are one stage, The main problem is a tibial tunnel that's too posterior. You can fill the space with a screw, but that can damage the graft. So I do occasionally do an acute bone grafting with allograft dowel, but 11 millimeters doesn't worry me at all. I think that should be done in one stage. I would use a patellar tendon graft with a tenodesis and use metal screws. I don't like bioabsorbable because I think they tend to encourage tunnel widening.
Right. Mosco, un tiempo o dos tiempos viendo estas imágenes.
One time or two times, or two stages. He needs to use the microphone. We cannot hear him. 22 millimeters.
22. It's too big, maybe, no?
I always have this discussion because the trend globally is to do a surgery, and they showed some cases with a good alloy or on the proximal part. So I think that each one of us can do that exercise of using a wet big one to fill. But the problem to me is not the surgical skill. To me, this is a disease that we're causing, and that it should be corrected. If you're going to operate, you all our patients are important, but a professional football player or soccer player, an elite, you may think that 2 surgeries may be difficult. My personal opinion after so many years of experience is that I first heal the disease, and I take off the graft, I place a bone, and then I do an excellent diagnosis under anesthetics, because that's one of the issues that we have. And then 4 months after, I will do a surgery. It is very rare to do just do this once.
Back to the future. Wait a minute. That's the question. We have Joao. He's raising his hand. And Stefano also, but Joao want to tell us something.
Good morning, everybody. A big hug to all of you here there in Cartagena. I miss you a lot. It's a great pity not to be enjoying this fantastic city. And I thank on behalf of ISACOS all the speakers and the SLAR for this outstanding program. It's always important for ISACOS to promote the tight connections and relationships with Latin America society. So a big hug to Moscow and to all the South American guys. En lo que respecta a este caso, es importante.
With respect to this case, in my opinion, we need to assess and we need to measure instability. And for that purpose, we use the testing device, and we trace on the CT scan to determine if we need to add a lateral tenodesis. As Andy indicated, it's really important to be sure that we're going to control rotation. I'm not so concerned in this case about the loss of bone if we use a tendon, a patella, with a long piece of tibia. We can refill the tibial tunnel without a problem. But if the loss is quite significant in the femur, we can use the Stefanus technique of using un over the top. It is very, very likely, because there will be an important rotation instability, and we need to add a lateral tenodesis. But as I mentioned, we need to know what we're talking about. What's the type of instability that we have? How many degrees of rotation? How many millimeters of translation? So if we don't know about these, we're not assessing our patient well. Those concepts are really interesting, and based on time, we're going to show you, because we were planning to do this in 2 phases, based on instability and based on the widening of the tunnel. We can hit the video there, and when we went in there, and then.
So next question is, do you have any experience with revisions of that kind of grafts with synthetic grafts? Alberto?
Yes, I did many because there was a period in Italy that they planted 1,000 of these ligaments, and many of these failed within the first 5 years. And it is very, very typical to find this huge enlargement of the bone. At that time, I developed a technique that was published with the conical press fit, femoral press fit. So using autograft, I was able to remove the bone patellar bone with a big plug from the tibia and a conical shape in order to fill completely the defect on the femur, and then with bone insertion also in the tibial tunnel, you can do in one-step surgery. However, I would discuss with the patient, and I agree with Moscow that if the patient agree to do 2 surgeries, you can first remove the synthetic ligament. You must clean very well because there are small fragments of the synthetic ligament everywhere in the capsule. They frequently have big synovitis. And then you close the gap, the tunnels, and you redo after 6 months the reconstruction if needed.
Robert, do you think it's easy to take out this graft, or do you have some complications to do it?
It is not easy. If I can tell something from...
Yes, for sure, Stefano.
Yes, in this case, it's only one of the very few cases that I do 2-stage, because when I have this type of artificial ligament, you have a lot of synovitis, and it's very difficult to remove not only the part that is interarticular, but also the one that is in the tunnel. And you have to struggle to remove the tunnel, and then you have a lot of increasing of your side of the tunnel when you go and clean and try to remove this type of artificial ligament. So in this case, I prefer 2-stage. It's the only case now.
Any comment, Robert?
Just a few comments. Basically, the LET I find very helpful in revisions to reduce risk of failure, because they're automatically at higher risk since it's a revision. So I'll do that fairly frequently. And I like patellar tendon for revisions, and I will frequently go contralateral patellar tendon with a lateral tenodesis is my sort of favorite combination for revision surgery. I also rarely do 2-stage, but there are times where you have a cavity that's too big to do in 1 stage. And another trick that I've done a couple of times the last few years is a laterally based tunnel. So just next to the tubercle coming laterally, and then you're in virgin bone, and you can get a nice metal interference screw in that bone and either graft or leave a medial tunnel if you want to avoid it for whatever reason.
Andy?
I think it's important to say the vast majority of cases I do in the series we published, there was 3 cases in 200 as a 2-stage. 2-stage is safe, and you should only do a 1-stage if you really are confident you can deal with it, because the worst thing is another failure. And but with regard to this synthetic ligament, the thing that used to kill me was you couldn't pull it out of the bone, and the shavers, I get through 3 or 4 shavers.
We broke 3 shavers on that.
And as Stefano said, I think maybe the operation will take longer than you expect.
Exactly, and you see, ahí estábamos retirando los tornillos que no eran bioabsorbibles, eran de un material.
We were removing the screws, which were of a very strange or odd material. When they looked at the size of the screws, you could understand the size of the tunnel, because as indicated before, there was a difficulty. There were difficulties to remove the graft and the widening or the enlargement of the tunnel. So you have to be very careful when you use this type of grafts. Let's play the video. We filled the tunnels with the femoral head, having a positive impact in the femur, which is simpler, and also in the tibia. You can see how we do it in the tibia. So those of you who like it in one time and and where we have a higher piece of the VTV, look at the extent of the tunnel. This is way too wide. So if we had found this interoperatory, we would have changed the indication to 2 times. Look at the size of the graft. It was extremely big, and this was a good way to refill it.
One stage, I always consent the patient for 2 stages, and of those 3 cases, one was a surprise, and she's an international squash player, and I had to give her the bad news that I couldn't do in 1 stage, but you've got to be prepared.
Bueno, hicimos luego el control imagenológico del relleno y luego del cuarto
Then
mes.
we looked at the images, and then we planned to do a revision in a second time, and then in this case we did an autograft. This just to show how there was instability. This is something that we were discussing. So we were thinking, we were planning. There was some sequels. You can see how a good tunnel filling was achieved. Benefiting from the conversation that we had with Dr. Juan Pablo. Do you think that this is a case for an augmentation? This is something that we were discussing with Robert. There's no doubt here that in this type of revision, the level of residual stability will require a lateral augmentation.
When there's just gross laxity like that on a Lockman, if you put a graft in the usual position, ACL, that has a high chance of stretching because the secondary restraints are all loose. So I think that's a great case for a tenodesis to assist your graft, reduce failure rate. I agree.
I think that in this particular case that you did in 2-step probably could be useful to use the technique that Zaffagnini used over the top and the originally Marcacci technique, then bringing down the graft on the tibia. What do you think, Stefano?
Stefano, or are you with us, or Moscow?
Yes, I would do, in this case, I would use, even if I do 2 stages, I use a fresh frozen Achilles tendon allograft, where I fill the tibial tunnel with the bone of the Achilles tendon plug, and then I do the lateral plasty with the length of the Achilles tendon. So I do my technique, but with the fresh frozen allograft.
Andy, and
when you have such great laxity, do make sure there's no missed medial laxity. A paper from Karl-Heinz Frosch's group last year in KSSTA suggested that even a minor MCL laxity increased the risk of ACL graft failure 17 times. So my talk this afternoon is about the medial side of the knee, and I'll talk about anteromedial rotatory instability. And we used to think, oh, grade 1 MCL laxity, don't worry about it. Well, for a high demand patient athlete, that is a problem, and the re-rupture rate goes up considerably.
Es muy importante lo que nos comenta Andy, y fíjense que
what Andy is mentioning is really important because the posterior meniscus was not good, and we need to discard this type of situations. In this case, was just to discuss is an anterolateral with a minimum invasive technique could be positive, or if, as Dr. Pravaliano indicated, if we could do the learner modified technique. There's no doubt that in this case, these are complex cases. First, for the enlargement, the laxitude, and I think that this is the right combination. We are quite familiar with these cases with a third surgery. And the reason is because we're really concerned about the ligaments, but the most important part is the insufficiency. If you don't do any sports, that will be different. But oftentimes, when you do an anterolateral, there will be a failure, and there will be a failure because there's no meniscus. So in my case, I never do a surgery of revision without doing a meniscus transplant. To me, this graft may fail, and this is something that was shown. If there's no medial support, then this will be a patient that will elongate, and the ligament will fail. So in this case, I will and due to the reasons that I do this in 2 times is precisely for what you just said, because regardless of how skilled that you are, there are things that you may omit, but that's something that you won't omit in the surgery. So what Andy said, this type of a rotational instability, which are quite simple, which are subtle, are really difficult to diagnose. And in this first surgery, you can do it. And you can look at the meniscus insufficiency. You can see the cartilage, the lateral part, and then after healing, you can do everything in a single time. That's an interesting concept. The patient was operated.
Comments. In fact, the meniscus laxity and the meniscus deficiency in this case is really important. And we demonstrate that if you have a meniscectomy, you have 3 times increasing of laxity. And so you have a very big risk of instability, and then this will go to failure your revision. So you have to put much attention to the peripheral structure, as say Andy, but also to the menisci. These are the 2 most important things for me right now.
Sin duda coincidimos, el paciente actualmente lleva 10 años de postoperatorio.
Yes, the patient was operated 10 years ago. He's a football player, but he's not a high performer. But we need to evaluate what's the requirement for osteotomy plus a future meniscus transplant. And if I'm
much already. But anyway, this afternoon's talk involves a lot about anteromedial rotatory instability, and there are knees that when you put the ACL graft in, they've got a negative valgus stress test. There's no opening medially. You just know that there's some anteromedial motion. So.
Bueno, muchas gracias y espero recibirlos en Argentina, en Buenos Aires, en septiembre.
Thank you very much. And I'll wait for you in September in Argentina.
My pleasure.
Fantastic.
A picture of Guillermo, come with us. Giancarlo. Guillermo, maybe acá in front of
of the time, we will be looking at the work of Juan Pablo Mosquera, Juan Pablo Martinez, and Juan Enrique Kenny and Juan Miguel del Castillo. The dynamics of the presentation of the free work is very simple. 5 minutes for the presenters and 2 minutes for commentators. Then at the end, if the public has any questions, we would like to invite the people who are going to present their research work here to the stage so that they can answer those. So the first work is titled The Reinsertion of the ACL in Proximal Lesions, Sherman 1, a series of cases, preliminary results presented
Mosquera y comentado por Dr. Alejandro Jaramillo.
by
Buenos días. Este es un trabajo.
Dr. Manuel Mosquera. Hello, this is a work with a series of cases that we perform with the experience of 3 clinics: Erasmus Clinic from Valledupar, the Clínica de Horizonte from Neiva, and Carolina from Bogota. I do not have any conflicts of interest with any co-authors. The gold standard in treating the ACL lesions continues to be reconstruction, but we have seen an increase in failures, especially for high-risk patients. Therefore, in the last 10 years, we have seen great interest in trying to repair certain lesions, especially proximal lesions that are classified as Sherman 1. This is a retrospective study, a longitudinal study in 50 patients, all with proximal ACL lesions, with follow-up of between 12 to 36 months, so on average 24 months, in which we did a subjective assessment taking into account the Tegner and IKDC scale, and in 35 patients, we performed an assessment with an arthrometer. As for the materials and methods and the criteria of exclusion, they were only Sherman 1, no matter the time since it had evolved, and patients where there was conservative or failure of conservative treatment. The exclusion criteria were lesion Sherman 2 or 3, or associated ligament lesions, or bone avulsions. Within the surgical technique that I showed before, this is available in the videos of the Congress. The proximal lesion, what we do here is to clean the wall of fibrosis. If it is a chronic case, we also perform drilling in the footprint area and take the tissue with high pressure sutures for each handle, and then we fix it. Although we can do a lot of things in 28 patients, we used knotless sutures, and as you can see in the picture here, we added an internal brace. These are 2 acute cases that I had, and this is the final result for the same patient. So we can see the ligament there. What were our results? We had a statistical analysis that we performed with an SPSS program, version 15 for Windows. We looked at the radial, so age, sex, the side that was affected, specific Lachman tests for instability, so Lachman test, anterior draw, pivot, pre and post-operative analysis as well, and we added the measurement of anterior displacement with an arthrometer, and we compared it obviously with the other side. And the statistical significance was lower or equal to 0.5. What kind of results did we have? Over those 3 years, we operated 88 patients using this technique. Since December 2018 until January 2021, we were only able to follow up on 50 patients according to the inclusion criteria. 48 were chronic, 2 were acute. 54% of cases were men. Ages oscillated between 8 and 63 years of age. The average was 32. The lower right limb was slightly more affected than the left, and according to the Tegner scale, 92% were between excellent and good results, and the IKDC were 78 in general, 85%, and we must highlight that 15 to 22% were not satisfied due to pain. These patients had work-related trauma. As for the patients that were measured with the arthrometer, there were 35 in total. 34 of those, so 97%, had a difference that was lower than 2 millimeters with respect to the good side, and the rest had a 3 millimeter difference compared to the used side. We had few complications, but there were a few, 2 infections, one that improved after washing without affecting stability or the ligament, and the other, despite the washing and treatment, created arthrofibrosis with a bad result due to the rigidity, stiffness. So it was unstable. There was also hemarthrosis in one patient the second week, and 2 patients had anterior pain, and we looked at those cases where we found some lesions. Out of all these patients, only one of them has torn the ACL. She was a football player, a young football player. She felt fine 5 months later. There was a tear, so I did a reconstruction, much like a primary reconstruction. Within the discussion, although reconstruction is the gold standard for the ACL, there is an interest in using repairs in proximal lesions. Our results reported in our work are similar to those reported in literature. Perhaps the most significant thing in this work, and also the value of it, is that in literature, there is no bigger series reported about chronic cases referring to patients with lesions that are more than 3 months old. This is a value because some have more cases, but they are usually acute cases.
Importa el tiempo, lo que importa es cómo está el remanente. Si el remanente.
The important thing is that we should look at the remnant and how it's doing, the diameter and longitude.
Aparentes es apto para reinsertar. No podemos decir que este sea
with good
mejor,
vessels for reinsertion.
obviamente es un trabajo retrospectivo. Obviamente,
This is not better than reinsertion because it's retrospective work.
pues tiene un sesgo importante que es el sesgo del cirujano.
We must be careful with the bias of the results, the bias of the surgeon, and in the literature, they're proposing that work be done where you have a prospective study that analyzes the results of proximal lesions with reinsertion versus reconstruction. We haven't looked at this yet. We hope that we can have these results in the short term. Thank you very much.
Doctor Jaramillo, por favor, comentarios.
Bueno, primero que todo, ¿se escucha? Primero que todo, felicitar al doctor Mosquera.
Okay, first of all, I want to congratulate Dr. Mosquera for his work. He has also showed us the paradigms and what we've stopped or forgotten or what we should do, and he always makes us think about whether what we're doing should be looked at from a different angle, as in the case of reinsertion.
Debido a que juntaban todos los Shermans, todas las
Which was previously abandoned because we looked at all the Shermans and classifications. We thought that reinsertion was not the way. And I think Manuel has been a pioneer in our country in South America saying that actually there may be specific indications such as Sherman 1 lesions, or as the Dr. Felice says, maybe Sherman 2, which can be reinforced with different techniques. So I'd like to congratulate him for his work, and it's great to know that it's the biggest series for ligament or chronic ligament reinsertions. It's been done in 3 clinics, and also follow-up of on average 2 years is also significant. As with all things, it is not perfect, of course. There are a few things that I would have liked to know. For example, you did not say how many times you used 2 knotless or 1 knotless to understand what kind of results may vary, because I think that it's one of the variables that we should look at. I think there was an important loss when you started with 85 and ended up with 50 patients. For some of us, a loss of 10% is also already something that takes merit away from your work. But you've said that you do not comply with inclusion criteria, so there may be other things that haven't been expressed here, and it also wasn't clear why you would use the internal brace in some and not in others, and what the comparative results are.
Por tus resultados, solamente una
But I
reruptura de
just want to congratulate you for the tear of only 50%, because that's lower than traditional reconstructions, the re-rupture rate. So thank you very much for your work. Okay, the next piece of work is an anatomical study of the tendinous portions of semi-tendinous and gracile muscles applied to ACL reconstruction by Juan Miguel del Castillo. Okay, thank you very much for accepting my work and for inviting me to be part of this talk. This is the work of the group that works in the anatomy department, where I am a professor on the board, and so it has an anatomical emphasis. We believe, which many researchers don't believe, but we believe this is the base of scientific study. Okay, next, there we go. So the introduction is that we understand that lesions in ligaments are increasing, especially in the ACL. We understand that the use and harvest of tendons from goose feet for multi-ligaments being done, but we also have issues such as available tissue when we have quadruple graft. The idea is for it to be an incision that is not invasive, so we wanted to look at the tenderness value of them and their insertion to see if there's a relationship between the length of the leg and the anatomy, because sometimes we think that the graft is not long enough. The autograft is not long enough. Sometimes we can predict that length, comparing it to the length of the leg of the patient. We also wanted to assess the role of ultrasounds that we have in our clinics to look at these terms as well and assess them. So we dissected 4 inferior limbs in formal. That's what we do in our department. We had also an ultrasound in 18 volunteers at the lower limbs. This was donated by the faculty. So for bodies to be studied, there's very important conduct issue there in our country, and we looked at different variables such as the length of the leg, and we had a mathematical model as well. So what were the results? In the dissection of the cadaver, out of those 24 limbs, the height was on average 36.2, with a variation of 2.9 centimeters. The average insertion was on the edge of the tibia and 4.6 with LA. Semi-tendinous was 2.7 and 5.7. The diameter and length of tendons were 0.55 and 13.29 centimeters for the gracile and 16.42 for the semi-tendinous. We established a linear correlation, which is quite significant with regards to the length of the pain. We have a linear regression with regards to the leg, rather, and we can look at the regression, and there are significant variables here. This is one of the dissections that we do. As you can see here, there's the goose foot reaches the distal part. As you can see,
hicimos justamente esta regresión lineal para comparar la longitud del tendón en función de la altura de la pierna y la
so the
distancia.
tendon, we can see it based on the length of the leg. We can look at the
Después
insertion based on that length.
18
Then we did the same thing, but we had healthy volunteers. We assessed using ultrasound whether we could extract some of these values.
diferencias en ese estudio.
We realized that it wasn't that easy because the study in the cadaver was quite significant, so we couldn't correlate that. The ultrasound tries to discriminate the distal part of the element of the goose foot, goose paw. So we saw common insertion 3.9 distal centimeters and 1 plus 0.3 medial to the VAT, and we can't differentiate between one ligament or another in the distal insertion. The differences could obviously be when you have healthy volunteers, you can't really compare them to a dissected cadaver with formal. But in the debate, we can say that different studies obviously show us that there is an anatomic region where we can find these tendons, and we've confirmed that. The place of the insertion, the established area, or the incision obviously tells us that if we can do the linear regression that we did beforehand, I think this is the most interesting part of the work. If the insertion is in the 10th proximal of the leg, if we take any person's leg in cadavers, obviously there's a bias in the cadaver due to the material, but on average that's 36 centimeters in terms of the length from the articular edge to the external part in the 10th proximal. If you divide it into 10 parts, that's where you have the proximal insertion, sorry, distal insertion of the goose paw. And if you're more precise, here we have the novel mathematical model for the gracile muscle. You could have the length of the leg divided by 10 plus 10 centimeters. That would give us the length of the internal part for that particular length of leg. And then for the semitendinous, if we want to know exactly how much we would measure in that patient and harvest the semitendinous, that would be the length of the leg divided by 5 plus 9 centimeters. There were no reliable results, probably due to the population because there were cadavers versus live patients. Obviously, we've already mentioned some of the conclusions. The most novel part is obviously the limitation or the area that's outlined in the ultrasound. It did not prove that it was that the ultrasound was useful for this, and I think we could explore a very interesting novel mathematical model that we should validate that in clinical practice to see if the information that we found is important and can be applied. This is preliminary work that we're doing. It's a door that's opening. See whether in the future it could be applied to our patients as a model. Thank you very much. Thank you very much, Juan. I'd like to make a couple of comments.
Bloque presentando un trabajo. Entonces,
Now
para la audiencia, la importancia del trabajo
audience of the work, the gracile
relación directa con la longitud de la pierna.
tendon and the semitendinous, the length of the same length of the leg. But it seems, that's how it seems. It's important. This seems to be quite proven in this case. I'm talking about the leg when we do linear regression, whatever that may be, whether it's multivariable, however you see that, you always need to have a background. So I can't extract variables without the biological sense, without previous rationale, because it would fall on its weight. So the length of the leg can tell me about the length of the tendon, because the length of the hamstring or the tendons, I mean, you've said that the length of the leg is directly correlated and positively correlated to the length of the tendons of the hamstrings, right? So if I look for a linear relationship with other variables that have no biological sense, then I can probably find those. What's the reason and the rationale behind this? If you maybe investigated this in your work, that's an excellent question. And I thank you for that, Diego. What we're looking to do here, and perhaps that's our bias, is that our rationale was to find an easy way, in principle, of measuring, for example, in this case, the length of the leg. And with that, we could find whether there was or wasn't a relationship with the hamstring harvest, because when you're going to operate multiple ligaments, then if you did not plan that properly, if you did not measure the hamstring, it could become complex or there could be issues. So if it's always open, it may be easier to measure. Maybe our bias was that we didn't think about it rationally. That's a critique that I'll take with me to improve things. But maybe we were thinking about making things simple when we start, knowing that it's easy to measure and it can be taken from every patient, even if you haven't done any planning beforehand. Well, I think that if they experience a lot of pain with the equation that you suggest and present to us in your work, if we find a clinical relationship beyond finding a rational explanation, it may be practical, especially when you're, for example, looking to use triple grafts or quadruple grafts. It's good to predict how far they can be flexed to have a reasonable diameter. Thank you very much, Juan.
El doctor Juan Pablo
Finally, we have Dr. Juan Pablo Martinez. The title of his work is Treatment of Chondral Lesions in the Patella of Rabbits in New Zealand. It's an experimental study and it's been commented on by Professor Figueroa. Maybe he is in the room. Thank you, Diego. This is the title then of our work. We have co-authors, Juliana Nau, there's Fernanda Sua, Andres Castro, and Jose Oscar Gutierrez. There are no conflicts of interest disclosed. As we know, the treatment of chondral lesions in the patella is a challenge in clinical practice with worse results than in other locations. The different existing treatments have their limitations in terms of cost, availability, especially here in Latin America, many are not available, and also access to these treatments. If you have a chondral lesion, this may generate persistent symptoms and lead to the development of osteoarthrosis and bad quality of life for the patient. Therefore, the objective was to assess 5 different treatments in the regeneration of cartilage tissue in chondral lesions in the patella of rabbits. This is a preclinical, controlled, randomized experiment in 20 rabbits. Both knees of the rabbits were operated on, and there were 5 treatment options. There was a control group where we performed the lesion, that had the lesion. The second one was 1 millimeter diameter nanofractures. The third one had bigger nanofractures where you would add fibrin glue. Then the fourth had aspiration of the bone marrow, trying to simulate what the drilling would do, bringing blood from the bone marrow without damaging the bone and stabilizing that with fibrin. And also the same cartilage that was taken from the lesions would create a fragmentation, and there was added what we called minced fractures with fibrin glue. This lesion was created, which was completely thick, using a commercial system with 4 millimeters of diameter for osteochondral autologous transplants, but we removed the cartilage and completed it with a cover, and we wanted this to be a 1-stage treatment. Each rabbit could have a randomized study for a different type of issue in its histology. We sacrificed them or put them down a week later, and also we used 14 different variables recommended by the ICRS for the quality of the cartilage as well as the filling percentage of the cartilage. The assessment was performed by a pathologist who was alien to the type of treatment, and it was approved by the Committee of Animal Ethics of the University of SSE. When we compared all 5 treatments, we fell short in terms of the size of the sample to find differences that were more statistically significant. But we must remember that in animals, we always minimize everything because they're going to end being put down, so we minimize the number of animals used. We found, however, that in the control group and the nanofracture group, they had the worst quality of tissue. When we compared nanofractures to the other groups, we found significant differences in the architecture of the surface, in the medial part of the cartilage and the subchondral bone with bigger nanofractures or plus nanofractures, whereas aspiration was better in terms of the clustering of chondrocytes in the medial side or part with the nanofractures. The fractured cartilage was only high in the subchondral. So for a different type of nanofractures and aspiration and fragmented cartilage, there were a few parameters that they were better at than in the control group and the nanofractures on their own. This is an image that I thought was quite nice of a nanofracture and the formation of cartilage based on that nanofracture. We can see here that the edges of the lesions have cartilage formations, and we can see the cartilage from the nanofractures, but it doesn't have good relationship with the subchondral bone, which is unstable, meaning the quality is not good. This is an image of the aspiration of bone marrow. It is not concentrate, it is pure aspiration, and it's similar to hyaline cartilage, where the chondrocytes are not clustered as in the other case, but they're more in a kind of row. The distribution of the collagen fibers and the surface layer, they're all very similar. And the debridement and traditional nanofractures show that they were inferior in terms of certain characteristics in cartilage tissue, nanofractures, plus the aspiration of bone marrow and autologous cartilage fragments. This serves as a hypothesis to continue doing clinical trials and widen evidence in this area of knowledge. Thank you very much. Okay, well, this is wonderful work, Juan Pablo. This is a preclinical trial with an explanatory objective to resolve basic science queries that are unknown, and I'm sure will have great implications on the clinical aspect. It's very interesting to see the reparatory process when you only use aspiration of bone marrow. So it's very cool work. Congratulations, Juan Pablo.
Los expositores al frente y
So maybe the next presenters want to, or maybe the presenters want to come up to the stage, and we'll have a few questions from the audience.
Dos implantes, sí en todos pensamos las dos, pero esto es importante. Y no en todos usamos internal brace y es muy importante hacer la diferencia.
So we used an internal brace. This is very important. I have found no differences when you add an internal brace from the point of view of the result. The only issue here is the fear due to the football player who had a tear, because this is a surgery that does not produce a lot of pain. So patients feel better very quickly, and I think that's the risk. But I can't say that the internal brace provides that security, or that it's better than not using it. This does attract my attention, but I think this is the interesting thing about your work, because it does break a little bit with the risk factors of the failure of a repair, or the factors that are associated to tears and to failures. In fact, in the initial work of Sherman, he describes young patients with chronic lesions. When I repair Sherman 1, for example, there's an author, I forget, if they have a higher tegner than 7 and they're young and they have chronic lesions that have not had synovial covering, it goes badly for them. So, I mean, this work does debate with your observations, because you are repairing chronic lesions in a heterogeneous group that is probably younger, with a high tegner that we call high, and despite that, you have functional results in terms of failure rates and the results reported by patients, which are quite satisfactory. So this does push the indications for repairs. So I think that's the value of the work, because if it does break, or there is a big debate with recommendations, and obviously that's difficult, even in Sherman 1, where you shouldn't do that, and that's what they say. So that's quite interesting. That's quite good. Thank you very much for your participation and for accompanying us.
Buenos días. Disculpas por la demora para iniciar. Estamos ajustando los últimos detalles. Gracias por unirse a este simposio.
Good afternoon. Thank you for joining us in this symposium. It will be in English because several of the speakers do not speak Spanish. So if you do require simultaneous interpretation devices, please make sure you use them.
Let me introduce myself. I am Jorge Rojas. I am a shoulder and elbow surgeon at Fundación Santa Fe, Bogotá, in Bogotá, Colombia. I have a master's degree in clinical epidemiology and a great interest in research. And first of all, I'd like to thank the meeting organization committee for letting me coordinate this symposium, especially to Dr. Ginás, who had this clever idea of having a discussion on a topic that we rarely talk in these meetings. And I am sure that most of you and myself had not had the opportunity in the past to have 3 editors-in-chief of orthopedic journals in the same room to discuss and make some questions that we frequently face when we are publishing our work. So it's a pleasure for me to introduce our guests. Dr. Bruce Breeder is an emeritus professor of orthopedic surgery at University of Chicago. Since 2002, Dr. Breeder has been editor-in-chief of the American Journal of Sports Medicine. And since 2009, he's the executive editor of medical publishing for the American Orthopedic Society for Sports Medicine. The American Journal of Sports Medicine is the official publication of the American Orthopedic Society for Sports Medicine. As you probably know, AJSM is a very prestigious journal in our field, and its current impact factor is 6.2, ranking it 3 out of 82 journals in the category of orthopedics and 7 out of 88 journals in the category of sports sciences. Second, we have Professor Stefano Saffagnini. He's the head at the Second Orthopedic and Traumatology Unit and the coordinator of the Sports Traumatology Excellence Center at the Istituto Ortopedico Rizzoli in Bologna, Italy. He is full professor in orthopedics and traumatology at the University of Bologna. And since 2019, he is the editor-in-chief of the Journal of Experimental Orthopedics. GEO is the official open access journal of ESCA. And last but not least, Dr. Fernando Barclay is the head of the Department of Orthopedic Surgery and the Unit of Arthroscopy and Sports Medicine at Clínica Besone in Buenos Aires. He is the editor-in-chief of Arthroscopia. Arthroscopia is the official publication of the Argentinian Society of Arthroscopy, as well as the official publication of slard. This journal is published in Spanish and is a free open access publication. In addition to our guests, we also have Dr. Camilo Elito. He is a slard member. He's gonna help me to moderate this session, and also Dr. Francis Soler from Spain as a slard member panelist. So thank you all for your participation in this symposium. So we're gonna divide this symposium in 2 parts. In the first part, each one of the editors-in-chief are gonna present us their journals, and then all of us, including you, if you have questions, I encourage you to participate, and we will have a discussion on some topics regarding publishing in orthopedics. So without any further delay, let's continue with Dr. Reeder, and he's gonna present us his journal, AJSM.
Muchas gracias, Jorge. Buenos días.
Thank you so much, Jorge.
See if I can figure this out. Can I have my slides? There we go. Okay, I must say it's a great honor to be part of this symposium today and to be back with so many of my South American friends. Poetically, the last international meeting I was able to attend outside the United States was the SLARD meeting in Santiago, Chile, 2 years ago. It's hard to believe 2 years have actually passed by. It's like a big hole in my life, but here we are back after the COVID hiatus, we might say. Well, 2022 is a very special year for my journal, the American Journal of Sports Medicine, as we're celebrating our 50th anniversary year. And so I'd like to take the opportunity to tell you a little bit about how AJSM came into being, how it developed, not just into one journal, but into now a family of journals. Which button? That one? Okay, so it all started 50 years ago in 1972. And it was really the vision of one man, Jack Houston, from the Houston Clinic in Columbus, Georgia. He wasn't an academic, but he felt that it was very important that there should be a journal of orthopedic sports medicine. This may seem very natural and logical now, but at the time it was kind of a revolutionary idea because most people in orthopedics, at least in the US, kind of ridiculed sports medicine and thought it was a silly thing. And as a result, it was very hard for American orthopedic surgeons in sports medicine to get their articles, their research published. And so he thought it was important to have a journal that would just be sports medicine to publish those articles. Interestingly, at the same time, another group of people founded the American Orthopedic Society for Sports Medicine for a very similar reason, because there was no place for American orthopedic surgeons in sports medicine to present their research at meetings because they were always turned down at the major orthopedic meetings. So 2 years later, these two entities came together in 1974. AOSSM and AJSM joined forces, and AJSM became the official journal of AOSSM. Now, if you look carefully, you will see that the name of the journal is the Journal of Sports Medicine. We didn't become the American Journal of Sports Medicine until 2 years later, when the society decided to purchase the journal from the original publisher. And it was kind of a shoestring operation at the time. The president of the society, Les Bodner, actually loaned the society $100,000 to buy the journal. So the society bought the journal, and the name was therefore aligned with the society and changed to the American Journal of Sports Medicine. And a contract was signed with Williams and Wilkins to be the publisher. As you can see, we went through quite a few different cover designs these first several years. In 1979, we're already on our fourth cover design here, but I think what I wanted to point out is a very important event happened in the history of the journal, is that the society realized it was important for the journal to have editorial independence and not be involved at all in politics of the society. So a separate journal board of trustees was established, which only looked out for the welfare and the development of the journal. And I think this has been really important in the development of AJSM over the years. After a few years, the journal trustees thought that maybe we could publish the journal ourselves, so we didn't need an outside publisher. They told Williams and Wilkins they were discontinuing the contract. Williams and Wilkins immediately wanted to buy the journal for a lot of money, but we thought, well, that was pretty valuable, so we kept it to ourselves. 1990 was a pretty momentous year in AJSM. Dr. Houston felt that someone more academic should be the editor, and so he asked Dr. Robert Leach, who was chairman of the Department of Orthopedic Surgery at Boston University, and at that time was working as the chair of the Board of Trustees. He said, let's change positions. You become the editor and I'll become chair of the Board of Trustees. So that happened. And I think this was another important event. Dr. Leach was very active in the international Olympic movement. And I think this was influential and helped AJSM become even more international in its outlook and scope. One of Dr. Leach's other innovations was to start the section of review articles called Current Concepts in 1996 with Tim Foster as the editor. 2001 was another very momentous year for the journal. Dr. Houston retired, and Dr. David Sisk from the Campbell Clinic in Tennessee took his place as chair of the board of trustees. Dr. Sisk immediately had another job because Dr. Leach said he was going to retire also as the editor of the journal. So a lot was going on. One of the last things Dr. Leach did before he retired was to take the journal online. And again, a very important event in the history of the journal. It seems, of course, completely natural now that journals would be online, but at the time, there was a lot of anxiety that this might cut into the subscriptions of the journal. Nevertheless, of course, it did not. In fact, it allowed the journal to expand and to have a more international audience. Dr. Sisk immediately set to work, and in the summer of 2001 started looking for a new editor. And it probably won't come as too much a surprise that after a competitive qualification, we might say, I succeeded in becoming the new editor of the journal, and somehow they haven't gotten rid of me yet. It seems unbelievable that it's been at least 20 years. Nevertheless, I set right to work, and with the advice of Donna Tilton, who I saw earlier in this room, we started an online manuscript submission system. Before then, it was very old-fashioned. If an author wanted to publish a paper in the journal, he had to actually mail 4 copies of the article to the journal. They were then mailed to reviewers who read them and then mailed them back to the journal. It was very, very cumbersome. When we went online with our submission and manuscript review system, again, it allowed the journal to become much more international because it was so easy now to have authors from all over the world submit articles and to send them to reviewers from all over the world as well. So all these things really helped in the growth and I would say the internationalization of AJSM. In 2004, we started to realize that publishing a journal was getting very, very complicated. And so we started to look for a possible new publisher because we were only publishing it with a couple employees of our own. And after a competitive process, Sage Publications from Thousand Oaks, California became our publisher. We've had a good relationship with them and we've renewed the contract with them several times since then. The journal continued to grow. In 2005, we started monthly publication and we also started the preview or published before print section so that as soon as articles are typeset and approved by the authors, they're published online without having to wait to appear in a print issue. Now, publication has gotten more and more complicated, as has orthopedic sports medicine. And over the years, I've realized that we need more and more expertise to really evaluate the papers sent into the journal. So besides Tim Foster, who's the current concepts editor, I asked Braden Fleming, a PhD in biomechanics, at that time from Harvard University and now at Brown University, to take over and be associate editor for biomechanics. And since then, we've had a number of other specialty editors, including Scott Rodeo in translational biology, David Landy, who's a PhD in epidemiology for controlled trials, Jim Carey for epidemiological and large database studies, and Ted Ganley for pediatric orthopedic sports medicine. We also have Brett Owens in charge of the electronic features, which I'll talk about in another slide or two. Now, this is a snapshot of AJSM in the last completed year that we have, 2021. If you look at the top graph there, you can see in the next to last bar, in 2020, there was a huge COVID bump in submissions, 500 more submissions that year than we ever had before. I think orthopedic surgeons had nothing else to do except finish all the projects that they were procrastinating on for many years. Now we're back to sort of normal of about 2,000 submissions a year. In 2021, we published 416 articles with an 18% acceptance rate. We're now up to 14 issues a year. We have monthly issues plus bonus issues in March and July. Last year, we had our highest impact factor so far to date of 6.203 with a 5-year impact factor of 7.391. We have roughly 1.5 million downloads per year, which is, I think, strong for a subscription journal. Now, if you look at the bottom graph, you can look at those bars, and the blue bars are the publications from the United States, and the red bars are from the rest of the world. And as you can see, it's pretty much 50-50 from the US and the rest of the world. So that's AJSM today. Highly cited topics in 2021, of course, the ACL, which is no surprise, but specifically some of the adjacent topics such as the ALL, a relationship of OA after ACL injury and re-injury and revision, articular cartilage resurfacing, FAI of the hip, PRP and MSCs, and shoulder instability. These are some of the most cited topics from AJSM from 2021. More and more in the 21st century, of course, electronic and social media are very important. And so we created an electronic editorial board specifically to handle those areas of business. Brett Owens is the head of that. This is expanded now. We have 25 members from all over the world, including several from South America. These people create and manage the Facebook, Twitter accounts, and also they create electronic features for the journal. For example, we have podcasts, at least 2 podcasts every month with author interviews and highlighting articles in that month's AJSM. And we put on regular webinars. Just last year, we were honored to collaborate in a webinar with SLARD on shoulder instability. And then finally, we have video features in AJSM, including an animated video every month and author interviews. So all of these are electronic features, which I think are really an important part of the journal in the 21st century. But as I said, we grew into a family of journals. We're not just AJSM anymore. The first journal that we added was Sports Health, a multidisciplinary approach. This actually started brewing in 2007 when a publisher approached us and asked if we wanted to purchase their general interest sports medicine journal. We decided that that wasn't a very good idea. We could do a better job ourselves by making a new journal from the bottom up. So we started Sports Health, and the concept of Sports Health, rather different from AJSM, is that it's a multidisciplinary journal. So we have input not just from orthopedic surgeons, but from primary care sports physicians, from athletic trainers, and from physiotherapists. And Sports Health is also a very strong journal with its own impact factor over 3. Ed Voitis serves as the editor-in-chief of Sports Health, and I work on that simply in an advisory capacity. Sports Health is green open access, so the articles become open access after a year, and so downloads are very strong, over 2 million downloads a year. Being a multidisciplinary journal, it's important for Sports Health to have its own group of associate editors in all these areas. So we have Irf Asif in primary care sports medicine, George Davies in physiotherapy, Tim Gabbett from Melbourne, Australia in sports science. We have Ryan Palmieri Smith in athletic training, Hollis Potter from HSS in imaging, and then Moen Khan is our social media and electronic media editor. Well, that wasn't enough. We thought we needed to have at least 3 journals in the family. And specifically, I thought that open access is a concept that I was aware of since 2001, but it was growing and growing. And I thought it was important for us to have an open access option for authors that wanted to publish open access. So in 2013, we started OJSM, which, as you know, is our online completely gold open access journal. So every article published in OJSM is freely available immediately from the time of publication. I'm very proud of the fact that OJSM is one of the first and still one of the only orthopedic open access journals to have an impact factor, which is now over 2.7 and continues to grow. We have an international editorial board for OJSM, and we have a very international group of partner societies. This is one of the things that I'm really keen on in OJSM, is that we have international participation. We have 35 international partner societies now, all of whom their members get a steep discount on the APCs. Here's a snapshot of our society partners, and I'm particularly proud. The one I've circled in red, of course, is SLARD, which we're delighted to have as one of our society partners in OJSM. OJSM has its own board of associate editors that help me out a lot with this, including Julian Feller from Melbourne, Australia, our latest addition, Don Fithian from California, Keith Kender from Michigan, and Dan Washer from New Mexico, who is here in the room. And I'm delighted to have him here. And he does a wonderful job with OJSM. And then we have Doug Evans, again, with social media. Well, our latest addition to the family is a little baby. It just started last year. So we're just completing our first year plus a couple months in publication. This is VJSM and the Video Journal of Sports Medicine. We started this because we thought there's a lot of video out there on the internet that's very unregulated. And I thought it was important to have a peer-reviewed video journal. So the concept of VJSM is that the principal article is a video, an 8 to 10 minute video, with the written portions limited to a transcript of the video, the reference list, the abstract, and of course the author declaration. Steve Brockmeyer helps with this as the editor-in-chief, and we are doing very well. We're continuing to grow. We have an international editorial board of almost 100 members, and VJSM has its own group of 25 partner societies. Again, I'm excited and honored to say that SLARD is among them, and we're really delighted to have this partnership with SLARD. Finally, this is not a journal, but it's kind of a pet project of mine. We call it the Easy Writer podcast. Every month I get to interview somebody from the world of orthopedic sports medicine and find out all those little secrets about their lives that you don't know about. We've had some wonderful guests, including, of course, my dear friend, Mosco Mosquera. And if you haven't heard his interview, I advise you to go wherever you find podcasts and listen to it. You're going to find out some wonderful things about Moscow that maybe you didn't know before. We've got some other great interviews on there, including Freddie Fu, Reinhold Schmieding, as you see there, and coming up in 2 months, Werner Mueller from Switzerland. So I really appreciate the opportunity to talk to you today. I probably shared more information than you ever wanted to know about the AJSM and our family of journals. It's a great honor to be here. I'm sorry that I blew out all the electricity, but I'm a rather electric personality, I guess. Anyway, thank you very much.
Thank you very much, Dr. Ryder, for this insightful talk on the AJSM family of journals. Now we are gonna go ahead with Dr. Safagnini and the Journal of Experimental Orthopedics. Dr. Safagnini, please go ahead. No, parece que nos está escuchando.
No ce l'abbiamo. No, they should have the presentation.
You should have the recorded presentation.
The recorded presentation, you should charge the recorded that I send you.
Okay. Él dice que la envió y que está pregrabada. So I think while we figure this out, we are going to move with the next speaker.
Yes.
Okay.
Dr. Barkley, can you go ahead? Muchas gracias. Dr. Barkley nos va a hablar de la revista Artroscopia.
He's going to talk about the Arthroscopy magazine, journal.
Bueno, esto también en Latinoamérica. Decía que esto también es Latinoamérica, ¿no?
This is Latin America difficulties. I mean, at home, we have power failures all the time, and managing a journal also involves this type of things. But my gratitude to Moscow and to Slard for the place. I always say that I would like to see full rooms or full house when we have these type of events, and I never achieved this. Cruz has helped us a lot in these courses in Latin America and in Argentina. And I normally apologize for the rooms. He's not so concerned about that, but perhaps we could. I know that I will accomplish my work when I have my full room. So I'm going to talk about the journey of the Arthroscopy magazine, which is the Latin American magazine of arthroscopy.
Ok. Antes de empezar con la...
So before I begin explaining the journal, there are no magazines without authors. This is essential. If we don't have people to publish there, we cannot have any scientific journal or magazine. So we have to understand this. Why are we publishing? I did a small summary in terms of why are we publishing this type of information, and this has to do with this. What you're apart from the curriculum or apart from the fact that we have a contract with the society in order to publish. I think that the most important thing is to know that in order for us to publish, we need to have something to say. And if we have something to say, in order for people to know what we want to say, I'm going back to 1994. The Argentinian Arthroscopy Association was created in 1987. The foundation, as many society, stemmed from the Orthopedics Association, and those who created that association were really clear that the creation of a magazine was going to be the fundamental basis for the growth of that association. And just as Bruce mentioned Jack Houston within the American Association of Sports Medicine, one of the founding members of the Argentinian, who is Dr. Luis Musculo, he indicated that the reality of publishing a journal was essential. And why? It has to do with the publication. The publication helps us analyze the work. When we write this into paper, we can become more sensitive to what we do. It leads us to investigate. And at the end of the day, we can treat our patients better. But it also has to do with this, and this is something that was written by Luis in the first editorial of the second version of the journal. As Luis indicated, he said that there is no medical association that can survive without scientific papers published. So I think that the Latin American Association of Arthroscopy, which is your association, has to be fundamentally based on its journal in order to succeed. So we were with our group in 2010. We took over the magazine. And that first part, what we tried to do was to change what we were presenting in the magazine. So we were based on evidence, and we took the medicine based on evidence as the format. We tried to increase the number of papers published. We tried to convey a structure, administrative structure that the magazine didn't have at the time. I am very pleased to hear Bruce when they were sending the papers, 4 copies of paper by mail 10 years before we did. I saw a lot of editors in the 10 prior years with their works, correcting them in the different places so that they could produce these magazines. And this is a story that is repetitive, and this is perhaps the story that we want to change. So the administrative structure helped us organize ourselves, just like the commercial structure. We were going to talk about open access, but everything helped us grow and improve in terms of what we were doing. And fundamentally, what we did, we digitized it, and from there, we achieved a better visualization of that the paper-based journal, which was quite regional. Then in 2012, we did the first merger with the Latin American Association. This first merger was an initial merger. It was rather weak because we didn't have any commercial support in the online magazine, and the Latin American society was working to increase the amount of work that was received to the magazine. So the reality is that at that time, these were 10 years, very exhausting, where we established a very limited board at the time because we were reviewing pretty much everything that we were doing. It was 2 or 3 of us doing. We were doing grammar corrections, a spell check, and we were also doing pretty much everything that others had to do. But despite that, we had the positive things far beyond the negative things.
Lo más importante para mí, lo negativo fue que la fusión con slard no fue tal que esperábamos. Fue una fusión débil en donde más allá del
merge with slard was weak. It wasn't the one we expected. So there was no commitment from both societies to bring the journal forward. So I think that there were a number of positive things. The visibility increased, and administratively and commercially it worked, and we started to self-fund. It is an open access journal. It was always open access, and luckily we were able to fund ourselves. In 2017, we adopted JS, and in terms of work, for those of us who worked as editors at the time, this benefited us enormously. It is an operating system that allows us to organize the work that we receive and organize revision work, review work. So those who worked with me helped us achieve great growth.
Digamos, yo me preocupé en
But
seguir.
fundamentally, I was concerned about continuing with the merger because there aren't too many Spanish journals or journals in Spanish. I mean, we have the Spanish one, but we know that the Spanish language is a language of enormous growth around the world, especially in the US. And Bruce probably knows this and must be interested in having the Spanish language in his journal as well. If you look at the numbers that I was analyzing, they are truly impressive. The Hispanic community, or as a language, it would be the first community, non-English speaking community in the States. If we look at statistics about the language that university students choose as a subject, the first language that they choose is Spanish. So I think this is an enormous opportunity as a Spanish-speaking journal, not just in Latin America, but also around the world. For this reason, in the previous SLARD Congress, we have David present here, by the way, we set up a meeting that was quite tense, quite difficult, but it was absolutely useful from my point of view, because we can bring our efforts together, and we committed to keep moving forward because we needed to keep moving forward in a more unified manner. So we created a new editorial council with representatives from many different countries around Latin America, with active participation in the development of the journal, with habitual meetings to discuss different themes in the article and the journal from a global Latin American point of view. So this was truly important.
La cuestión del open access, hoy los journals del mundo.
For me, it was very important for it to be open access. As our colleague showed us, most journals are becoming open access journals around the world. It's the best way of making the work that we publish visible, and I believe that open access has a lot of advantages and great commitment to keep moving forward. One of the great commitments is related to the model that allows us to sustain that open access. So the model that we're going to use around the world is a model shift. So generally, the open access model was one in which the user would pay to read articles in a magazine. But today, this is turning around on its head, and nowadays authors will be paying to publish. And this is how most international journals are being managed right now. Now, if I try to compare myself to the international journals, this would be quite difficult because generally speaking, around the rest of the world, in Europe and the US, authors don't usually pay for this. In actual fact, between 65 to 70% of authors have been funded by different institutions, either universities or libraries or their workplaces. Therefore, it isn't the author himself or herself who pays, but rather the institute supporting that particular author. So it's the institute that pays, because publishing in the US and Europe gives you a certain level of institutional status. That means that institutions will support these authors. Latin America has a great problem because our institutions don't tend to support authors, and they don't take the author as someone who gives them institutional status. So for us, open access will be an issue because authors will definitely not pay to publish in the arthroscopy journal, and if this happens, it may disappear. So we need to make the most of self-funded open access and find a way to ensure that the Arthroscopia journal, this Latin American journal, continues. Find a way of helping it continue without authors having to pay for publications. And then maybe based on this new open access methodology around the world, Arthroscopia will be able to publish the greatest amount of articles, and it will continue to be free for the author. Without a doubt, there is a funding issue that we need to solve and work on so that authors do not depend on companies in their publications. I believe that the contributions and financial work should be done for the journal, Arthroscopia, so there's no bias, and publications can be absolutely clear for those who are going to read it. So after looking at Bruce's presentation, it's difficult to compare this, and I don't intend to compare this at all, but just so you understand a little bit, I compared myself with the Michelin stars of a restaurant. I like to cook. I think I'm a better cook than a surgeon. But in order to achieve Michelin stars, we need quality and creativity above all, and these stars are granted in these areas. 1 star means it's a very good restaurant. For general regional consumption, 2 stars usually refer to a very good quality restaurant with international consumption, and finally 3 stars mean that they are high quality restaurants of superlative quality, as for example the American Journal of Sports Medicine would be in our case. But stars do not need to be requested. You know, often I walk down corridors in congresses and people say, when are we going to index? When are we going to index? When are we going to index? Indexing is something we should earn. It's not something you should ask for. It's a long pathway to reach indexing, and it requires a great deal of work. So whereas Arthroscopia at the moment, I think in terms of quality, our current quality shows us that we have a long way to go. Indexing means that you have to have articles of better quality and better level of evidence, and I will later show you that we are in a very low level, at a very low level for evidence. So I think that in order to improve quality, we need to educate ourselves. A congress like this one is the kind of place we need to choose for that education to ensure that the biggest amount of Latin Americans publishing good quality work is even higher. Creativity is linked to finding different ways of doing things. We had a meeting with the editorial council of the journal to see how we can move ahead and implement new pathways for the journal to continue to grow. And this fundamentally depends, in my opinion, in Latin America on the abandonment of biases and issues that intervene in the growth of something that is not our own. It belongs to a society, an enormous society, the current Latin American society. And for me, the soul of every journal or magazine is the editorial council. You have the editorial council in the second step that will help the journal grow, and that's why we need it to be truly proactive, and for each one of them to perform a particular role, and for this to allow the journal to continue to grow. We are here, and perhaps these are all Latin American organizations that have worked with Colicete in Argentina, the body that regulates all these journals. We've had many different meetings to see how we can continue with this and how we can get the journal to reach indexation. I put that in yellow. I think everybody's concerned about this, and it is a truly long path. Within that path, you have all these different items that you can see here. So increasing the percentage of articles published, of course. We have a quarterly journal. We have an average of between 30 to 40 publications per year. If you compare that with the American Journal of Sport Medicine, it's quite hard to see these figures, but as Bruce said when we were talking, sometimes he asks me why I'm laughing, and I laugh because it's interesting to continue to work with this, and I think Latin America is able to reach the numbers of the American Journal of Sports Medicine. We need to improve the quality of our work, without a doubt. We need to improve the index for impact that we don't have at the moment. And we need to continue to work on understanding that publishing is the foundation of any scientific society. Within the visibility of the journal, the idea is to take or to translate it or make sure it's in these two languages, Spanish and English. We also need to professionalize it. This is very important. I was looking at the editorial council that Bruce showed us, and each one has a role. Each person has a role and is an expert in a specific area. So you can only imagine what this would represent for a Latin American article or journal to have this kind of editorial council. I think it can be done. I think it's a case of setting this objective, because anything we set out to do, we will probably achieve. We both need to professionalize and transform an article, and to do that in two languages we need a budget. So it is key in the sense to understand that the article is a company, or the journal is a company, and any company would need budget to continue to move forward, would need a budget. So how much do we publish? Just so you have an idea of how we're doing. This isn't in any way to compare. This is something that was published, Anna, 2004 to 2012. So the number of summaries presented to the Congress, out of those 67% of these summaries or works presented are published. And here you can see that the American Journal of Sports Medicine up to 2010 had a higher level, so 77.4% of those presented on the lectern are published. And we do not have a database, so that makes it difficult too, but I personally went and looked at the Congress of 2016 of the Association of Argentine Arthroscopy, and I was looking at the summaries and the works presented to the lectern, and only 5.3% of those were published to date. So this means that we can see the figures of how much we publish exactly, and the figures are the only thing that show us the real situation. What do we publish? We also performed a systematic review with our group that we published in 2010 in the journal Arthroscopia. The systematic review tried to define exactly what kind of quality of work was published in Latin America, and we have levels of evidence 4 and 5, 90% of the publications, and level of evidence 1 for 1% of the publications. This means that it's not just about how much you publish, but also about what kind of level of evidence our publications have. And these are absolutely real figures that you can look for in any location. I think that Latin America has, generally speaking, retrospective thoughts.
A principio de año con nuestro grupo de trabajo.
When we sit with our working group at the beginning of the year, we usually think about what we've done in the last 2 years. And so we start to look for patients, and most of the work that we publish is retrospective for a series of cases. And so I think that one of the fundamental changes that we need to make is precisely that, to think about, or to think prospectively. So anyone who manages groups in our countries can sit down at the beginning of the year, instead of thinking retrospectively, they can start to think prospectively to the future, because we all know what kind of surgery we perform, and we can definitely schedule the rest of the year here and after. So we train our fellows, we train our residents to think forwards, and that way, or to be forward thinking, so we can increase the level of evidence of our work. So as you will see, this is not an easy task, and it's not just about indexing or not. It requires data collection, the creation of databases, training for our residents and fellows, and they should be the engine that helps us throughout the year publish good quality work. I am not a huge fan of social media, but analytics show us how we're doing, and the general growth of the visibility of the journal, which always increased in the past. We are at around 60,000 users that go into the article or read the journal per month. This is definitely a gift. I was looking for the article that was read the most, and incredibly, the one that was read the most was the one about how to publish a scientific journal by Bruce, with the help of Pablo Narbona. So this is the most read piece, but we do not have that many publications, on the other hand, or a high level of publications. Latin America has always had these dichotomies and paradoxes, and perhaps that's due to our culture, but science needs order, and it needs us to be able to show and see what's happening to us, whether that's good or bad. Continuing with education, and thanks to Bruce, we're going to perform this course this year jointly with the American Journal of Sports Medicine. The idea is to have an online course. It will be a practical course for publications. We'll have pre-recorded talks about specific cases. There will not be big conferences, but a look at the different publications in arthroscopia, the journal, and to see what we can do better. So we can do that as of April or May. We'll have 4 modules that will try to continue to educate so that we can continue to publish. This will perhaps be a practical guideline so that we can all use it and improve our publications. So finally, I'd like to thank Pancho Arcuri, who has been my right-hand man for many years. Over the last 10 years, he has become so interested in the journal that he has created courses on statistics and many other things that are linked to the journal. And of course, this is absolutely ad honorem. Nobody on the editorial council charges for the work that they do, and we believe that this work is absolutely necessary and essential within our medical practice. I'd like to thank Pablo, who is here and who helped us very much so over the first few years, because we were parting from a journal on paper without any level of professionalization. We tried to make it professional, and he was of great help over the last few years. And we've got him here. This is our editor, who does the admin and commercial part of the work, and he has learnt with us and grown with us to take the journal to where it is today. Just to end, this is perhaps the mission of the group of arthroscopy. They published this mission, Arthroscopy for the World. The mission is to be the maximum authority on the source of information that is most updated, to be reviewed by our peers in the world. And I believe in regional education, not global education. I think that every country has its own culture and its own methodology, and I think that our football players and our torn ACLs are playing on land with wells and soil, and so that sometimes to recover they have to work, sometimes they have to recover at night or work at night for 12 hours. So sometimes our results are very different to players who play American football or patients in Finland who have different climates and different cultures. We eat a lot of meat, a lot of fat, we are fatter, and I think that we definitely need to capture all of our results and share those with our colleagues in Latin America. So please choose our journal, Arthroscopia, and hopefully it will become what we all want it to become. Thank you very much.
Muchas gracias, Dr. Barkley, por
Thank you very
esa.
much, Dr. Barkley, for that wonderful talk. It is admirable to see the efforts that you have made with this journal, and especially making it open access and free is a point that I think would lead to a great discussion about the role of open access and free journals in coming years. We will now continue with the talk by Dr. Safanini of the Journal of Experimental Orthopedics.
To this nice session made by Lenas about the editorial board of some important journals, and I am the smaller one, but I am glad to be the first one speaking. So the JEO, Journal of Experimental Orthopedics, is the official open access journal of the European Society of Sport Traumatology, Knee Surgery and Arthroscopy. And I am the editor-in-chief, and I have been invited by ESCA to take the position of the editor-in-chief from June 19, 2019. And there was the scope to bridge the gap between orthopedic basic science and the clinics. So therefore, from my start chairing this journal, we increase the area of interest of the journal. We have entire orthopedics field, including basic science, clinical research, studies, and translational and epidemiological study, and across all aspects of musculoskeletal disorders. So there is definitely an increasing part of area that we are more interested now before the beginning. In fact, looking at the history of GEO, the 2013 start, the GEO was launched as the official basic science journal for ESCA. And the goal of this time was to really attract basic science people to included in the ESCA society. And the first editor-in-chief was Professor Henning Madri, that I take his position from 2019. And 2019, I was nominated the editor-in-chief because Henning Madri was want to close his position. And so I was asked by David Dejus, that at that time was the president of ESCA, to become editor-in-chief of this new journal. And I thought it could be a nice opportunity. And the expansion of GEO-scope to include clinical research. And now in 2021, GEO is already indexed in Emerging Source Citation Index and Clarivate. And in 2022, I could say that GEO is continuously growing and expanding, and we need the help of all the people who are interested in research and clinical and basic science study, because I think if you want to really increase your capacity, you should be able to do some research. Why you choose GEO to publish your research? Obviously, there are many attractive things, fast publication schedule. So you have 35 days for the first decision, including peer review, and 80 days to final decision. This was our data in 2021. We perform even the double-blind peer review system, and this possibility to publish a large data set and large number of color illustration and moving pictures, display data in a form that can be read directly by other software packages, so allow readers to manipulate the data for themselves and create all relevant links to other journal and other things. So it's really easy and open access journal. Geo, as I already say, is included in Web of Science and in Emerging Source Citation Index, and also is in PubMed, PubMed Central, DOAJ, Embase, OCLC, Scopus, and Summon by Serious Solution. So there are many ways of found our paper, and we are really trying to increase our visibility in all the way. Looking the type of published article in 2021, most of the people are original paper and review paper, and very few case report, editorial note, or letter to the editor. So there is, we accept all type of scientific articles, but should be very good performed and very well interested. Geo, we try to have an international profile as much as we can and encourage submission from all geographical areas. In fact, even if it's an ESCA journal, we have half of the people that are from Europe, then we have most of Asia Pacific people that are very attracted, and even North America and Middle East. And we need to increase the Latin American part of our journal. And I hope this presentation will help in doing this. In fact, we have seen in these last 2 years a continuous increase in citation and downloads that really, I hope, will allow us to have impact factor this year, and in order to be really even more attracted by and attractive for the researcher. This is just to see the new submission, and you see from 2018 to 19 there has been a jump from 220 and 221, and we have now in the new trend even in 2022 similar to the 221. I wouldn't expect to have a double every year because it's impossible, but I hope to have a 20% increase even this year. There are some J awards. So the best paper, that is a biennial award with prize of €1,000. And the award for young research in clinical science, and also has a biennial award prize of €1,500. And obviously full article publication charge of waive. And the award for young research in basic science, and again, is a biannual prize with the same amount of money and the full article publication charge waiver. And then we have the best reviewer, because also it is important that we recognize the role of the reviewer, that without a reviewer we cannot do this type of work and to be so quick in publishing. And so there is a annual award that is a prize and is done with the free ESCA Congress registration for the best reviewer. And the awards will be given to the winner at the biannual ESCA Congress that this time will be in April in Paris. This year we have also some promotion. So we have a 40% discount of APC for the first 20 papers that will be sent by 12 or 22 ESCA Congress delegates. So if you are able to come to ESCA and you are a delegate in ESCA Congress, you can really send the paper to us and you will get the 40% discount. Then we have 10 expert opinion articles that I could pick during the year, and Springer allow us to have a free waiver for these 10 expert opinion articles. So geo-social media is a very big part of the new things that we are trying to catch because it's important to have a really live social media, especially for young population, for young doctors, and is very active in our journal with all social media platforms, ensuring large promotion of scientific papers and authors. So we will have a podcast and we will have Instagram images that will where we'll make announcement of all our new paper coming out, and this will allow to this paper to be even more cited. And so I hope every one of you young that you are in the meeting right now follow Joy social media for update on latest research and finding published in our journal. Obviously, I have a sister that is Kesta and is much bigger than us, but we have some educational initiatives that are coming together. So we have a methodological course for evidence synthesis in medicine, and is one-day online methodological course for evidence synthesis in medicine that will be taken in March. So I think it's 18th of March 22. And then we will have the Kesta Geo Authors and Review course that will be taken live course during the ESCA Congress in Paris, the 29th of April, 2022. As I say, Kesta and Geo, we are the two official journal of ESCA. ESCA, you know, is the European Society with a community of almost 15,000 professionals, more than 100 countries. Congress has normally more than 4,000 attendees. We have 40 affiliated society. We have 4 specialized sections, ankle and foot, degenerative knee, shoulder, and sports medicine. And we continue to do professional education. And then we have 10 scientific committees and working group, and we have part of this really nice community. So thank you to all and for time, and looking forward to your submission to GEO. You will be sure that you will get cited very soon and very wide, because our social media guy, they are very aggressive and they are very good and young, like I hope all the people that will send us your paper. Thank you very much.
Thank you very much, Professor Saffagnini, for sharing with us all of these details of your journal that probably a lot of us didn't know before. So unfortunately, we are a little bit short of time for discussion, but I think we cannot miss the opportunity to discuss with the 3 editors-in-chief we have in the room. So I think we have room for a couple of questions, and I will let some of my SLAR panelists to ask questions. Camilo, please go ahead. I know you have a question.
Thank you. The presentations were really good. I think we all, as authors, we have sometimes we face difficulties in publishing, because especially here in Latin America, I can say I come from Brazil. We sometimes face difficulty in publishing. So I would like to know what do you recommend as a structure in our universities to increase? I know it's a really tough question to answer shortly, but what are some tips you can give us to increase our publication rate? What do you really need to have a structure and to increase our publications?
I seem to be blowing out all the electronics here. I'll tell you, one of the things that I'm still a professor at the university, and one of the things that I do is I lead the journal club every month. And I think this is a very important part of building towards publishing. Our residents get very well grounded in critiquing published articles. And I think by doing so, when they start to do their own research, they're more aware of all the pitfalls and all the mistakes that can be made. And they have models for some of the highest level publications that they can try to model themselves after. So I think that's one way that I think is very good as far as educating people towards getting published. And my other comment would be just to keep at it. Fernando mentioned the importance of prospective research. I think prospective research is always going to be higher quality and have a greater chance of publication, even though obviously it's sort of a delayed gratification. You have to plan it and then you have to wait sometimes years until it's finished. But that's another way. Those are just two suggestions right there, and keep trying. Don't be discouraged. The last paper that I submitted to AJSM before I was lucky enough to become the editor was rejected by Dr. Leach. So believe me, everybody has lots of rejections. It's hard to get things published. And so don't get discouraged if you're rejected. If you keep working at it, you'll find a place for your paper.
If I can add something, I totally agree with Bruce, because I do the same now in Rizzoli. So we have the journal club each month where the residents can follow up about the paper that has been published, and then they know what are the defects of some paper and what are the advantages of some paper, and so they understand what are the things that you should really pay attention when you do and you try to write a paper. And I really think this is very important for the young people. We need to educate the young people that to do a good surgeon, you need to have the capacity to do research and to understand what we are doing and how you can improve the results of your surgery. And this is just educating them that you need to have some idea and to follow the idea and to do in a prospective way to evaluate their results. This is the way.
Thank you very much for your responses.
The problem in Latin America, our practice is clinical practice always. We don't have enough time to research. And I think that the change is going to be more time to research and doing our clinical practice. So we all have to work with the young researchers to do research and then publish. And the clinical practice is one of part of our work. It's not only the only part of the work. So I think it's cultural, no? The culture is in Latin America is the clinical practice.
I think we have a question from the auditorium. Go ahead, please.
Hello. Thank you all for the classes. It was all brilliant. My name is Pedro. I'm from São Paulo, Brazil. And I have a doubt in our academic, I work in a university over there, and we try to publish a little bit. And we know it takes a long time since you write the paper and until the paper is published. What do you think, sincerely, about the preprint in terms of at least receiving a DOI number to certificate that your paper will not be copied? I know American Journal don't like preprint, but what do you think about it?
Me either.
Well, that's an interesting topic, the topic of preprints.
Yeah.
I can understand from an author's point of view that they want to get their work out there before it's even reviewed. And, you know, some journals are very open to it. I can tell you our position on preprints is that we have a very limited number of papers that we can publish, and we want to present papers that information that has not already been out there in the public. And that's why we don't allow for our journals papers that have been published in preprints. There's also the issue of the article of record. If there's an unreviewed copy of that research out there and then it goes through many revisions and you publish it, there may be some confusion about which is really the version of record. So those are the reasons we have made that decision. Other journals freely accept preprints. I'm a little concerned just as an individual that it's sort of the Wild West out there because almost anything. And I will also warn you that we've had the experience of authors not knowing that their articles were published in preprints. Some journals, if you submit an article to it, someplace in the fine print, it says you agree to have it published as a preprint. And then if you change your mind or if it gets rejected by that journal and you look elsewhere, you may find out you're not qualified because you've already been published as a preprint.
Okay, thank you. But as an action to create a DOI number and it's not safer for the author. It's not or no?
Well, Donna maybe can fill in here, but I think you have to really have a published article to have a DOI. That's for those who don't know what a DOI is. It's a number. It's like the social security number of your article. It's a unique identification number, but you can't really have it until the article is published. I guess maybe I'm antiquated, but I think in orthopedics, maybe it's a little less important because we're not such a rapidly moving field as maybe some basic science fields that we're worried that someone is going to steal our research.
Okay, thank you.
We have another question. I think it's going to be our last question to respect the schedule of the meeting. This is a fascinating topic, but we don't have any more time. So please go ahead with the question.
I have a very controversial question for you, Bruce. I think the designs must to be very independent. And don't you believe that an open access art journal that the author pay for publish must be considered like a bias for the science?
Well, I would disagree with that. I think it could be. We all know that there are so-called predatory journals out there that basically exist just to collect money and publish everything that's sent in.
Okay.
So I certainly wouldn't respect anything that's published in one of those journals because there's no real vetting process. Basically, everything where the authors are willing to pay is going to be accepted. And unfortunately, sometimes the least sophisticated authors are the ones that are victimized by those journals. But in the quality open access journals, there's the same peer review process, the same selection. And I don't think that it's a conflict of interest, but it's always a potential issue. I think it's a very important question you raised, Pablo. Certainly when I'm going over the papers that have been submitted to OJSM, I know, well, if I accept a lot more papers, we'll make a lot more money, right? And we'll be able to pay Donna more money and everything. But on the other hand, then we won't be a very good journal. And I want OJSM, and I'm sure Stefano feels the same thing about JEO, and Fernando feels the same about arthroscopia, that we want it to be a high quality journal. So we're not going to just accept papers so we can get their money, but there are journals like that for sure.
Yeah, great, thanks.
Thank you very much to the attendees and the speakers for your time and participation in this symposium.
Thank you. Thank you. Hi, Bruce. Ciao. Very good.
Bien, buenas tardes a todos. Estamos aquí reunidos, como sabéis, porque vamos a compartir un workshop sobre prótesis de hombro y concretamente sobre herramientas que podemos utilizar en nuestra práctica clínica diaria y que nos pueden hacer más fácil el manejo de esta patología de pacientes con una articulación ya destruida en la cual la única alternativa terapéutica es una prótesis de hombro. Yo soy Emilio Calvo, trabajo en Madrid, en España. Es mi primera vez en Colombia. Si era un colombiano, tienen ustedes un país maravilloso, porque estoy sorprendidísimo de la belleza del país. Vine el viernes pasado.
This is my first time in Colombia, and I came last Friday. I'm sure that I'm going to have to come back, and I'm very pleased to be here. I'm fully devoted to shoulder. I do post-medicine arthroscopy, and I do open surgery and orthoplastics. And I'm devoted. I did a fellowship in the use of exposed medicine, and then I geared towards shoulder surgery. We have several tools, and when we cannot do because there's because the joint is destroyed, we resort to the prosthesis, and there are several companies. Wright bought a French company, and then Wright was acquired by Stryker. So at present, Stryker, they have the most powerful portfolio on the market. And I want to express my gratitude for allowing me to share my experience with you in the management of these processes. I wouldn't like that to have this a master class. We all learn on a day-to-day basis, and I have learned from people where I have shared this type of auditoriums. Feel free to raise your hand, whether to ask any questions or even better to share your experience, because maybe some of you may have the experience or may have more experience than me and when managing these problems, and I'm sure that we can all learn from each other. So the portfolio of the Strike is quite powerful, and there is a tool that is extremely useful, which is called Blueprint. Blueprint is an application that can be downloaded on the computer of each person, and you can do a pre-operatory planning in terms of what does the patient require and how to manage this grafted. This is extremely useful, and for many years I have done this type of art talk. And I've done this based on my knowledge, the anatomy, and the utilization of Blueprint that changed the way I work, because this allows approaching in a more accurate way. The surgery is faster, and the outcomes are better for the patient because we avoid errors that are unexpectedly found. So I would like, in this first part of the presentation, I would like to share with you the principles, the key principles in order to do a pre-operatory penetration in a patient with a humerus arthropathy. So if we begin with this. So this is the problem that we normally find. There is a joint where the patient has his anatomy completely distorted, especially in the glenoid, where it is very difficult to place. There is a very significant bone loss, and the anatomy has been altered in the posterior area. For many years, it was a prosthesis, an anatomic. We will do a coding, and then you can see that these type of issues, they fail because of the loosening of the component.
Por tomografía computarizada preoperatorio, donde no tenemos hueso suficiente para colocar un implante, y hacer probablemente una prótesis anatómica en un paciente como este supone un fracaso del tratamiento quirúrgico. Pues bien, para ello podemos contar con Blueprint, que es una herramienta que nos puede
For
ser
this,
muy
we can have Blueprint, which is a very useful tool to therapeutically address these cases. This is the case that I mentioned before. And we can see how, after the calculations, we can look at the mobility of the patient, following the recommendations of the application or the software. And we can see how this can be done with a metal implant or a bone implant by simply taking graft from the head, and we can see how the anatomy of the glenoid can be reconstructed using autograft from the head. So this is the example. What are the objectives of 3D planning? First of all, we need to choose the correct implant for each patient, and in second place, it's important to ensure that the implant is positioned and seated correctly to have the best clinical result, to avoid complications, and above all, to increase implant longevity. As you know, there are prosthesis, anatomical prosthesis and reverse prostheses, and the anatomy is completely different. And so we're going to look at this in detail. First of all, we're going to analyze the key points for the implantation for the anatomic glenoid side. So first of all, you have glenoid loosening, which is a problem. Another key point is avoiding reabsorption. So excessive burring of the chondral bone.
prótesis de rodilla o de las prótesis de cadera.
Many of us have thought that in hip or knee prosthesis, we need to have blood in the glenoid. That's not the case. You need to avoid the cartilage layer. You need to be conservative for the chondral bone because movement of the glenoid component is related to overbearing. So for that, you need to have a good match between the prosthesis and the bone receiving the component.
Como veis, esto es una imagen que
So
veis
there are
aquí
cases like this one in the image at the bottom, where you have the cut and how it can coincide with the implant. So we need good seating, but in the axial cut, you can see the seating of the implant, which is weaker. So we have to resort to a second implant to better match the glenoid component with the underlying bone. We need to take into account 3 factors for a good implant. So the version, the orientation, and the inclination. So the paraxial orientation in the coronal surface and the sagittal plane. So we know, and it's clear in the literature, that excess retroversion of above 10 degrees leads to issues. So if we want to have higher degrees or use higher degrees, this will lead to failure. So we need to think about the design. This prosthesis will not work, so we probably need a design that adapts to these characteristics with posterior augmentation to increase that retroversion. As for orientation, the axis of most stability is the one that coincides the tubercle with the inferior part of the glenoid, where the lateral pillar of the scapula ends. So usually the human eye tends to put the implant in this position. So it's important to understand, and this is what we usually say with the tool, that we should follow the axis between the glenoid tubercle and the inferior part. As for the inclination, any orientation with a higher tilt, as with the inverse prosthesis, is a risk for loosening, early loosening of the glenoid. So here we can see how it was. The glenoid component was implanted with a higher tilt, or superior tilt, which can increase superior migration. This variable allows us to control preoperatively through the blueprint tool. So anatomically, the key is to preserve the chondral bone, to never implant prosthesis with a higher retroversion than 10 degrees. We should orientate it behind the scapula and the tubercle between those, and seating should be higher than 95%. This is something we know. We always need to base this on sensations beyond the human eye. The blueprint tool allows you to understand what kind of milling you need to do for the seating, and for the contact of the prosthesis with underlying use can be higher than 95%, and this is critical, as I was saying before, where loosening happens in the glenoid component. As for the anatomic rate, we know that the humeral component, if it is badly implanted, in the short term, it will lead to the glenoid loosening. This is why it's important to perform an adequate implant of the prosthesis in the humeral component. So this will lead to the inclination of the anatomic collar, anatomical neck, and then we need to control the humeral head size. So we need enough radius for the soft parts, but without making it too big, otherwise we will lose mobility, and there will be no effectiveness in the rotator cuff, and there may be early loosening of the glenoid. Then with the reverse case, this is experience that I have in my own professional career. We used to implant in quite difficult situations. We needed not just glenoid supplements, but also we had to manage the bone with great skill to try to avoid early loosening of the glenoid. Despite that, there were many cases where we were unable to add a glenoid component. We had to use boom and run techniques and leave this component in its place. With the reverse method, this issue has changed. The number of reversals are increasing the most, and anatomically they are reducing. In Europe, we are ahead of the US. As you know, the reverse method was approved by the FDA much later than in Europe, and the reverse method is increasing exponentially, more so than in Europe, so in the States. And many more anatomical ones take place in the US. In the future, this will be very different and much better than the anatomical method. So the reverse prosthesis has a complete different process. It doesn't depend on the rotator cuff for lifting, only for rotation, and it has a constrained design that means that the patient can effectively lift the shoulder. This was achieved by extending the center of rotation of the head so it could have enough of a competent lever. And as for the humeral component, there was a risk, as you can see in this video. In this video, we can see how it continuously brushes against the humeral component with the lower edge of the glenoid. Initially, we thought this would have no repercussions, but we've seen that it actually does. So obviously, the glenoid component has a risk of loosening, and there is an evident short-term risk, which is for the polyethylene to wear down. And this happens due to the humeral component. If it fails, then the reverse will also fail. So let's see how we can avoid this. We were talking about notching before. It can be achieved by descending the component. So the lower the position, the lower the risk of notching. The other possibility is using eccentric glenospheres with a lower offset to reduce the risk of contact between the polyethylene and the inferior edge of the glenoid. And in third place, with lateralization, this means that we bring the center of rotation outwards, and we can achieve that either through implants that have supplements within the implants to do that, or with bone graft taken from the head of the humerus. This is something that Blueprint helps us to do. It will tell us if we need lateralization or not. So we can use lateralization or not, but it also tells us whether it is suggested or not. So once again, in this way, it's very useful for planning before the operation. We can use grafts from the head of the humerus, or also through lateralization with metal, using supplements in the metal component, as we will see next. So this is how Blueprint is suggesting that we can achieve lateralization. We can see that it has a superior orientation, and this is how we can lower the center of rotation for the component and also correct that superior tilt to achieve good contact with the implant and avoid kinematic issues and loosening. So we're going to talk about another issue when there is superior erosion. We have the Leupobat classification from E0 to E4 and how you can frequently produce superior erosion because there has been an issue with the humeral head, a deformity. And we know that this inevitably and involuntarily leads us to put the component looking upwards, so with a superior tilt, and obviously we know that this carries a risk of instability. Therefore, this should be avoided completely. Once again, Blueprint will tell us how to avoid this. So as a point of reference, we should take the line of the spine of the scapula, and it tells us how much of a supplement we need to add to correct that superior tilt. So here's an example of a base plate that has a superior block that allows us to correct it in a very simple way with preparatory calculations of the superior tilt of the patient. Another frequent issue is retroversion. So we said that there may be retroversion, but the prosthesis, the glenoid component, needs to not have retroversion, and we need to be able to correct something that frequently happens. So this posterior erosion that we mentioned before, we said that you shouldn't add more than 10 degrees of retroversion if the anatomy of the patient kind of obliges us to add an anatomical component. We will have to use a reverse prosthesis, and this is what has happened here. These are calculations that Blueprint gives to us, and it indicates the block that we need in this case in the posterior and superior areas to correct the deformity that the patient has arrived with. Preoperatively, as for the humeral component, it can be 145, 135 degrees, and our philosophy is that we want to divide the incline of the humeral component and thus increase the lateralization. And we can achieve better extension this way, and they can better bring it backwards and have external rotation, which is important for daily activities. So the rule is quite clear for inverse prosthesis. Prosthesis, inclination between 0 to 10 degrees, retroversion of 0 degrees, inclination higher or equal to 10 degrees, inferiorization to achieve contact between the prosthesis component. Seating should be more than 80% and the angle should be between 145 and 135. Sometimes the anatomy is completely distorted or enormously distorted, and the calculations that Blueprint gives us are quite difficult to do. There are a series of guidelines that allow us to correct around 15 degrees or inclination of up to 15 degrees in terms of modern instruments, but in some cases it's impossible, so it's very hard to calculate that. And we know that the human eye is imprecise. So for that, we are able to design these guidelines, personalized guides for each patient. And Blueprint does the same thing. So it gives us the orientation that the axis should follow, that we use for execution to prepare the glenoid. And if the anatomy is very distorted, especially in complex cases, it is very useful to be able to have a template, a personalized template for the anatomy of the patient that will allow us to be guided in a very simple way preoperatively. I have a case here. You You may have seen that the title of the presentation is B2. It is very frequent, this case. These patients have a static dislocation of this shoulder and they have developed arthrosis, glenohumeral arthrosis. If you have any questions about this, then before we analyze this case, we can talk about any queries that you might have or any questions or experiences that you have that you want to share. Dr. Toro? That's a very good question. Those are two excellent questions that I can talk about from my experience. As you have, I have been implanting prosthesis without any planning beyond a CAT scan. And in the image for the reconstruction, you could say, okay, well, I need to add incline, or I need to do more milling, etc. And that's it, because the reverse prosthesis has very good clinical results. But then we have to look at survival in the long term. With Blueprint, there is a learning curve. It's quite a short learning curve. It's very simple. It's an application that we are used to using. When we started to use Blueprint, I used it for difficult cases because I thought that I didn't need it for simple cases. And the more you use it, the more you'll use it with simple cases. And if you examine and think, okay, there's a case and I would do this way, if you're an experienced surgeon like yourself, you do that. But then when you look at the case through Blueprint, you'll see that you're right, and that effectively it doesn't mean that Blueprint is, panacea, or the perfect solution. You'll see that you're right, but it does add knowledge that says, okay, well, I hadn't realized that there was a slight superior tilt. I was going to repair that posterolaterally. So sometimes it gives you these little nuances that provide excellence to the implant of the prosthesis. So it is useful, but without a doubt, it's definitely very useful in complex cases. What's the second question? Okay, the PSI. Okay, I use a health system. In our health system, costs are very important. So the reverse prosthesis is obviously not a cheap implant from any company, in any company. So this means that I have to be quite strict in terms of what I use in my patients. PSI is quite useful. I use it only for complex cases right now. So in conventional patients with an easy case, I do not use it because the tools, so both the instruments for this prosthesis and also its potential, the potential offered by Blueprint, allow you to do this. In the future, it may be used more and more. I have friends in the States that use it a lot more than I do, but I think this just depends on each person's capabilities in terms of how to address it, and also the type of coverage that each patient has, or economic coverage. Any more questions? Do you want to see this case? I want to ask how many of you use reverse prosthesis regularly? How many use Blueprint or these kinds of preoperative tools? How many of you navigate with prosthesis? So this is the ratio more or less around the world. If we were to do the survey in a year, I'm sure that the ratio or the percentage of surgeons that use Blueprint would be higher, I'm sure. And I think that that's more and more the case. Blueprint has provides an enormous amount of help, but there's also a danger to it, and this is that you can't believe in it 100% or blindly. It works very well for conventional cases. It works very well for significant defects, but there are situations in which there may be a bad union after fracture where it can trick you because the soft tissue has been altered quite a lot after a fracture. So obviously, as in your own case, that requires the experience of the surgeon who needs to resolve it. But even so, it's very useful in these cases as well, because you can determine the specific issue, you can look at the problem in the glenoid, and you can have preoperative analysis as well, and I insist whenever there is a severe alteration, such as an incorrect union, you do have to use the tools that you generally use.
Sí.
Yes. Sorry, he's not using a microphone. Are these values used in any way to modify your planning? Yes, of course, without a doubt. So when I use the tool, what I do is I plan the type of prosthesis that I want to implant with the supplements and things. Then you also plan according to the results. So it doesn't just depend on the bone anatomy, which is what Blueprint contemplates. But if you use Blueprint to have a higher possibility to correct the bone anatomy, then this is an aspect that you can eliminate. In the softer parts, you can decide what to do with them. So it doesn't analyze those parts, but I mean, you can do that way.
Si no tengo tanta rotación, cambio algo.
But what do you look at specifically? If there's not much rotation, do you use the numbers to modify that? I use the numbers to have the most precise orientation with the greatest contact possible between the component of the prosthesis and the host bone. So that's what I use. Once I've done that, I can manage all of the parameters to see how to achieve maximum mobility. I prioritize seating, so the contact,
La reconstrucción de los defectos para corregir
clearly, and correcting the deformations to correct incline and orientation. Once I've achieved these two objectives,
implante para conseguir
I
mejor
play
movilidad.
around with the implant to better locate it. So that's at the preoperative level. Then intraoperatively, I mean, we all understand the different ways that you need to tie it to achieve greater mobility, and that's part of the art of the operation. And obviously that's not provided by the tool. There is another issue as well that we're debating at the moment. I was a little bit pessimistic in this area, and I was able to collaborate in a research project to assess the educational capacity of Blueprint. So for residents or for young surgeons who wanted to be guided through shoulder surgery. So the ability of the tool to teach other patients in terms of how they should execute it in the future. But I thought that we needed a learning curve based on conventional surgery and then use Blueprint. But actually, there is a person who joined us last year on the team. They did a fellowship with Pascal Bello, and one with me and then with Pascal, and then came back to my team. And this person is, of course, a lot younger than I am, and he does not ever ignore planning. And I thought, okay, but you know, there are no bone defects, it's a very simple case. He says, no, but it helps me learn, and that's true. So within his, he's using Blueprint within his learning process, and probably more for some aspects rather than others, but as a learning curve, in order to work with the tool and to correctly implant prosthesis, it's definitely very useful. So that's definitely the case, yes. So in your clinical practice, have you noticed the effect of planning using Blueprint? I'm sure that before Blueprint, you performed a lot of operations without this planning, and I imagine that these cases are mostly good. Have you noticed any real changes in the results of your patients after using Blueprint? Well, I can't really say because I haven't analyzed that, but it would be interesting to do that. I have, I don't know, randomly operated many people, 50 with Blueprints, 50 without, so it would be very interesting. And the utility of Blueprint has been demonstrated in its evidence in literature. In my experience, coming back to this, I can't say that it's better with Blueprint because I'm sure that a lot of people have more experience and don't use Blueprint, but I have had bad results, as everyone has, and I'm sure there are a few patients that I thought were doing very well. All of a sudden, in post-operative testing, I've noticed that they have a superior issue, and this has occurred as it occurs to most people. And the greatest help that I find in the tool is that if I look at the case and I look at 3D reconstruction and think, okay, we need to do this and this and this. When I use Blueprint, it says you need to do this and this and this and that. And so I feel happy because as a surgeon, I'll realize that these nuances that you hadn't taken into account, then all of a sudden you do take them into account after using Blueprint. Or sometimes you think, okay, I think I need glenoid retroversion and we need to add a 15-degree block or something like that. And then you think, no, actually 10 would be enough. And then the Blueprint shows you that that's the case. So why would you mill 5 degrees that you don't need or that the patient doesn't need? So in my experience in preoperative planning, you do see these little nuances that you had missed. So that's very clear. And I know many experienced surgeons that use it systematically for this reason, because of its reliability. It almost gives you a bigger peace of mind. Well, in very complex surgeries, if there's very high glenoid destruction or severe issues, this would be critical because, like you, I have performed many complex surgeries, and when we did the CAT and detailed the blocks and things, you do okay. This allows you to be more precise, however, because it tells you that the block should be 25 degrees, and so you can measure that. And it's not as it used to be before. Felipe. Sorry, we can't hear the question. I use a graft. I think it's a fantastic alternative because before blocks existing, I used to use graft and the results were very good. And the literature shows that results are good. You need to know how to use them as well, because replicating anatomy with the graft, not all patients need the same supplement. So you do need to play around with that to understand what kind of graft. There's a degree of art needed or experience to do this.
Mucho más sencillo, dices, bueno, tengo
And the
que hacer un
metallic implant is a lot easier to use. So if you need to create a supplement of 8 millimeters or 10, then you can do that. And do you lateralize when the glenoid does not have a defect? Yes.
Sí que en mi experiencia he estado muchos
Yes,
años
in my experience, I did not lateralize for many years, following Paul Gammon's technique with the center of the glenohumeral head. My patients were doing okay. We know that inverse prosthesis did well in terms of elevation or lift, and there were great results in terms of improving pain. And we said to patients, okay, well, you may not be able to do this or that, or you may not be able to reach the back, or you will only reach this position. And so this is what we said to our patients for many years. Patients improved and felt very happy because pain was removed and lift was recovered, and they could more or less rotate. The main difference I have found with the lateralization is internal rotation. External rotation too, but mainly internal rotation in my experience. So patients can lean back a lot more, and it's very useful for women to put on their bra, for example. This is something that seems to be a tiny issue, but it's the main difference that they notice after lateralization. There are studies with small increases that show that rotation improves, but I've definitely seen this in my patients. Yes.
Ya, perdón.
Hola, sí.
So someone has a question over there. Hello. Yes. With regards to the lateralization and rotation, how do you manage the subscapularis in lateralization? That's a great question. The subscapularis, as you know, has been ignored a little bit in this kind of surgery, saying that, there was no problem if you didn't reinsert it. But it's true that it's difficult to reinsert it sometimes, but it's also true that there is data that even though it is a little bit old, there is data to suggest that even if you do reinsert it, 50% of the time it will not scar and become loose. So this has contributed to that to people ignoring it. So for years, I was a follower of the same policy of ignoring it, but I try to be a lot more careful now. So I always reinsert it whenever I can. And so I focus on releasing it, so it sits well, and I try to reinsert it at the point where I detached it. And if I can't, then, or because it's a complex case or something, then I try to stitch the edge of the stostomy area to try to reinsert it. So I do try to reinsert it, and sometimes in the reinsertion, sometimes the reinsertion will disappear over time, but I try to be very careful. There are also surgeons who say that if you do that, you will improve strength with internal rotation. So this makes sense. The reverse prosthesis is not for strength, it is for mobility and to eliminate pain. I think there's a question over here.
Escapular, ¿no? Sí, pues el abordaje que hago es ese. Vamos a ver este caso. Mira.
So that's how I approach it. We're going to look at this case with a B2 prosthesis. You can see
la parte anterior.
It seems to have preserved the anterior part of the glena, and it's quite severe, as you can see here. With an anatomic prosthesis, the only alternative that you have is to overmill the anterior part. And the effect is so important that you wouldn't have enough bone to support the glenoid, or you can use a posterior supplement. And the results are a little bit controversial because there aren't too many that have been published. They're relatively new and not many have been published, because this issue has been resolved quite well with the inverse prosthesis. Even with those who have preserved their rotator cuff, or if it's irregular or it's significant, we need a reverse prosthesis. That is very clear because the results will be much more predictable. So this is what blueprint says. So we can see the glenoid component with a supplement and a superior supplement, either with a block or without one. And this is the technique that I used. So this is the patient. This is the presentation or the exposure of the glenoid, as you can see. It's going quite slowly. Okay. So it's going at a different speed on my screen, but here we have an eccentric burr at the lower part to avoid notching, trying to ensure that the metal is exactly at the same level as the inferior edge of the glenoid. So with the cutting or the milling, we can mill the periphery of the graft. Sorry that it's going a bit slow. It looks good on my screen. So we're cutting or creating the hole for the central part of the metal component, and that can be done with this needle. So you mill the periphery and make holes to stimulate it at the subchondral level and to stimulate the growth of bone and to improve the attachment to the bone. Once we've done this, we can implant the prosthesis. In this case, you can see that it's a bio-RSA. So what we're doing is we're building the glenoid component with bone, but this can be done with metal as well, and it would be perfectly valid for this case. And we can add the sphere, the component, the glenosphere, and whenever I can, I use the eccentric component just not just for lateralization, but for the center of rotation of the humeral head. We're implanting the shaft here. It's quite short, as you can see. This is the platform. It's an online design. And we can see here the polyethylene insert. And what I wanted to show you was the need and possibility to reconstruct these defects with B2. Well, without a doubt, the best alternative is a reverse prosthesis, although the rotator cuff has been preserved.
¿Cómo llevas el planeamiento que haces en
How do
Blueprint?
you plan? How do you bring the planning and blueprint to the fact to the event of the client of the patient? This is a customized guideline for the patient. With blueprint, you need to authorize this from the factory. I asked this from Stryker, and this is in complex cases when the defect is not so important. Then there's a guideline. I don't know if it was something that you saw at the beginning. You can see the image. Can you see the image? And this allows for 10 degrees of mobility upwards or downwards, and this also allows using allows the anterior and posterior movement. Then, in order for you to have precision, this is the guideline that I was mentioning before. You can see the different guides. You have to place it perpendicular. This would involve lower tilting, which is how I normally do it. You can do it upwards, and this guide, despite the fact that it's not designed for that purpose, it can be installed in a perpendicular manner to do a milling. So it has that use. In complex cases, you need to get a specific guide for the patient. That depends on the process, but this involves a very evident benefit. Any additional questions or any additional comments? Okay, so that's it on my part. Thank you all for your support.
¿Ok, así o no? Sí. Sí. Ok, gracias.
Maybe por el programa, moderador, ahora hasta las 3.
Esta presentación la puede hacer desde el podio, porque no hay cable.
Okay, let's try.
Más, si quieres deja de compartir ahí. Deja de compartir.
Okay, 2:05, I better go. Vámonos. Go. Okay. Can you put it up there?
¿Qué pasó? Aquí en el micrófono. Ah, él fue el que dijo que iba a hacerlo desde acá abajo. Mire, la mesita no. No, pero es que la podemos poner si la tenemos aquí. No podemos poner computadora acá. No.
Hola, buenas tardes. We're going to get started. I'm Robert Marks from New York. I'm going to run the video from over there because it's working better. And I'm going to speak English. Perdón. Mi español no. Bueno.
Sorry, my Spanish is not too good.
So I'm going to speak English. I'm still learning Spanish. So I'm going to get started now. Okay. I'm just going to start the video. So the first part of the operation that I thought is important to see is the timeout, which we did. Oh, this one? Oh, sorry. Okay. The first part of the video that I think is very important to demonstrate is the surgical timeout. I don't know to what degree you do the timeout in your countries, but at our place, I'm a big advocate of the timeout. I think it's very important to help keep patients safe. We have the nurse who's on the left run the timeout. Everyone stops what they're doing in the room. Everyone introduces themselves. Everyone in the room says what their name is and what they do. So I say Robert Marks, surgeon. The nurse says, that's Genwani Sanchez. She says, Genwani Sanchez, circulating nurse, and so on. That encourages people to speak up and be engaged in what they're doing if they see a problem. We confirm the patient's identity, what we're going to do, the consent. We confirm the surgical site is marked. So it's our last chance to make sure we're operating on the correct side. We make sure we have the images. And then discuss any other things that are important for the case. We check that we've given antibiotics within the hour and tranexamic acid, which I use for all ACLs. So it's another thing to make sure we don't forget anything. And this is all written down. So if the nurse is doing it without reading it, I say, please read it. It's not that you don't remember, but by reading it, you can't forget because it's written down. It's impossible to forget. And that's it. It's not working. No. So we look at the timeout together, make sure we have the correct side. Everyone points at it. So this is my technique for patellar tendon autograft ACL reconstruction. We check the Lockman and pivot shift, confirm it, and when that's positive, we go ahead and harvest the graft first. So first I just cut through the skin. Once I've done that, I use a technique of lifting and cutting repeatedly, because if something comes up in the air, it's not paratenon. See, if you can lift it like that, it's not paratenon. Once you've cut everything that you can lift, you see there, not much coming up. When you cut everything, then you're down to paratenon. And I like to preserve, see, they were on paratenon. I like to preserve the paratenon carefully. I'm not going to show the whole dissection, but there you can see I've lifted the whole paratenon layer up, and we close it at the end of the operation. We then cut the paratenon where it's continuous with the prepatellar bursa or prepatellar fascia here, and we divide that the length, and we close that also. We bone graft the patella at the end of the operation and close that prepatellar fascia or prepatellar bursa or continuation of the paratenon, whatever you want to call it. We close that over the patellar bone graft at the end of the operation. Now we have the patellar tendon exposed. I mark the center of the tendon. And then I use a double cutting knife. I use 10 millimeter plugs. We take an 11 millimeter double cutting knife. This is a disposable double cutting knife. And you just slide in line with the fibers. As soon as I hit bone, I stop. If you force the knife against the bone, sometimes it pulls the blades too close. So I do the rest with a 15 blade, about 1 centimeter apart, 10 millimeters apart, because that's what my bone plug is going to be. Then you can either measure, or I just check with my finger. I know what 2 centimeters looks like. I want to take about a 2 centimeter bone plug. I take a little extra because then we use the extra to put back in the patella. We bone graft the patella, as I said. So if it's a little longer than 2 centimeters, that's okay. And then we use the saw. This patient was a American football player's bone was very solid bone. So it took a while took longer than usual to saw through because it was very hard. You can see I'm not quite vertical. I'm like 10 degrees from vertical, not just slightly converging, only 10 degrees converge. So it's almost vertical. And you have to feel the blade go at least a centimeter deep. And then we do the same thing on the other side. You can see we have the tendon clearly exposed. And you want to see right where, so that you're not detaching any extra tendon, either from the graft or the remaining tibia. And we just make a little line. And I should be about 10 degrees from the vertical. And then at the bottom, I go inwards. You see, we don't cut outside the verticals, not medial to the medial cut and not lateral to the lateral cut to avoid a stress riser on the tibia. We do the same thing in the patella. And you see I'm aiming proximal slightly, angling slightly proximal. And then with an osteotome, we free it at the top and then it's loose. So cut all 4 sides. Once the plug is loose, we just use the mets to release it from some periosteum and fat pad. and then the graft is free. Then we use a vancomycin soaked gauze right away on the graft. The more it soaks in the vancomycin, the better. So we start the soak right away. And I have my physician assistant hold the graft. So I encourage excessive paranoia when holding the graft. Okay? You can't be too uptight about the graft to hold it. One time when I was a resident, I saw it fall on the floor. Well, I didn't see, I heard it fall on the floor. So not since, and I want to keep it that way. So very excessive paranoia. And then you see here, we mark the graft on the patella. Make sure, some people have a short patella. Make sure your horizontal cut is not too high. And then we just mark it here. And this cut is a little different. It's 45 degrees. And I curve away at the bottom near the tendon, not to detach the tendon. So there you see 45-degree cut. And you have to feel a little give. It goes through the cortical bone and it gives a little. It slides through just a little bit. If you don't feel that, the bone will not release. It won't come out. So you have to feel a little, yeah, there, you see that? And there I'm going, there, that give, you have to see that. You feel it too. And then we do the other side. Again, 45 degrees, but curling away at the bottom. You see at the bottom, I'm aiming a little away from the tendon, right there. See, yeah, that little curve, just so you don't detach tendon from the graft. And there you see, I'm just plunging through. There's just a little bit of a plunge there. That's it. And one more time, maybe at the top. That's it. Now it's free. Now the top, we do the same thing as I did in the tibia, where we stay inside the vertical lines. So I'm inside there. One more time on the other way. And then similar to the tibia, we aim a little distal. So see, I'm aiming a little distal and I'm backing out so I don't go too deep. You want to feel it give just a little. So you should just, there it was, you see, so it just plunges just a little deep. And if your saw is good, it may not come out that easy, but I never use a hammer on the patella. I just pry it out with an osteotome. Now I'm going to skip over the patella. You see she has two hands on the graft and we're very carefully handling it on the back table. And after we put sutures in one end, we'll clamp it to the table. But I'm going to skip ahead a little bit here. Hopefully I can. I'm going to skip the preparation. Preparation is very, very important, but if anyone wants, I can share this with them, but we're going to just move along just a little bit here. Okay, so we mark the graft where the sutures are. So we don't want to put the screw where the sutures are. So we want to put the screw where there's there, that one we want to put where the sutures are not. So where it's marked is on the, we put the tibial plug from the patient's tibia, we put in the femur. So I put the graft upside down because it's a little easier to put the screw into the tibial plug. It's better exposed. We mark the graft lengths as well. Now I do in the femur only an 18. So does everyone understand? I just want to check. I take the tibia plug and put it in the femur tunnel. Everyone understand that? And instead of 20 now, I do 18. It passes easier through the knee and it's long enough. Okay? Okay, so we measure all the lengths and the overall length. So you see that's 20. Now I do only 18. And you see it's bulleted. The tip is a bit like a bullet. It passes easier, not square. Then we put it in a vancomycin soaked gauze as long as possible, at least 5 minutes, but probably more time is better. 15 or 20 minutes is probably better. And see, we save it in a bag. So if God forbid the bag falls, it's still sterile. So mucho paranoia for the grefo. All right. So then we start the arthroscopy here. we confirm the torn ACL. And the ligament's clearly torn. So what I'm going to do now, I'm going to skip the diagnostic arthroscopy and just advance a little further. So now we're removing the ACL remnant. First, I start with a biter, get the big pieces chewed up so the shaver goes more easily when the biter has done a little work. And very important to remove all the graft from the tibia anteriorly. See, now the light source is over at 9 o'clock, but I will change it to make sure we get everything. Obviously, you have to remove it from the femur so you can see. We got to get that out of there. I like to do not a notch plasty because I don't remove any cartilage. I don't take any cartilage, but I want to get rid of all the graft so I can see. And also in the front, so I don't get a cyclops lesion or cyclops. I don't want that. So I get rid of pay a lot of attention to get rid of all this stuff. So you got to get rid of that. And then of course on the femur, and no cartilage is removed because God put the cartilage there for a reason. We don't need to take it to do the surgery, but we have to get rid of all this torn ligament because it's in the way. So we clean all this out. I want that muy limpio. Okay. So we get rid of all this stuff. And then we get the cautery there. We'll clean all that off too. You can see well now, but I want to see exactly the bone. So we use the thermal ablation device. And this is just the surgical exposure, just to see. And, you can see when you make your portal right next to the tendon, I can see perfectly without a 70-degree scope, without cutting away any cartilage. And here I'm just tickling the bone gently just to get rid of the little ridge, the intercondylar ridge. So we can see this is also just exposure. Just a very, very little bit of bone gets removed. Very, very little. And then I'll just check with the device again, make sure there's no soft tissue, and that's it. That's my femoral preparation. So I like to make an anteromedial portal for preparing the femur. I just think, to go transtibial, we never go make a hole by going through a bone. We make a hole in a bone directly. So I go direct. I go through the incision. If it's a hamstring, I make a new portal. About 1 centimeter medial to the patellar tendon, right above the tibia. Right at the tibia. So that I'm aiming up and I will miss the meniscus, I'll show you, even though it's right next to the tibia, because it's aiming slightly up, about 20 degrees up, you won't hit the meniscus. And I'll show you that here in the video just to make sure you feel comfortable. I usually don't look because I know, but just to show you in the video, you can see it's well above the meniscus. No, and you're also central too, so well above the meniscus. So once I make a big hole in the capsule there because the fat pad prevents water from leaking out. Then I put a trocar and then the microfracture just to give me a relative starting point. But make a big cut in the capsule or the reamer won't go in. So then I go halfway between the cartilage at the bottom and the PCL at the top. This is maybe 2 or 3 millimeters lower than maybe I would put it now, but very close. That's around where I would put it. So that's just a marker. And then I put the over-the-top guide. I used to use a 7, but then we changed companies, and now the 8 works better. I was having trouble coming too close to the back with the back wall, and it's because we had a different company and it was slightly different. So when you change companies, sometimes you don't realize the instruments are a little different. Took me a few times to realize that. So this is an over-the-top guide. I use an 8 over-the-top guide now. I drill it in about 1 centimeter. You can see there's a little bit of metal there. starts to cut the metal. So I go in about 1 centimeter and then I pull it out. And then I advance it the rest of the way about, over 2 centimeters, over, about 20, 30 millimeters. And then I check, we have room for the condyle, because with the anteromedial portal, you can hit the condyle, and this is too close, right? This is about 3 millimeters or less. So I use a low profile reamer, and I've broken a couple of them. This is just an important point. You see how the low profile reamer was chucked up quite long, like 20, 25 centimeters? Then it can break because the torque can break the low profile reamers and the pieces can break off. If you chuck it up to 8 or 9 centimeters, that shouldn't happen. It hasn't happened like that. And I do it always by hand, the femur. Solo a la mano. And then, see, not power. The low profile reamer makes a bit more of a mess, but at least it avoids the medial femoral condyle, so I prefer it. Unless there's a lot of room. If there's a lot of room, a bigger patient, when I check, I'll use the regular C reamer, but always by hand. I think it's safer to decrease the risk of breaking the back wall, the posterior femoral cortex. So I go by hand here to 20 millimeters. With the low profile reamer, sometimes I find I need to do an extra millimeter or 2. Needs a little bit more. See, just over 20. With the low profile C reamer, I go millimeter for millimeter. And then I clean out all the debris. I like to use just a suction tip, and then just by suction it goes out, and then I get the shaver in, and maybe I'll advance just a tiny bit. Here we are, just cleaning a little debris. I'll use the shaver to clean the debris. You can see I have a back wall of about a millimeter maybe or 2. We'll clean that. Again, shaver, or you can use the suction tip with gravity. With the low profile reamer, sometimes there's some bone in the femoral tunnel, so I have to pull it out with a probe. And for the tibial tunnel, I use a standard guide, and I'll use the footprint. Pretty much you can use the anterior horn lateral meniscus between anterior horn lateral meniscus and medial tibial spine, maybe a little anterior to that point I just described. In the footprint where you can see there's nice ACL tissue. And then I'll skip maybe just a tiny bit ahead here. So that's a position I like. In the center of the footprint, just posterior to the anterior horn lateral meniscus insertion. Medial tibial spine. So I grab it. If you don't hold it with a grasper, sometimes the reamer can suck it back and you lose control. So I hold it with a grasper. You see my right hand is holding it, and I have the person doing the reaming. It also protects it from going too far into the knee. Of course, the tibia I do on power. It's impossible to go through the tibial cortex by hand, or it would be unpleasant to try. And then we use the shaver to clean up. I don't know if I think I get a view of them. If I may have missed it, the view of the medial femoral condyle to show you that with the low profile reamer, we avoided it. Sometimes you hit a little bit of the front of the tibia, but that's okay. It's anterior. It's not weight bearing or anything. And then we clean the tunnel, remove all debris from the tunnel. Hey, Mosca. So we debride everything from the tunnel. And then this is important. I use the cautery to get rid of any soft tissue at the mouth of the tunnel, because that can make graft passage difficult and block your graft. So I spend a good 20 seconds, maybe 30 seconds at the most, making sure There's absolutely no soft tissue on the tunnel. It's completely clean, and so that the graft will pass easily. And then we put carrot in, plastic carrot, to block fluid from leaving the knee. Then we pass a pin through the knee. I go through the anteromedial portal, of course, the same direction. And I didn't mention, we flex the knee past 90 to create the femoral tunnel. And we do the same thing for the pin. So I don't know if I mentioned that, but it flex the knee at least 105 to even 125 degrees for the, most importantly, for the tunnel creation. And then we pass this pin all the way through the skin, of course. And then we pass the suture through the knee. And this suture is what we use for graft passage. The pin generally needs to be hammered through. I guess I don't know why he was trying to pull it through, but we always use the hammer basically. And then we retrieve the suture, of course, through the tunnel, the tibial tunnel, so that we can pass the graft. Now, at this point, I send the person to get the graft, and I always say, take your time, because I don't want them to feel rushed, even though I'm in a rush, of course. I tell them to take their time, because the difference between 5 seconds of rushing doesn't matter. And I definitely want extreme paranoia with graft handling at all times. I think I said that already, though. So then we loop the graft, remove the carrot, and pull it through. I put the color of the graft where I want to put the stitches in the visible location. And we pull through. And usually I'll use the probe in the knee here to just unlock it and allow it to pass, and also rotate it. I'll put the probe, the tip of the probe, in one of my drill holes where the sutures are to help turn it, so that I have it turned where the tendon is in the back. Now, this bone plug going into the femur is from the patient's tibia. And as you'll see, there's an area of bone next to the tendon, which is made for a screw. Like God made the tibial insertion of the patellar tendon for a screw, as you can see, because when you insert it, you have all that purple bone to put a screw in, and the screw will not damage the graft. Now, you have to have your assistant pulling hard the whole time now until the screw is completely inserted. Now the graft is in place. We just have to put our screws. But this is possibly the most important part of the case. I do it through a screwdriver. I put the screwdriver in the host bone, but right next to the graft. Right next to the graft. The knee is flexed maybe 10 degrees less than when I made the tunnel. I want a little bit of convergence. I gently mallet in the screwdriver, and then we take a nitinol guide wire. Other guide wires can break, but the nitinol wire doesn't break. I drill it in 3 millimeters at a time. If you do more than 3 millimeters, it can spin outside the screwdriver. That was a little more, but generally 3 millimeters 3 times, a centimeter. And then the wire is stuck in there, and you can slide the screw. Sometimes you can just push the screw through the fat pad, but I'll screw it through the fat pad because you don't want to drag the fat pad into the knee. Then you can't see. So I screw it through the fat pad, and then the fat pad backs up out of your way so you can see. And then I put the screw in about halfway over the wire before taking the wire out. So the screw goes about, halfway, about a centimeter. And then when I'm happy, I'm getting good bite, good purchase of the screw, we knock out the guide wire with a mallet. Do not screw it out. because if the wire's bent, it can get broken if you use the power. So you bang out the wire. If you can't bang out the wire, loosen the screw half a turn or a turn, and the wire will then come out. Bury the screw deeply if you don't want to see the screw past the graft. See, it's flat with the bone. You don't want it sticking out or it could abrade the graft. And I usually, sometimes I'll touch the graft to make sure it's secure. Usually you know it's secure and I'll just
A
pull
veces
on it.
toco el injerto para asegurarme de que esté seguro y lo jalo y no se va a ningún lado. Y luego verifico la extensión. Debe haber bastante espacio. Y ahora está asegurado de manera fija en el fémur. Me gusta fijarlo en la tibia con lo que utilizo para el PCL. Lo utilizo en todos los LCAs. Se puede aplicar bastante tensión. Craig Fennelly me enseñó a utilizar este boot. Así que es el que utilizo. Me gusta la bota. Tiene más o menos 20 libras de tensión. Ponemos en la parte medial. Ponemos las suturas alrededor. 3 veces para Ethagon. Estoy utilizando Fibron. Si uso Fibron son 4. Después lo uso la abrazadera. Las suturas están seguras. Paso a 20 libras de tensión. Eso ya lo hice. Y empiezo a hacer una moción cíclica. Debo hacerlo en extensión plena y suturarlo de esa manera para no fijarlo con una posición más anatómica. Si lo hago con flexión, puede ser difícil para ellos volver a tener esa extensión de la rodilla. Puedo volver a tensionarlo dependiendo de qué tan ajustado esté. La idea es que no esté demasiado ajustado. El asistente lo sostiene. Pongo el cable, el azul, si está en la parte tibial, no hay sutura. Este viene desde la patela. Y pocas veces es muy corto. Si es muy largo, quito el extra. Este parece estar apenas, este tapón. Y utilizo estos tornillos de metal que son muy afilados. Normalmente, si quieren utilizar este tipo de tornillos, son bastante afilados. Me gusta el metal porque se ve en la radiografía y son fáciles de eliminar en cualquier momento o remover. Siempre los he utilizado en toda mi carrera.
Nothing more. We don't have to show you the
Y
closure.
eso realmente es todo. No tenemos que mostrarles el cierre, pero sí tomo injerto del hueso que queda del injerto. Por eso me gusta tomar bastante de la tibia. Lo ponemos en la patela, en la rótula y hacemos un cierre cerrado con Vicra. Y tenemos cuidado con el cierre subcutáneo de la piel. Les pongo un brace durante 5 días. Hago 5 días en extensión. Dejo que se sane, que baje la inflamación. Y luego fisioterapia 5 días después.
Todo claro.
Okay, do we have any questions?
Bueno, muchas gracias, doctor.
Okay, thank you very much, doctor. Does anybody have any questions in the auditorium or any questions or queries or suggestions? Questions in Spanish, perhaps? I don't know. Doctor? No, Moscow?
For me, it's not usual to see guys using metal screw. Well, I know you do BTP, but what is the reason that you do with metal?
So I think the reason that people don't use metal screws is because we are brainwashed by industry that metal is bad because it's cheap. So it's as you'll see, I have my talk tomorrow afternoon a las 5:30. I gotta talk about how we make decisions. And I don't want to give my talk now, but I think sometimes we are influenced to use maybe more products or products that are more expensive, because what I do now is I can't use metal for my hamstring grafts on the tibia. I can't get the metal soft tissue screws anymore. They stopped making them, I think because they were too cheap, not expensive enough. So I use PEEK because I can't get metal. But I had these great metal soft tissue screws. A retro screw by Arthrex was great soft tissue screw. But I think there's some advantages in addition to the cost, because I don't pay for the screws. The hospital pays. It's not my problem. But I like to see it on X-ray. I like the bite of metal screws. I like that there's no biological reactions. You heard Andy Williams talk about the bio screws. I've seen some bad lysis of bone and synovitis from bio screws. And they say they resorb, but sometimes you go back 3 years later and there's big chunks of screw. It's sometimes the whole screw. And you, again, for a hardware removal, you can't see it. And we don't know really what the effects. I've seen sometimes biocomposite screws, with debris in the knee, and we don't really know what that's all about. And the metal, I think, is pretty inert. And I think also for a BTB, a metal screw, the bite you get fixing that is very satisfying and secure. So that's my rationale, Moscow. It's a great question. Thank you. The other thing I wanted to mention is I showed a patellar tendon, but I caution to do patellar tendon in people. I mean, I rarely do it in, I'd say men over 30, because they're not playing usually aggressive sports, or women over 25. I do. If I have a man who's 40 who's playing football, soccer, then I do. I would probably do a patellar tendon. But if they don't have a big, strong quad like this guy, this is an American football player. They don't have a big, strong quad like a female, over 25. It can be a very long recovery sometimes after a patellar tendon, because they can't get their quad back, and they may not be able to walk normally for a while. And it's mucho dolor por la paciente con el cirujano, los dos, dolor.
So it's very painful for the patient and the surgeon.
No.
Is there a question at the back? No?
It's a good question. I mean, I'd say maybe 20%, but it's usually short-lived and they may complain briefly. But people who really need anti-inflammatories and struggle, I'd say probably less than 10%. And long-term problem, very, very rare. I just saw a patient literally this week before I came down who had one of the worst cases. It was 10 years ago. He came back for something else, but he had lingering anterior knee pain, like a little bit. He still could do everything, long hikes and everything, but he'd feel a little. And that's like the worst case I've had. So yeah, you get some cases here and there, but managed with good physiotherapy, some anti-inflammatories, it usually goes away. And in rare cases, does it persist to be a nuisance. Another question.
Dr. Marks, Fernando Contreras from Costa Rica. Great to see you here.
Great to see you, Fernando. I was hoping you'd be here.
Yeah, thanks. So I have a question about the portals. I can see you're drilling from an accessory portal closer to the tendon than the one you did for your scope. I've seen many people, and actually the way I do it, my accessory portal is actually more medial to get my tunnel more lower in the wall, and sometimes I even have to scope through this anteromedial portal that I did first, which I do very close to the tendon when I cannot get a good look at the back of the wall. But you do it the opposite way. You do your portal for drilling more to the midline.
It's actually, you can't see because it's through the incision. I make my skin portal through the normal, because that one I use a lot. But for the anteromedial drilling, it's really about a centimeter below, a centimeter and a half, depending how you measure, below the other portal. So when I do a hamstring, it's directly below my normal portal, but it's pretty close to the tendon. When the knee is open, I go maybe a centimeter medial to the tendon.
Okay, so both
But I
are
think
about
you don't want to be too medial or you will hit the condyle with your reamer. I use a straight reamer, straight pin, straight reamer.
okay, so both are about the same distance from the tendon. Just one is lower.
Yeah, I would yes. Maybe it's a little more medial, but not extreme. When I do a hamstring, I use an incision pretty much directly below.
How many newtons do you use for the tension of the graft?
So that device is, as I understand it, 20 pounds. It's a ratchet, so it goes maximum 20 pounds. I'm not sure the translation, but if I can't use it for whatever reason, like if I'm putting a staple, if the graft is too long, I'll make a trough, like a longitudinal hole in the tibia and put the graft in it if it's too long and put a staple on top. And then I can't use the boot. So then I use my hand and I pull as hard as possible, basically.
Okay.
In full extension.
Do you find any difference between anterior knee pain, as the doctor asked before, between hamstring tendons and BTB?
You know, I think there has to be more with BTB. I mean, you know, there has to be. You're cutting out a piece of the patella that can't feel good. So there has to be more. But I don't find it to be a huge problem in general. But also don't forget, I just said to avoid this operation in people, you know, say my rough rule, female over 25, male over 30. Never say never, never say always. It's not a fixed rule, but those people tend to have slightly smaller quadriceps, of course, except for people in this room. I mean, other people. So, you know, you take a person like that, or if you have an athlete, even if they have very small quads, I may do it anyway, a young athlete, like someone 20 years old, 15, 20 years old. But if they have very small quads, they're not very muscular, they may have more difficulty with it. They'll have more difficulty with any operation, but especially with a patellar tendon. So beware, be careful if you have someone with particularly small quads, not muscular legs. I think they're more at risk for anterior knee pain.
Okay. ¿Alguna otra pregunta?
Any more questions?
The other very important thing to avoid anterior knee pain, while I'm waiting, if someone has a question, please put your hand up. It's great to see Fernando again. He was a fellow with us in New York for a year, the poor guy. Pobre. 1 year in New York with us, but I haven't seen him in a while, so thanks for coming. I'm glad, very, very happy. So to avoid anterior knee pain after the surgery, I think the physical therapy is very important. It's critical, and not just how we treat them. So one thing I tell every patient after surgery and after any injury is they have to use 2 crutches until they can walk normally. I have quite a few patients who speak Spanish, so I can say dos muletas until caminar normal, perfecto. So I say that a lot, dos, no. You have to have 2 crutches. So every step is therapy. They're practicing every step. And then what happens if they don't, if they're limping and they're walking badly, then they're overloading the front of their knee and they're causing pain and swelling and making it worse. If they're walking with 2 crutches, they're getting better. I use a brace, a leg immobilizer for safety in case they fall down. But I encourage them after 5 days to use the leg, 2 crutches. You know, if we have ice in New York, so on the road, so, you know, wear the brace, don't fall down. But I think that's an important cause of anterior knee pain is how they walk, what they do after surgery. And not overdoing it in physical therapy, doing too much too soon.
Okay. Well, thank you very much, doctor, for your speak. And muchas gracias a todos. Si no hay más preguntas, damos por terminada la
Thank you to
sesión.
you all. If there are no more questions, this is the end of the session. Thank you very much. A pleasure. It was a great honor. Thank you. Thank you.
Buenas tardes. Creo que es bueno comenzar ahora.
Good afternoon. I think it would be good to start now. It is 12:51, and we are going to start the symposium of scientific societies. The society is Brate, the shoulder Society of Brazil, with the President Sergio Canuto and Luis Alfonso Gomez, respectively. The first topic will be provided by Sergio Canuto on lesions on ramp lesions.
No funciona, no funciona. Okay.
De la parte de hombro, Juan Luis no lo dejaron entrar por problemas de la vacuna.
Oh.
Él trajo una copia y
¿Cuál es
quería
la conferencia?
la primera de hombro, la conferencia Un Track de Inestabilidad. Juan Luis.
Yo, Luis de Castro, tratamiento artroscópico de la lesión de banca y no está no está grabada.
No está grabada.
No importa. Haces.
Vamos a hacer un poquito de la flash un poquito más larga.
Ok, sí, si quieres. Lo importante es ahí en el tiempo. Sí. Pero ahí solamente hablaría Joao Felipe de Medeiros.
Felipe tiene después el fuego cruzado y después yo.
Fuego cruzado, ¿dónde está?
El fuego cruzado tiene el Paulo,
Ah,
el Beno.
ya. Listo. Como estamos comenzando de pronto.
Okay, given that we're just starting, we will not take too long. We're going to start at, what time is it? 3. Okay, we'll see how long.
Ok. Sí, no habría problema mientras acabemos a la hora. Esto se acaba a las
4:30.
Sí, 4:30. O sea, hora y media.
Sí.
Ok. Sí, listo. Vamos a... Sergio tiene problemas con la conferencia, entonces vamos a comenzar con la conferencia de... ¿estaría la de Lucio o la de Víctor? La de Víctor. Víctor, ¿cuándo no suturar un menisco asociado a ligamento cruzado? ¿Cuándo no suturar? Víctor, bienvenido.
So now we're going to look at when not to suture the ACL, led by Victor Barrion de Padua. I want to thank you for this invitation. Thank you for organizing this Congress as well. So when do we not suture a tear in the meniscus and in the reconstruction of an ACL? So the answer is never, but sometimes there are some exemptions. The functions of the meniscus are biomechanical, so stabilization with condyles, absorption, distribution of load, and also biological functions like lubrication, nutrition, and proprioception. So when we do a meniscectomy, we alter the biomechanical functions, we reduce the area of contact, we increase the pressure, and it also alters biomechanical functions, and it changes an inflammation of the cartilage is also seen. Fairbank in 1948 talked about the reduction of intra-articular space and the presence of osteophytes. So this is the development of arthrosis. This is the worst result with lateral meniscectomy because there's less movement in the compartment and it's convex as well. So there's a greater risk of condylosis. The medial meniscus, when you have a meniscectomy, is when it's linked to the ACL, has a greater risk of instability and greater pressure on the ACL and worse results in the long term. So when we read different work in literature, they all show greater risks of arthrosis when you have the ACL linked to a meniscectomy, medial meniscectomy. There are quite a few books and quite a few congresses around the world that talk about the meniscus and talk about the importance of preservation. So we have we can see that there's a white part that's the complex part of the meniscus in younger patients, and there are counterindications, lesions, small lesions. Maybe we can leave them when they're under 10 millimeters, when they're stable and incomplete. So you can see the superior part, the inferior part of the medial meniscus, or the lateral meniscus. When we read the literature, there's a lot of work that shows us that they behave in different ways, the lateral and medial meniscus. So with small stable lesions, we shouldn't do anything. And with the medial one, there is greater pain and there's greater chance of healing when it's the lateral meniscus. The lateral lesions after the popliteus have greater potential for scarring and healing. The longitudinal ones under 3 millimeters are better for scarring. The radial ones do not scar too well. When we look at all of this literature, there's greater failure rates when we do nothing, when we don't treat these medial ones compared to the lateral ones. So it's very important to differentiate between stable medial and lateral meniscus. These are important works as well that show that the operation rate is lower for lateral meniscus when we don't do anything. And when they're higher than 10 centimeters, they're worse. Another piece of work also shows us there's greater failure rate with medial meniscus. Pujol showed that when there is a medial lesion, even if it is stable and incomplete, it's better to do a suture. And when we look at the consensus of the ESCA, the conclusion is that when you have a stable and complete lesion, we should at least perform stimulation to help the biological part. 0 to 30% is the reoperation rate when there is failure, even with stable ones. The lateral one has better prognosis, and the limit should be 10 millimeters, and the medial meniscus, even if it is unstable and incomplete, maybe it's unstable and incomplete, it's better to perform a repair. There are certain types that are debated, such as the horizontal ones, where we recommend not doing anything or having a meniscectomy of the upper part or the inferior part, superior or inferior, but we prefer a sandwich suture to close these types of lesions, and normally this is in the lateral meniscus in young patients. Another type of lesion that we should pay attention to are the hidden lesions. We can see that there is a small morbidity of the medial meniscus. These are lesions that where we have a posterior medial compartment, and normally these are lesions that we find, so ramp type lesions. When we look at the literature, some authors say that these ramp lesions that are stable, lower than 1.5 centimeters, have better healing, but there may be abrasion. So if there's going to be abrasion, it's best to perform treatment. Our preference is to perform sutures, as you can see here in the posterior medial portal, because in the end you have to do abrasion, and it's better to create a suture which is safer to stabilize the area which may overload the ACL.
So in conclusion, sutural
So to conclude, to the extent possible, we need to look at the best results in the long term and less failures of the ACL. So, and in the middle meniscus, we should do any sutures if there's any incomplete process. But perhaps the only lesions that where we should not do anything is the lateral, the incomplete stable meniscus, which are lower than 10 millimeters. Thank you for your attention.
Muchas gracias, Víctor. Continúa el doctor Lucio Erlund.
Thank you. We're going to continue with Dr. Lucio Emlund.
Buenas tardes a todos. Es un placer muy grande
Good
estar
afternoon, everyone. It is a pleasure for me to be here in Cartagena. Thank you so much for the invitation from Colectiva Brazil. And I'm going to try to speak Spanish. My apologies.
não tenho nenhum conflito de interesse.
I don't have any conflicts of interest. Thank you, Moscow, for his friendship and his invitation for me to be here in Colombia. Everything begins with the anatomy. The anatomy is the basis of the entire medicine, and this is no different in orthopedics. And we need to have total understanding of the knee anatomy in order to think about the treatment. When we talk about lesions, root lesions of the meniscus, it is important for us to bear in mind these images, which has indicated that the root of the meniscus is 1 point from the insertion point in the tibia. When it is more lateral of 1 more centimeter, it can get closer to the root. This is really important because this is bringing us to the classification in terms of how to do the treatment of the meniscus lesion. It is important that this image is really important. It was showed by Victor in terms of what happens when we have a root lesion. It is removed from its original position, and then there's a transfer of the load from the femur to the tibia as if it were a meniscus full lesion. These are really rare lesions. They're laterogenic and they're rare, and they take place at the time of the anterior portal. The posterior root lesions or lateral ones, they have a traumatic lesion. There is an incidence of 8.7% of the ACL, high energy, and there are effects due to pivot and contact. There are associated risk factors, which is the meniscus concomitant lesion, and almost 60, and there is a 65% false positives. The classification in this case, this is the most perfect one based on the information that we need for the planning phase of the surgery and the suture. The diagnosis begins with a good scan, and it is clear that we have a posterior root. There is a good sign. Yeah, you can see the image to the right, which shows that the image of the meniscus insertion, it is showing a good ghost sign. There are several papers that talk about the importance of the lateral meniscal posterior root. And it is important to notice that there's an increase on the anterior tibial translation, and there's instability. There is a rotational instability, and this is quite clear in several scientific papers published in literature. The treatment can be with screws. My personal type will be this is quite simpler and cheaper to do. These are some of the designs, and it shows how we do it. We're using the BIFCAM, a wire, which is the one that is commonly used. And then you introduce this, and there is a very simple and cheap way to do or to push the tendon to the bottom part of the tibia. This is a very clear sequence, and it shows this is the BIFCAM. And then we're doing a suture with the clamps and to look at the opening of the shoulder. That's quite easy to do. Now this is a different case.
Menisco
because the lesion in the middle root is clearly related to other meanings. And I imagine that Botero was an orthopedist because all his designs or his art is showing everything that we need to do in orthopedics. Obese people have this type of lesions, and with this type of situation or lesion in the patients, when the patients are in kneeling position, and that's when we analyze the cases of medial meniscus. This is a clear image. This is the evolution for what conservative treatment. These are cases where we have advanced arthrosis, chondral lesion 3 or 4. When we have a meniscectomy, we have more mechanic systems where there's no possibility to have the correct suture. And for the repair, in those cases where there's an initial arthros, when there is a low chondral lesion, young patients having an acute prognosis with given the different positions of the leg. In terms of rehabilitation from 0 to 6 weeks, necrosis, partial support, ADM up to 90 degrees, and from 6 to 12 weeks, support that you can support the feet. You should not bend. You should not bend, and above 12 weeks, it will have a total movement. So the results are very good, and these are the outcomes of the surgery. There is no evidence of the reduction of arthrosis. Which are the take-home messages? The medial meniscus, degenerative, insidious. We need to observe the weight of the patients and the presence of arthrosis. In terms of the lateral meniscus, it's traumatic. It is related to ACL, young patients, and there's instability. Thank you. Thank you, Lucio. We now have Sergio. Sergio, with your conference.
Ok. Eu vou falar sobre lesões em rampa.
We're going to talk about the ramp lesions, meniscal, which are associated with the LCA. This video facilitates how the ramp lesions are taking place. This is a group from the Santi video from Santi group, which is showing an anterior tibal with the ACL tear, a lesion on internal rotation, and this is a postomedial. There is an anterior translation of the tibia with a contraction of the membrane, and therefore there is a lesion in the ramp, oftentimes associated with the lateral meniscus with a higher prevalence. This is an upwards view. When we have a medial or when we see any type of liquid behind the meniscus, we need to think about the ramp. The diagnosis can exceed 50%. Underneath the meniscus, there is some elevation. You need to do a UPS vision. And in this case, when we have a medial and then we have the suture. This is a new lesion. No, this is something that goes back many years. This is something that was discovered 39 years ago. The term a ramp was created in 1988, and Craig Morgan was referring to an arthroscopy technique that is quite similar to the one we currently have. These are colleagues from Korea. They published a series of cases, 39 cases with the same technique that we are currently managing. And then the Santi group indicated how to do the diagnosis of the ramp. The step one, in the frontal part of the meniscus. The step two is the step three is to use a needle. When I insert the needle, we identified 21 cases, and 40% had a posteromedial case. This work of colleagues from Korea has indicated with the 70-degree view, there's no posteromedial displacement. So this is the classification, and they're showing 5 types of ramp lesions. And what is the prevalence of ramp lesions? This work of the sports medicine from Santi group indicated that it was 24% in primary ACL. This is an article published in 2022, which indicated that there was 10.9% prevalence. In 2013, we found 4%. In 2019, 20%. So with the experience, you can diagnose even more. This work of Romaceo indicated that there is more cases. The patient. So the colleague from China, he published that many of the lesions it could imply an abrasion. And he said that if there was abrasion, why shouldn't we suture? The ramp lesions have a higher prevalence with the process.
Como reparar? Muitas formas de reparar.
How can we repair it? There are many ways to repair. My experience is with the suture. We use the clamps and clamps, and this is something that we were using in 2015. So we use a national. We use the suture that is very difficult, but they're also difficult to use. What about the all-inside devices on the anterior path? It is possible. We can, many of them, and in that cases, they're not good. So there is a technique published by Negrini for meniscal ramp lesions. So this work of our friend Matitona included 248 lesions with a failure of 7.3%, 4.3% of failures with the suture, and 20% with the all-inside devices. So we have 5 times more failures with the anterior device. So all the ramp lesions, they require a needle exploration, and there's a debridement on the postmedial part of the meniscus in order to remove the edges and to try to do the suture. And there are many ways to suture. In this specific case, was done that there was a count positive, and this is something that was achieved with this technique, which was a little bit harder, but it was possible to do. As I indicated, there are many devices that allow conducting this technique. The most commonly used is the one that I referred to initially, using a hook, doing a suture, and then there are no difficulties. You just have to do a little bit of rotation in the tibia and a good person providing support. This is another hook technique. We're coming from the top, and we're getting to the bone. So in terms of the posteromedial portal, you may experience some complications like hematose and the savannah nerve. There is and there's a phase 3 to try to avoid any lesions in the structure. So the conclusion, the ramp for prevalence is from 10 to 25% of the primary ACL. The risk factors are young patients, male, chronic, and the clinical implication is the anterior translation from 1 to 2 millimeters, and the repair of the ramp in most of the case can improve the performance. In cancer, there is 40% of LCA, and the spontaneous, there is a small lesion which is established and may not require any suture. The repair with the lasso 25 suture that I do indicated that it was that presented or reported 5 times more failures compared to using a hook. So thank you very much. Excellent, Sergio. Pedro. Option treatment, degenerative meniscus tear treatment options. Hello, good afternoon, everyone. My name is Pedro. From Sao Paulo, Brazil. It is an honor for me to be here with you. I am very pleased. This is my first time in Colombia. I'm going to try to speak Spanish. So I'm going to talk about the meniscus degenerative lesions. In my opinion, they can raise a lot of doubts in our practice. The cases are not the same. We have different cases. I'm from Sao Paulo. This is the hospital that I work at, and it's called Santa Casa de Sao Paulo. It goes back to 1883, and it is part of our society. The osteoarthrosis is characterized by structural alterations, mainly in the articular cartilage, but also in the synovia and the hoffa fat and in the muscles and in the ligaments. So this is a disease. This is an articular disease and not just a cartilage lesion. We know that the meniscus lesions are give rise to osteoarthritis, and this can give rise to meniscus lesions. So this is quite a difficult treatment. We know that the rupture of meniscus is spontaneous, and it's present in up to 35% of people above 50 years of age, and 2 out of 3 are asymptomatic. There's a lot of meniscus ruptures that are not observed, and they're even more prevalent in patients with arthrosis. Meniscectomy is the surgery that is conducted most frequently in the US, and the purpose of this is to eliminate unstable fragments, maintaining the most feasible tissue. The arthroscopy for the treatment of arthrosis that we has decreased significantly. Therefore, the meniscectomy that we call the meniscectomía parcial also increased significantly by 50% in the past years. So the meniscus degenerative lesions, how can they be treated? How can we look at these as different things? I separated 2 classic works that serve as a guidance for me on a day-to-day basis, and I think that these will be very useful. The first one is going to talk about the articular. This is going to be an arthroscopic surgery for osteoarthritis, which is very interesting in 2008. So in this work, we separated 2 groups of patients, one for arthroscopy and the other one for physiotherapy, to assess this treatment in patients with arthrosis, not with those having meniscus lesions. WOMAC was done in the first 2 years. 86% were subjected to surgery and physiotherapy. 86 patients were only subjected to physiotherapy, and at the end of 2 years, there were no statistical differences. If we can see, in the first month, the patients of surgery, they were better, but at the end of the 3rd month, they were the same, and after 2 years, patients with physiotherapy and with arthroscopy plus physiotherapy, they remained the same. And what about the partial meniscectomy and in a master athlete? When should we do this? So I separated 2 articles that can actually. This paper refers to partial arthroscopy versus placebo, which is the what's a placebo surgery? This is a surgical process. So you identify the lesion, but the lesion remains the same. So in this work that was done in Finland, we studied patients from different hospitals with different symptoms, without any arthrosis or any trauma. So these are degenerative lesions, patients from 35 to 65 years of age with symptoms for more than 3 months. All patients were subjected to an arthroscopy, and then after confirming that the lesions were there, a nurse will open a package that will determine the treatment given to a certain group. Lisholm and Womet were done with 12 months. 70 patients were subjected to the placebo surgery. They will only remove the arthroscopy. 76 were subjected to surgery. After 12 months, the result of the persons operated was not better. They remained the same. So that's what we can see in this graph. So therefore, these are non-traumatic lesions, and which were treated by physiotherapy. This is important. There was a lesion, and the outcome was the same. The third paper, in my opinion, is quite interesting, and it's about patients about 45 years of age, from the same newspaper, with meniscal lesions in the knees with arthrosis. This is mild to moderate. They had symptoms for more than 1 month despite the adequate treatment. They had the physiotherapy for 1 month, but the symptoms persisted. So this was a group. We had 351 patients eligible for this study from 7 hospitals, where they were assessed through WOMAC from 6 to 12 months. And the 2 groups had a surgery and a physiotherapy, and there was another group just with physiotherapy. At the end of the 12 months, the scores were the same. We had patients, symptomatics, have surgery and have only physiotherapy, but at the end of the 12 months, the grades, the scores were the same. However, 6 months after, they had a crossover option. Those having pain after 6 months could request the surgery, and 6 months after, we had a 30% crossover among the different group, despite the similar results. 30% had the opportunity to go through surgery because they were not doing well with the physiotherapy treatment. This is with traumatic lesions, and they had an advantage. And then this is a guideline from ESCA, which is recent. This is an interesting guideline that I'm using here to continue, that I use in my private consultation, and it was distributed to 84 knee surgeons in 22 countries in Europe, and it defines degenerative meniscus lesions such as spaces of a meniscus which are traumatic. And I concluded that that arthroscopy for the partial meniscectomy of degenerative meniscal lesions should not be the treatment of choice. This is an organization chart that they have. This is the lesion. Without that diagnosis, they are not indicating any type of process. The patient goes to physiotherapy. There are infiltrations, and then after 3 months, those who are doing well are doing well, and the ones who had not didn't have an MRI, they mostly had them, and there is no sign of arthrosis after 3 months of treatment. And if there's a lesion, then they will order arthroscopy. I have a couple of cases to finish my. This is a 62-year-old male with medial pain on the knee, and he affirmed that he could not play football, but there was no trauma. He played, but today he cannot do it anymore, and he wakes up at night with pain. So to me, this is a typical sign of meniscal instability, because the patient wakes up at night due to the pain. So I think that this is very important in my clinical practice. It is mildly positive and McMurray positive, and then he went through 2 months of physiotherapy. Just a second. So this is a classic case of a degenerative meniscus lesion that actually broke.
En este paciente, no está yendo. Pero está bien, aquel caso era un hombre con lesión y que...
This was a man with a lesion and went through a partial arthroscopy and was allowed to go back to play football. This is another case. To me, this is a very specific situation of this patient that starts to suffer this type of pain. Uh, and and the MRI showing this image, this meniscal impact when the flap is dislocated to that medial region between the tibia and the collat and the profound ligament, causing this bone situation. Despite the physiotherapy that we do, it is very difficult for the symptom to improve.
Porque esa es una lesión.
This is a lesion, a very dangerous lesion. I think that you can. Why is this one very dangerous? Apparently, because apparently she doesn't need any surgical treatment. But this non-surgical treatment is not positive. So there's an arthroscopy with this situation. The meniscus seems to be there, but we need to believe in the exam. And we have we're creating a small path, and you will see what happens when we identify the lesion. Please don't fall asleep. When we identify the lesion, it goes from right underneath, which is what I showed in the MRI, and that's a very important lesson to be learned. It takes a while. The lesion is quite significant. There's a huge lesion that in general that wouldn't heal by itself, and it's hidden. It's something degenerative. Then we do. To me, this patient in the following day will be very pleased because the symptom will disappear completely. So that's what I wanted to share. Thank you very much. Thank you, Pedro. We're going to continue with a discussion on this module. So it's 3:37. We have 8 minutes for the discussion. Do we have anyone from the audience who wants to ask a question?
Buenas tardes. Quisiera preguntarle a Lucio qué
I
opina.
would like to ask Lucio, what does he think about the meniscal root insertion and in patients above 60 years of age? Because this is a frequent situation that we observe in the different scenarios where there's a lot of pain, but the age in some arthrosic cases generate certain type of doubt.
Na grande maioria dos casos não há a fixação. Não realizo
In most of the cases, I do not fix it. And the ones where we have fixed are the more young people. I don't think there's a great improvement in the stability of the patient in the long term with fixation over the age of 60. I'd like to know what Manuel thinks about this. Okay, well, I think that the age for what we do today is not a good factor to make decisions, because I've found patients who are 62 who have very good knees. So I look at the symptoms. If there's a patient with pain and they haven't improved with the therapy and they have a bone issue and I find a lesion, there may be even 70, and I will operate. That's my opinion. The thing is, we do not have evidence to say whether we're going to stop these patients, or we're going to prevent spontaneous necrosis. We do not know that, or whether the patient is going to have good healing. But something that is true that I know Paolo knows, and that is that when the patient has pain, in a case like this one, and there is some edema, if you do the reinsertion, the symptoms improve. So we're trying to use the symptoms as guidelines more than anything else. Any questions? Paul? Yes, Moscow. I have a question for Pedro and generally for all the audience. If a patient is over 60 years old and they have a degenerative non-traumatic lesion that hasn't improved with physiotherapy, and they've had a meniscectomy or something on the meniscus, what percentage of osteonecrosis do you see in these patients? What percentage evolves to arthrosis? Because we know it evolves to this, and also, do you use anything biological like hyaluronic acid or anything else to improve results in these specific patients? Okay, hello, it's very good to see you here. Thank you for the question. I think that if I see osteonecrosis post-surgery, when you finally opt for withdrawing the meniscus, the part of the meniscus that is causing pain, I don't think this is going to cause osteonecrosis. If it happens, I think that it will simply occur with or without the surgery. I think that this is the most logical path because the decision is there, the overload is there, so you're taking away the inflammation perhaps of the knee. So I don't usually see that. I mean, there has been osteonecrosis in this situation, but these are situations where I opted for performing surgery as soon as possible, and it occurred. It was dramatic, but I'm not sure if it was the surgery or if it had already happened. Arthrosis, well, it's the same with arthrosis because in the beginning, I think it's better to have a more or less meniscus or half a meniscus, but if the pain persists, then the meniscus, if it's not helping, then it won't prevent arthrosis. So I think it's more a pain option. I'm not sure if my friends believe the same. Yes. I'd just like to clarify the following vision. So patients need to be educated very well. And I think that a medical consultation should be a consultation that is going to be explained, where you're going to explain multifactorial information about the pain linked to meniscus lesions in patients over 60 or 70 years. So I think that's my opinion. I think that the majority of these patients see great improvements without surgery just by accepting all of the different multifactorial steps. That's the way I see it. Perhaps I'm wrong, but in my own clinical practice, the impression that I have is that it works really well when patients go in to that medical consultation and understand all the different factors as shown in the drawings by our colleague. So I think we really need to be very aggressive with these patients and take them into surgery. That's my question, I guess. And I think that this is a very this is an area where there's no right or wrong answer. We simply need to try it, and there's probably a lot of information that we do not have at the moment. Okay, please go ahead. Yes, I just wanted to comment with regards to the meniscus that have been withdrawn from young patients. And when we interpret their MRIs, they're rarely reported, and as a result of recent publications on the anatomy of the lateral meniscus shown to us recently, they have emphasized this. We have been much better at performing an appraisal, and in my practice, I have had young patients who, when you do an arthroscopy, you find that it is apparently healthy, the meniscus, but then when you explore it, you realize that it is extrude, and the whole plateau and the peripheral edge of the lateral plateau is basically uncovered by the meniscus. And there are recent techniques that I've seen over the last 2 years when I've been looking at this topic, where they centralize the meniscus, and so patients obviously improve, because these centralization techniques allow the meniscus to go back in, and they do improve. Otherwise, they'll continue to complain about impingement, especially when they jump and they finish a match. The next day, there is inflammation of the knee and pain. Yes, without a doubt, that is what we have seen. The first conference on the shoulder will not take place because our colleague wasn't able to arrive. So we will continue with the next one, called Instability of the Shoulder in Amateur Athletes, Off-Track Lesion and Remplissage by Felipe Pereira. Do you have your conference ready, Felipe? Yes. Okay. Hello, good afternoon. I'm going to speak Portuguese. I wanted to thank you for summoning us here to the Congress and the organizers. So I'm going to talk about a topic about, I'm going to talk about the remplissage and off-track lesions for amateur athletes. The first advice for these off-track glenoid lesions was provided in 2007 by Yamamoto. He wrote a study about the sliding head of the humeral and the glenoid with lesions called on-track and the ones that involve the head. And these lesions off-track are outside of that study. Subsequently, in 2008, in arthroscopy, Dr. Gene produced an advice to perform a remplissage, which is similar to the heel sacks, to put the tendon within the heel sacks lesion in the extra-articular lesion. And the sequence in 2014, Dr. Hitoy, alongside Giacomo and Bancart, brings these two councils together for glenoid on-track and a remplissage, and creates 4 groups. Sorry, we're going to stop here because we do not have a Portuguese translator.
A perda óssea seriam superiores a 25%, e daí fazem um algoritmo de tratamento em que aquelas lesões abaixo de 25% seriam possíveis promover a correção por partes moles, e as lesões acima de 25%, nós teríamos a necessidade da complementação com enxerto ósseo. A nossa aula, a nossa conversa de hoje vai estar restrita à conceituação do Bancart com remplissagem, então seria aquele subgrupo do paciente com menos que 25%, daquele paciente com a lesão do tipo off-track. E o que mostra a literatura? Esse é um primeiro trabalho do Pascoal Boulot, em que ele observa um follow-up de cerca de 2 anos de pacientes, de 47 pacientes, com alguns scores de avaliação, e vocês observam um ponto de perda de rotação externa nos pacientes submetidos a uma reimplantagem em torno de 10 graus. Porém, os resultados de retorno ao nível do esporte, de baixo índice de recidiva de instabilidade, com bons resultados funcionais dentro dos scores avaliados, levando os autores a concluírem que, mesmo tendo essa perda de rotação externa em torno de 10 graus, a atividade, os resultados funcionais eram satisfatórios. Esses resultados se repetem, são outro paper com um follow-up um pouco maior, mostrando também scores de avaliação, perda de rotação externa que chegaria a torno de 6 graus, mostrando um bom retorno funcional, mostrando o retorno ao esporte, desculpe, e uma baixa índice de recidiva, com a mesma conclusão de que o reimplantagem é uma técnica útil aos pacientes com aquele perfil inicialmente descritos. Um novo paper, N maior, follow-up maior, esse agora ele associa uma avaliação do Gutalier a posterior do reimplantagem, como é que se comportaria o tendão do infraespinal pós-reimplantagem. Sorry. E daí observa bons resultados funcionais. Eu não estou conseguindo ver.
¿Qué pasa? No adelanta. No adelanta aquí. Ya. Ahora, otra vez. Siguiente. ¿Está bien?
Ok. Scores e avaliação junto ao Gutalier, como eu descrevi, bons resultados funcionais, perda de rotação externa, a semelhança do trabalho do Pascoal, com 10 graus de perda de rotação externa. E quando avalia o Gutalier, nós teríamos apenas 50% dos pacientes elevação em 1 grau do Gutalier, levando os autores à conclusão do bom resultado funcional. Um outro paper, N maior, follow-up maior, outros scores de avaliação. Perda de rotação, todos eles avaliando o mesmo perfil de perda de rotação externa, abaixo de 10 graus. Resultados funcionais de retorno ao nível do esporte e de nível de estabilidade elevado, com os scores avaliados também de forma elevada, levando a conclusões significativas de um bom resultado do reimplantagem para o atleta. Um outro paper, também com N agora já mais elevado, do Dr. Eugene Rolfe, com score elevado, a repetição dos outros trabalhos, bom resultado funcional, bom retorno ao mesmo nível do esporte, resultado satisfatório e indicação do reimplantagem como técnica de tratamento. Por último, esse é o trabalho com um follow-up de quase 10 anos também, do Dr. Gene Rolfe, publicado agora no ano 2020, em que chega às mesmas conclusões, resultados funcionais significativos e uma boa indicação do reimplantagem para o grupo seleto de pacientes. Quando a gente copila esses resultados, passa a se observar que dos scores avaliados, todos os 5 papers apresentavam ROVE elevado e apresentavam um índice de estabilidade do ombro também elevada. Isso corrobora com as revisões sistemáticas que aí se sucedem, essa primeira observando os mesmos padrões, a gente observa um índice de ROVE elevado, um índice de retorno ao esporte elevado, um índice de estabilidade também mantida, levando os autores à conclusão que o procedimento é um procedimento de bom resultado aos grupos seletos. Agora, já uma revisão sistemática com meta-análise, aqui se faz comparação entre 2 grupos, reimplantagem com bunker isolado, e quando se sequencia resultados de ROVE, do UCLA, retorno ao esporte, recorrência de instabilidade, o reimplantagem associado ao bunker mostrava resultados satisfatórios em todos eles, mais uma vez, naquele grupo seleto a qual nós tínhamos descritos. uma nova revisão sistemática com meta-análise. Aqui ele faz a comparação do do remplissage com o Latarjet. Observa que, para todos os scores avaliados, recorrência de estabilidade, ROVE, escala de dor, perda de rotação externa, eles se assemelhavam, apenas que o Latarjet apresentava um índice de complicação maior do que o Bankart com remplissage, determinando que os resultados entre os dois são semelhantes, porém, o procedimento do remplissage é um procedimento com menos efeitos colaterais. Uma outra revisão sistemática, aqui já ele passa a comparar três grupos de pacientes, Bankart com remplissage, Bankart isolado e Latarjet. Quando se compara o Bankart com remplissage, o remplissage tem resultado superior ao Bankart isolado, e quando se compara o remplissage com o Latarjet, os resultados se assemelham com relação ao resultado final, levando à conclusão, como falado anteriormente, que o remplissage é superior à reparação de Bankart isolada e que, comparado com o Latarjet, ele apresenta resultados semelhantes. Para finalizar, essa é um trabalho publicado na Arthroscopy, tem menos de um mês que foi publicado, de fevereiro agora de 2020. É uma compilação de dados à semelhança do critério de Delphi, onde ele avaliou um grupo de 65 médicos e cirurgiões de vários países, dos 5 continentes, e à semelhança dos critérios, eles criam perguntas para determinar respostas. E eu selecionei, dentre elas, as que falavam de remplissage. E daí eles perguntam quando usar o remplissage. O remplissage teria indicação quando eu tenho uma lesão off-track, que quando eu tenho um engaging durante a cirurgia, e vocês conseguem observar um percentil elevado de consenso nessa afirmativa. Quando é que eu não faço remplissage? Eu não faço remplissagem quando eu tenho uma lesão que seja um track, eu não faço quando eu tenho um infraespinatus ruim, eu não faço quando eu tenho uma perda óssea da glenoide superior a 40%, e o último item é um item de importância, seria a não indicação para os atletas de arremesso, isso é uma indicação relativa, pela perda de rotação externa que esses atletas poderiam ter, mas quando vocês veem os trabalhos prévios que a gente apresentou, o índice de retorno ao esporte era elevado em todos os papers apresentados. Uma outra pergunta qual a complicação que o remplissage pode dar e como é que eu evito? A complicação que ele pode dar é perda de rotação externa. E se evita se promovendo uma sutura mais lateralizada, mais em tendão e não em músculo. Precisa-se amarrar o remplissage subacromial? Esse consenso fala que não, é indiferente você amarrar subacromial, amarrar por visão indireta intraarticular. E, ao fazer o remplissage com o Bankart, muda meu pós-operatório, o consenso determina que seu pós é semelhante, seja com ou sem remplissage. Esse é um vídeo, eu acho que precisa clicar.
Clique.
Um vídeo demonstrativo, eu faço inicialmente primeiro o Bankart, para a posterior fazer a correção do remplissage. A esse momento, nós invertemos a ótica ao portal anterior, eu passo a ver de anterior a posterior, e passamos a ver a lesão. O mesmo portal utilizado é o portal utilizado para a colocação da nossa âncora. Os fios são, então, colhidos através do uso de um bird beak, que é a lembrança da necessidade de remover esses fios um pouco mais lateralizados. Quanto mais medial eu fizer essa pesca pelo fio, maior chance eu vou ter de perda de rotação externa. Então, são passados 4 fios. Vê se consegue acelerar um pouquinho o vídeo. E a posterior feito a sutura como descrevi de forma indireta pelo espaço subacromial, desculpa, de forma indireta por intraarticular, eu não faço subacromial. A posterior, a visualização do remplissage e a correção do Bankart anterior. Obrigado.
Gracias, Joao. Muchas gracias.
Thank you very much, Joel. Now we will have a symposium of crossfire and irreparable lesions. It's 3:59 exactly. I just wanted to ask Joel before we continue on to the rotator cuff. Joel, your conference talks about patients that are not athletes, right? So would you, in that area, the off-track area, would you prefer to go with, let's say it, in a high-performing athlete, or do you refrain from differentiating and prefer to use the Bankart remplissage?
Mais com relação ao atleta de
It
contato.
worries me more so with contact sports people, so martial arts. Despite the works that have been shown, because they have similar results, but I feel safer using the former. Okay, and the work being done here, what kind of follow-up times do you have for that? Because what we see in the patients is that good results go down or reduce after 5 years. That's the work of Eugene Hof, 10 years. So the results, 10 years. For me, it's an ingenious surgery, but it's one of the few that hasn't changed. And I mention this because many Colombian colleagues and colleagues from outside Dr. Gerber, where they're practically condemning the Bankart surgery
Para este tipo de lesiones y lo que está
and
haciendo
Bankart for these kinds of lesions. And they're using the Lafarge.
espacio en la
We are clear that there is less space over time in the recidivant dislocation of the shoulder, the Bankart, right? That's something we all agree with. And the controversial part is whether in this grey area, as we've called it, where there is a Hill-Sachs lesion, quite a significant Hill-Sachs lesion, or a lesion in the glenoid, the Bankart and remplissage could be just as good as the Lafarge, right? Okay. Thank you very much. And now we're going to listen to Dr. Paulo Chinas. We're going to have a crossfire session. Each conference lasts 7 minutes. And we're going to look at irreparable rotator cuff lesions. And I imagine that you will be defending the balloon, Doctor. Yes, I'll be defending it. Okay, good afternoon. I want to thank the Brazilian Association of Shoulder and Elbow Surgery and Esprate for this invitation and also for including me in your agenda. It is a delight to receive all the different Brazilian societies here, and I think it's an honor for SLAD that you have joined us today and also for the rest of the life of the society as societies involved in this kind of subject. I have no conflicts of interest. In this presentation, I'm going to start this presentation with a clinical case, a classic clinical case from external consultation, where we always feel that they have not been ideally treated, these patients. This patient is 70 years old and she had a previous fall in October 2019. There was a fracture that was managed conservatively. She's a housewife, very low demand, 80 degrees of anterior flexion, external rotation of 10 degrees, internal rotation up to L5, abduction. If we look at her, perhaps we can get a better idea, a clear idea of what this patient looks like during the consultation. Typically, in those who are under 80 degrees, there is a subacromial injection with anesthetic and lidocaine to define whether they're pseudoparetic, and in this case she was. And due to time, I don't want to present that element. As you can see, Hamada is 1. There aren't many changes in the arthrosis. And in the MRI, I'm going to show you a few projections. We have Cotillier 3 with pate 3. This tendon goes beyond the glenoid, and also there is a partial lesion of the subscapular tendon. The question here is, what do we do with this patient who has many symptoms, and the ASES is 33.5, Hamada 1, pate 3, Cotillier 3 to 4, and those of you who are here will tell me that in your day-to-day consultations, this is a very normal case. It's not an exotic case or anything like that. So this is something we see every single day. And we face this diagnosis. We face a number of options for treatment, because if it was 15 years ago or 10 years ago, a 17-year-old was a complete candidate for a total replacement, a reverse replacement. Nevertheless, we have many different options today
hasta combinaciones de
that go
técnicas.
from debridement to the combination of surgical techniques. So I'm sure that in your minds, each of you has one particular option, and I can assure you that it is different. It is so different that we have come to a consensus at SLARD, and this consensus is exactly about massive irreparable lesions of the rotator cuff, expecting to completely coincide with most of the important surgeons in Latin America, the most important surgeons in Latin America, and out of the 336 chapters that we had, only in 30 of those chapters, 30 of those scenarios, did we coincide. In the rest, there was no consensus, in such a way that the magnitude of decision-making is something that affects us, and we owe this to our president here, and we want to send a message with this consensus through SLARD, of course. And I believe that we should always think about the easiest and most effective option, and also the best cost benefit. We think that the subacromial balloon is an option. We have learned from plastic surgeons, and we have involved within the shoulder, not really a balloon, it's more of a cushion than a balloon that covers the entire subacromial space and increases that distance, meaning that all of the strength, all of the force of movement through the deltoid and through the recovery of that dynamic or movement in the shoulder can improve symptomatically. So the indications of the subacromial balloon are very, very specific. So for functional patients whose main problem is pain and who has low demand. So I think these are classic patients that we see in consultation, and I think that this is the case for this particular patient. What did we do with this patient? Okay, well, first of all, I want to say that the subacromial balloon, the main benefit of it, which is how easy it is to put it in, is also one of the main problems because it may be over-indicated. Be careful with post-operative patients where the subacromial arch has been violated and you have no previous restriction. This is my patient where we didn't take this into account, and 2 or 3 weeks later you can see the dislocation, the anterior dislocation. Fortunately, it's biodegradable, so we don't need to do anything else to that. What do we do with this patient? Okay, well, this is what we do, and perhaps this is why the balloon works, but I think that to a large extent this is because it gives you the time that you'd need for rehabilitation, and this means that they can be free of pain. Why do we use it? Well, because literature is stronger and stronger with regards to its use over time, and because for approximately this year or towards the end of last year, it was approved by the FDA, and of course we have the support there, at least from the legal point of view, for its use. So what we do in consultation with functional patients with massive tears and irreparable lesions, what we do is look at all the different surgical possibilities and choose the best one for this particular patient. In this case, we're going to combine techniques, which I'd like to share with you. And very quickly, the surgical part, which I believe is the least important of this, we use the all suture. This is a massively huge lesion, we put an anchor in the middle of the tuberosity. We use the tendon of the biceps to have a superior reconstruction of the capsule. We release it of the transverse humeral ligament. We put this tendon through. We've lost his sound. So that we don't have to cut it, to provide the necessary tension, which is so important in reconstruction. And then we have a lasso loop to provide greater security. And so we allow ourselves to do the tenotomy, and if we do not find the cuff to put at least partially on top, then I think protect the capsular reconstruction with a subacromial balloon. As you will see, it doesn't take more than 3, 4, 5 minutes, this procedure. Then you measure it, you insert it through a cannula, you use saline solution to open it up to make it bigger, and you can see the humeral head comes down. You can protect the superior capsular repair that we've done with the biceps, and I think that we're very happy with this therapeutic option. Thinking about the differences that exist with a superior capsular reconstruction, a classic one that is costly and technically difficult in a 70-year-old patient with low demand, I think they are destined to another type of patient, personally. This is what we see in the lateral portal. This is what we do, and the results confirm this. So in sum, I think that each patient, if you can use the biceps, please use it. Be biceps preservers rather than killers. The partial repair should always be done. The subacromial balloon is indicated in low demand patients that are functional and have pain. I think that we should delay as much as possible the reverse prosthesis as far as possible, because when it works, it's great, but if there are complications, you truly regret doing it. So thank you very much once again for this invitation. Thank you, Paolo. We will now have Dr. José Carlos Vilena talking about transfer, muscle transfer. So welcome. Okay, good afternoon. I would like to thank the scientific committee. I'm going to try to talk a little bit of Portuñol. I think it's more adequate for a Latin American conference to speak Spanish than English. So please forgive my accent and my mistakes. This is a rather extensive subject. I'll try to be very objective. We must take into account that there is a very strict balance vertically in the shoulder between the deltoid muscle and the supraspinatus, and horizontal balance between the subscapular muscle with internal rotation versus the supraspinatus muscle that does the external rotation, of course. When you break that balance, there is an irregular distribution on the surface of the joint, which finally leads to degenerative arthrosis. On the right, we can see a classic case of arthroplasty of the rotator cuff that we should avoid at all costs. So the indication for the transposition is a patient that has pain and hasn't improved with physiotherapy, preferably under 65 years old with important functional demands, without pseudoparalysis and complete passive movement, with a reduction of strength in one direction. So the principles of transposition are as follows. A transposed muscle cannot compromise the function of the donor site, donor muscles, and receiving muscles must be able to perform the same range of movement and tension, as well as the traction should be similar to the receiver.
músculo receptor.
The donor muscle should replace the receiving muscle. So for the treatment, first of all, we need to understand which muscles are available and what kind of, and which ones should be replaced.
La primera situación es la pérdida de elevación.
First, we have a loss of elevation. We use the latissimus dorsi. The first description was provided by C. Gerber. External rotation. It works as a depressor of the humeral head and external rotator. So it's a clear scenario. It's very wide. We have done 2.
It's not working.
No es objetivo de esa clase.
Okay, this is not the objective of this class. Well, it is important to separate the part of latissimus dorsi, and we're talking about 10 centimeters, and it is easy to elevate humerus. So this is a typical case. This is a post-operatory patient showing the recovery of elevation, and he maintains the loss of external rotation.
Próximo. Sí, gracias. Entonces, la fixación.
So in terms of the fixation can be open or assisted by through arthroscopy. The success rate in 10 years is 74%. This is a surgery that has been established. For patients with loss of external rotation, when we're talking about the lower trapezius, this is an ideal transfer for the posterior superior lesions. The strength vector is quite similar to the spinal nerve. We have 23 millimeters of height by 40 millimeters wide. And something else. This is something more. It's more effective compared to the latissimus. The indications are irreparable of the cuff tear. I go to a little below 3. Acrohumeral interval of 7 millimeters. They need to have a functional subscapularis and no arthritis. I'm going to show a couple of videos so I can show the process. This is the approach that we do in the posterolateral head of the humerus. Today, I'm doing an incision through arthroscopy. Just to show that the tendon, the native tendon of the lower trapezius is not sufficiently long, we need to use a graft, and we have banks of grafts throughout the city. Currently, I use flexors.
Próximo, por favor.
Next.
Esse é o resultado desse
This is loss of the external rotation. This is a patient that has gained external rotation in this case, but and a little elevation. There is an improvement of 50 degrees of abduction and elevation and 30% external rotation. For patients having an internal rotation loss, pectoralis major is the one that it has been commonly used. There are two portions, the clavicular and the external, which is used for transfer.
Tá joia. Um problema que temos é que
one of the problems we have is that the pectoralis major is before the thoracic, and then and depending on the position of the humeral head, there is some forces that are exerted. The tendon is underneath the joint tendon. And there are significant improvement in terms of pain, but less predictable in terms of the strength. There is some there's a concept of 2254 according to Resch and 41-61 according to ASN. They need to have an integral supraspinatus. Latissimus dorsi is commonly used to repair the anterior superior lesions. Is more anatomic. The strength is similar to the subscapular. The technique is quite similar with the transfer for the external rotation. It's separated of the rehabilitation 6 weeks with orthesis all the time, movement of the hand and the wrist, and 6 to 12 weeks is a gain of passive movement and a progressive reinforcement up to 6 months. The general complications are xeroma, scarring, and lesion. And then one take comment: the management of the lesion in these patients is very complex. Although there are many other options, my option is trapezius inferior for posterior superior insufficiency with external rotation, and latissimus dorsi for the anterior superior insufficiency. Thank you. Dr. Benno Eisman, our dear friend, he's going to talk about the topic. He's going to talk about the superior capsule recovery. Thank you, Moscow. It is a pleasure for me to be here. Congratulations for such an amazing congress. It is not easy to bring all these people together. Congratulations, you have done such an awesome work. So I'm going to talk about the reproduction of a superior capsule, and I think that the options of my name is Benno Eisman. I'm from Sao Paulo, from the Federal University of Sao Paulo. And I think that we need to think about the difference between biology and biomechanics. because when we have a rotating cuff a lesion, when we have to go through a surgery, oftentimes we have the possibility to have good material in the anchors, but the biology is not good. In other cases, biologies are better. We have some patients which do not have the condition to do this type of work with good materials. So we have very good options. We know that we can always do a reverse prosthesis. This is an option for the patients. And as indicated, we have the capacity to do the muscle transfers, and we have several options there. I don't think that there's a specific option for every patient. We need to think about the patients and what's the type of treatment that we're going to prefer for that patient. Berha was a great defender of biological surgery. That we often try to do. We try to do a more biological treatments, and we have to do prostheses. Oftentimes, we'll have the possibility to try to maintain that patient with the best quality of life, good outcomes, and not doing any prosthesis. So when we talk about a case of a patient, we need to have a very large flow gram. We need to think about the patient, because if they have a severe arthrosis, we do know that they're going to walk with a reverse prosthesis. But we have other situations where we have to do debridement or balloons, or we can use partial repairs with the transfer of biceps and the repair of the upper capsule. So we need to think about the patient that we have and what will be our decision. We normally think that, as indicated by our friend Paula, we have the possibility to do the transfers of biceps, which is a very good option, which are quite similar as the repair of the upper capsule. This is some work that was done with a doctor from a doctor from Brazil. It is published in Arthroscopy, where we do the repair of biceps, where we do the mobilization, the subcapsule capsule repair, and then we place an anchor that and then we do the mobilization of the biceps tendon with the tenodesis fixation, and then we do the tenodesis fixation, and then we place some anchors, and then we can do the entry spine repairs. Oftentimes we do lateral repairs. This is an example of the reconstruction. And here we have the biceps. We do the debridement, all the bursectomies. Then we always look at the quality of the tissue. We're doing the debridement. We establish a new groove for the biceps. Then we do the mobilization of the biceps. And then we end up by doing the lateral reparations. We also need to think of this patient who was reporting a pain, but she went through a rotating cuff surgery. She had a tendon that, in our opinion, had a good elasticity. She had a condition to do a repair, but in this case, we thought that the patient had a biology that was negative. So we did the measurement of the size of the footprint or the lesion. And then we have the option to have a graft from the bank of tissue, so we can do the fascia lata repair. Then we do a normal repair as we normally do, with an anterior anchor. Then we place the anchor, and then the posterior, and then with this we do the stitches. We know exactly what's the exact size, and then we place the graft, and this is a step that oftentimes is quite demanding. Oftentimes it is not easy to do, and then we only do the double roll. We do the middle points, and then we do compression, and then we add more tissues, as if this were an augmentation with tendons of graft in order to improve the type of biology of the rotating cuff biology. We do the fixation here, and then we make sure that we have a double line, and then the graft is right underneath. So we start this is something, this is the old school technique. We started because we didn't have at the time the graft from the tissue bank, so we're getting the graft from the patient, and then we do the open surgery. So we do a mini open, and that's how we do the fixation, because the fixation is not it is not easy to do through arthroscopy. We need to have a lot of material. And I'm going to show you how we do the fixation. This is a work this is a paper that was published in arthroscopy. This is a 58-year-old patient. So we look at the different lesions, and in the MRI, we do a 3D reconstruction, and with that, we can obtain a model of the lesion. And with that model, we know exactly the size of the lesion. So we already know the size, and then we look at, we determine there was a bad tissue in the lesion, so we start to place the anchors for the fixation. These anchors slide, and then we place the lateral anchors, because the best thing will be to do a fixation with a double line. We have the model, and we have the graft. We do arthroscopy. We have to do the manipulation of the threads very carefully, because oftentimes it can generate certain difficulties. In this case, we are passing through the graft, and when there are right conditions, we do the lateral fixation. Oftentimes, we do not have a clear image, but oftentimes it is not easy. It may be quite demanding, but when we do this, it improves. Then we do with the lateral points, which are very important, especially in the posterior region. And this is the double line. This is the fixation and the graft that is being placed. This is one option that we can do when we have this type of device, but we need to determine how many anchors we need. So the conclusions, we need to understand the anatomy of the patient, and we need to know the diverse techniques to determine what will be the best technique for this patient. Thank you very much for your attention. Thank you. We now have Luis Alfredo Gomez, the president of the Brazilian Association, with the conference on the rigidity, the elbow rigidity arthroscopy treatment. Luis Alfredo, welcome. Good afternoon. Good afternoon. It is a pleasure to be here with you. As president of the Brazilian Association, it is a pleasure to be here in Colombia for the first time. Moscow, thank you, Paulo, that you are such a warm person. We have been talking on WhatsApp for such a long time, and I am really grateful, and I'm really grateful for this opportunity to be here with you. I'm going to talk about the stiffness on the elbow on an athlete's. Our professor, our teacher, Verdi Mori, was always very clear that the functional mobility of the elbow is from 30 to 130. Other articles refer to different amplitudes, but in general terms, globally, that's what the parameter that is most commonly followed, which goes from 30 to 130 degrees. But the question is, in high level, high performance athletes, do we need to accept this space without amplitude? We know that a minimum loss of the extension associated with pain in the endpoint will limit the performance of athletes. And of course, something has to be done. The arthroscopy release is effective to restore the movement amplitude of high-performing athletes. We have an image here, an open image, and then we have another image of the arthroscopy. The advantage is quite significant. So the arthroscopy treatment for stiffness generates a lot of advantages. It has to be minimum invasive, safe, with loss of blood losses, quick rehabilitation, and quick recovery. Therefore, these will lead to a better response to the treatment, and of course, to less complications, and with the right skilled hands to do the treatment. We had the opportunity to present our first experiences talking about this in our Brazilian orthopedics journal in 2011. And this is a case of a volleyball athlete, the 36-year-old athlete, a female. She had a lesion, a chondral lesion, and she was treated for a prolonged time of immobilization for more than 8 weeks, and she came back with the stiffness. In the exam, she had a flexo extension from 90 to 100 degrees, and the pronosupination was free. This is a video of this patient. We're in the anterior chamber where we could see the radius head, and we tried to do the flex extension. It was closed. It was closed, quite limited, and then we started with the medial portal, doing the debridement of the capsule with a basket, and then we did the capsulotomy, and this middle part there, we don't have any significant problems because the snakes or the serpents are far, so you feel more at ease in terms of the vessel. So we need to be very careful on the lateral part because we are very close to the radius hair. We are very close to the posterior nerve. We are releasing the insertion in the condyle. So with the scissors, we separate what we do the debridement, and then we use scissors to separate the capsule of the soft tissues. Then we remove part of the capsule, and with the basket we do the same process, but it's as if we were brushing. So we bite with the basket, doing this type of movement as if we were brushing. And then on the back, you can see the fat where the nerve, where we have the nerve, and we have to be very careful when doing this process. Then we complete the capsulotomy, the anterior, something similar we do with a central portal and in the cavity. If you can move, if you can show the video, we see a significant improvement of the flex extension in the posterior part and the cubital area during the debridement. And then we have the lateral and proximal insertions, In this case, it was not necessary to do any shaver aggressive. And then we're doing the debridement of the superior capsule. And then we conclude the procedure. Then, in terms of we don't have much things to do. And the final outcome and this is the immediate post-operatory. Thank you very much. Do you have any questions for our speakers? For Dr. Benio, what's the percentage of failures that you have done, that you have seen in the superior capsule, given that the literature is reporting up to 36% failures? If you have had any failures, what will be the best indication for an upper capsule at this time? Thank you for your question. We're not treating, I think that the numbers in Brazil or the figures that I have, the figures are not significant, very, very few cases. And I am doing, we need to think. Normally, I establish when I do the arthroscopy, I do a bone repair, and to me, it's a bone repair is better, and not so much the repair of a superior capsule. There are situations in patients that are not so old, but that they are adults, and they may they report the failure of the surgery, and I think that could be a good option. We need to know that the patients should not have any arthrosis, because it is better for them not to have any capsular. I think that those are the best indications that we have. If there's arthrosis, and if there is a reduction on the chromomural distance, the results will be very difficult. So I think that the outcomes will tell you the truth. The outcomes in these cases are really difficult. The problem, the best results are with the grafts, and in Brazil, the dermograft is not going to be a reality, perhaps ever. When you do the capsular reconstruction at the humerus level, why are you cutting the tendon distally? From Larry Field, that there is a suggestion to do just the transposition. So we have tried everything. For practical effects, what we decided to do, thinking rationally that biceps is a source of pain. Apparently, those who live it there have not had that complication, at least measurable. But if you look through time, many of the patients with massive lesions who are symptomatic and having tendon ruptures, they improve dramatically once they have that rupture. So I think that this is a biceps that is damaged with inflammation, degeneration, and our conduct, without criticizing the other one, is to cut it. I think that the most important aspect is that the tension of that capsular superior reconstruction is essential in order to have a depression on the head. And my suggestion is always to first do the tenodesis, and then then do the tenotomy, because otherwise it's going to be very difficult, as we did 10 years ago when we started to do this, where we had to track to do this capacity to rebuild this tension as a violin cord. Taking the time into account, it's 4:45 to go to the commercial sample. At 5, we're going to have a high lecture. I want to suggest the SLAR members that at 6 o'clock we're going to have the assembly. Is in room 3. If we cannot be there, so we will wait for you here at 5 with very interesting topics. And we will talk about shoulders.
Salón 1, barahona 1 y barahona 2.
For this general session, we will be in rooms barahona 1 and barahona 2.
Sí. No. Es que estas son charlas. ¿Listo? No. Vamos a tener una sesión de conferencias highlights.
We'll have some highlight conferences. We're going to start with Dr. Jankani, who has a talk about knowledge and transmission.
Good afternoon, everybody. So I have a very difficult talk because I'm not a specialist of philosophy. And the goal was to talk about knowledge, experience, and transfer or transmission in French. Could you push the next slide? I have no... yes. So, of course, I have no disclosure for such a presentation, but I would like to start with Michel de Montaigne, who was a French philosopher in 1572. And Michel de Montaigne probably is the well-known philosopher in the world. And he used to say, I'm not a philosopher. That means you are not a philosopher, but you can think, you can make work with your brain. And I think what you are waiting from me is just to understand what there is in my brain when I teach with young people. Please, the next slide, please. So next slide, yes. So I'm not a philosopher, and I must be modest, honestly. A surgeon is not a modest guy, but when a surgeon talk about philosophy, he must be very modest. So the first question is, when you look at this slide, where is the true? Who is the right answer? Is it the picture on the left or the picture on the right? Next slide, please. Siguiente, see. And you can complicate the problem. And finally, depending on where you are, you can see something different. And I think in South America, you can see the blue. In Europe, you can see the yellow. Maybe in the USA or in Asia, they can see the red picture. But nobody sees or is able to see the 3D dimension of this picture. So I think it's very important to understand that nobody knows what is the true, and each 10 years, each 7 years or 70 years, each 100 years, you have new discoveries who just counterbalance and totally destroy what you believe before. Yes. Next slide, please. So I have 2 or 3 slides. You see, this is a very... I grew up in Brittany in France, and this is Le Phare de la Vieille in Brittany in France, and this is in summer. Next slide, please. Siguiente. The same exactly during the storm, exactly the same. So where is the true? It depends on the time, where you are, what you see. Next picture, please. Siguiente. This is the Matterhorn in Switzerland, very well known. I used to ski there. Siguiente, por favor. Same mountain, but you have south from Italy and you have north from Switzerland. It's exactly the same mountain, one in summer, one in winter, south and north. It's exactly the same mountain. So I would like to say nobody knows where is the true, and it depends where you are in the world. Next slide, please, Siguiente. So the question is the true relative or not? Siguiente. I would like to take a few minutes to tell you the story of the allegory of a cave. So maybe you know, maybe you don't know. So this allegory, it's an history, come from Plato. Plato in 540 years before Jesus Christ. And he imagines some prisoner. You can see the prisoner behind this wall. No, please, you don't have to. Come back, please. Yes, thank you. You see this prisoner behind the wall, and imagine they are with chains, they are unchained, and with the head totally locked in front of the wall, and they see these shadows, and these shadows are moving. And imagine all the life, they are waiting like that. Siguiente, please. So Plato explained that, yes, but the shadows come from something else. And if an observer like you and me are outside of the cave, they see that there is a fire and there are other men in colors, because when you have a light, you have the colors, and they move some animals, and this animal create this shadow. So what is incredible in this allegory is the first man, the prisoners, just see one reality and they are in their own reality, but in fact the reality is something else. There is a 3D dimension, something else. So you can think now, what is the true? Of course, the true is on the side of a light, of a fire, because you see what is a 3D dimension. We are here explaining what is the 2D dimension and what is the 3D dimension. But do you think these three masters, these three men, has the right and the true? The next slide, please. In fact, if you go up out of the cave, then if you're able to go out, to exit, and you will see something totally different. But you realize that the light is not the fire, the light is the sun. There is the world outside. And finally, nobody is inside in this cave had the true. And I would like just to say that the sun, for Plato, the sun and the light is the true, and the indication is the most important thing. And the lack of indication creates the stupidity and probably the violence. Imagine now, just imagine one thing. You are here in this cave. You are one of the prisoners, and you go out of the cave to see the sun. So it's like it's just impossible to accept it, to support it, because this creates some pain on your eyes, and you want to go back immediately. It's not possible. When you have sunglasses, you look at the sun, you remove your sunglasses, then it's not possible. You cannot accept that. But that means it's very easy to understand what wanted to say Plato in 500 before Jesus Christ. Plato just say, what the true is just unsupportable. If you live of your life and you think you know, it's not possible for you to accept a new idea or an idea very different. And I think if you want to progress in life, first of all, when you listen an expert or listen somebody else in another country or somebody else who have some different ideas, first of all, you have to take off your shirt and you have to be naked and you have to be totally white and like a child listening something new, because if you are with your mind, you cannot progress at all. So the next slide, please. So now let's go to my topic. What is the knowledge? If you take the dictionary, knowledge, facts, information, skills acquired through experience of education, the theoretical or practical understanding of a subject. Next slide, please. So, siguiente. The experience is a practical contact with an observation of facts or events. And the last, please, siguiente. The transfer is knowledge. Transfer refers to sharing or disseminating of knowledge and providing inputs to problem solving. So now we're going through these three definitions. So next slide, please. Siguiente. Knowledge. Okay, siguiente. And now I would like to say just one thing. A master must stay both modest and honest, because if you lie when you give your results, if you don't want to show your failures, you will teach a lie, and your student will never understand that maybe it's the wrong way. So the problem is not to be wrong. The problem is to teach a wrong way to a student. The next slide, please. And now I just want to talk about the computers, the preoperative planning, and the artificial intelligence. Of course, I don't want to solve now this problem. But let's talk about for 1 minute or two the computer, the cooperative planning, and the artificial intelligence. For me, of course, I don't know the future, but I think that this is nothing else than some only tools. This will never take place from, of course, a surgeon like us. And I just want to take an example. For example, if you use the computer for a car, for surgery, the computer will make the surgery. Of course, you will control the computer, but with the artificial intelligence, you can imagine that one day the artificial intelligence will do better than a surgeon. Yes, but the artificial intelligence will make a decision depending on the risk of having a failure or not. And this will always be statistic and mathematics. For example, imagine there is 10% of having a failure and 90% of having a success. Okay, the computer will try, but the computer can make a mistake because we make mistake, and the computer can cut an artery or nerve. But imagine now 75% or 60% success, 40% failure. The computer will say, oh, the price with a lower, the risk of failure, and 40%, 60%, okay, I don't know. But a surgeon can target this space. He can say, yes, I have only 40% of success, but I know if I train a lot in the cadaver lab, I have to do a lot. After 10 years, I am better now. The surgeon can say, have a mentality and can go push up or not, but the man can go in a field where the machine will never go because the machine does not think anything, but the surgeon or the man have some a power inside of him who can push him sometime in the top of the mountains. We can make mistake, of course. The next slide, please. So we still have 4 minutes. Next slide. So what is the experience now? Siguiente, por favor. Siguiente. Thank you. Siguiente. Experience. How many dice faces? Of course, it's very easy because you know the answer. You know the answer because you've seen the answer. If I tell you there is a 2, there is a 1, maybe you know I'm right, but you can say, I don't know, in fact. You have to control, and this is the experience. I think the experience is the only thing that you cannot transmit. Siguiente, por favor. The experience is the only quality that cannot be transmitted. So it's not possible because the experience in the definition is you have to touch, you have to do, you have to practice. You cannot transmit any experience. You can transmit knowledge, you can transmit something. So what can I transmit to you? Please, next. So siguiente. Audacity, siguiente. You can go, please. Siguiente. Lots of things. More, siguiente. You see, you can read like me. Siguiente, and siguiente. Thank you. Not siguiente. So audacity, emotion. No, back, please. Thank you. Intuition. Sometimes when you make a prosthesis, you put your retractors. You can do anything because it's too cumbersome. You remove everything, and you can feel the soft tissue tensions. Then you can release, and you can put your prosthesis without any retractors. Empathy, of course, tenacity. You can target an area where the machine cannot target because the machine is afraid, because there is a logiciel inside, the software. Imagination. How can a machine can imaginate a new surgery? A dream. You always dream to become surgeons, and I think you become to dream very good at surgery, and you dream to treat patient. A machine cannot treat that. A machine just learn how to treat, but she does not dream to treat a patient. Optimism. We have to be optimistic, even if you have 1 failure, 2 failures, 3 failures. When I did lat dorsey at the very beginning, when I made my free flap transfer and with tools, with the 2 microsurgery, you have some failures. You have to do again. Optimism, tenacity, audacity, self-confidence. You know if you can do it. The machine cannot think she can do it. She knows she do it or not, but she cannot have some confidence in her. When to stop, why to push it, when to stop. You have to know your limit, but the limit today is not the same with your limit for tomorrow. And why to push on? Why to push on? Is for the patient good enough or just for me? Because I want to be sure I'm able. No, never forget your patient, of course. So next slide, please. So next slide. What about the transfer? So now only a few minutes. So the experience, the transfer, yes, it's very easy. The young man walks faster than the old man, but the elder knows the way. So the elder has a lot of things to teach, to transfer to the young people. This is a very old Tibetan proverb. Next, please. And you go with, you know, of course, this one, the transfer of the knowledge needs reception, positive reception. When I said you have to be next, when you listen to someone, if you want to learn, you have to be next to forget everything, because you have to be to catch everything. And the problem is, while the wise point the moon, the fool sees the finger. You know this sentence. So if you have to transfer, but you cannot give. The other can take or not. The other can catch or not. It depends of, and you have two fellows. One will catch something, the other will not catch anything, and you don't know why. Next finger, please. Next finger. So to sum up, Christian Gerber, who is one of my master, used to say, first, when you imagine a new surgery, first you look like crazy with your colleagues, then everyone tries to copy, and finally they forget you. But what is the point? Is it the man who made the discovery, or just the discovery is great for the humanity? Thank you very much.
Thank you, Dr. Kani. The next conference, Dr. Valenti. No, ¿me prestas el pasador de diapositivas, por favor? Okay, and the pointer. Doctor Valentino va a hablar de 30 años de experiencia con la transferencia tendinosa del trapecio inferior asistida.
Lights. I'm very happy to be here because I was in Colombia 10 years ago, and I talked with Felipe Toro that the people that didn't change, but the structures, the country progressed a lot, and I am very, very happy to be here. This is always the kind people in this country, and I feel that the country is very strong, and the future is very, very nice. And it's a big pleasure to be here for 3 days. So there is a technical problem. And the presentation is, Paolo told me that you have to talk about 30 years of experience of tendon transfer. And when I prepare this presentation, I try to find when I started to do a tendon transfer. And my first tendon transfer was for, okay. This is my disclosure. I started tendon transfer in 1990 on obstetrical brachial plexus because my mentor was Professor Gilbert. And we started for sequelae of obstetrical brachial plexus after failure of nerve surgery or to augment a partial result of nerve surgery. And the first transfer that I learned was a latissimus dorsi to restore active forward elevation on external rotation. And we did a lot of cases. After, to restore abduction, we use a trapezius transfer, and sometimes with a levator scapulae. And we modified the Batman technique and the Sarah technique, and we took a small bone on the VI skin incision to augment the result, but the result was not so good. It's around 80 degree of abduction. And I did with the trapezius, and I combined levator and latissimus dorsi for complete palsy, and this is as a result of the triple transfer. You see that is a complete palsy of the shoulder, and with a free tendon transfer, we obtain this result. So regarding the sequelae of brachial plexus lesion in adult, there are not many tendon transfer in 1990, and we did a lot of arthrodesis of the shoulder or osteotomy of the rotation to obtain better function. And we did a few tendon transfer, and we did a trapezius transfer in 1990s. There is no lower trapezius transfer, and we did latissimus dorsi rerouted around the humerus for external rotation, but the result was not very nice. So we talk about tendon transfer in 1990 in degenerative curve tear, and Gerber was fellow in Paris, and I knew him. He was fellow of Gilbert. And when he came back in Switzerland, he decided to applicate latissimus dorsi in adult in degenerative posterior superior curve tear. And it was the first tendon transfer for massive irreparable posterior superior tear. In United States, Michael Wolfs, I know very well, who work with Madsen and Rockwood, and he describes the pectoris major transfer, and after Resch in Europe, use this technique. And it's very interesting to understand what is the goal of tendon transfer. If the shoulder is a mild imbalance, the tendon transfer stabilize and decrease the pain. If it's completely imbalanced, tendon transfer restore external rotation or elevation on internal rotation. And we have to remember the general concept. If you use a tendon transfer, this is true for the hand, and we are with Jean Cany, hand surgeon, microsurgeon, surgeon of the upper limb, and we did a lot of tendon transfer for radial palsy, and this is the same concept for the shoulder. You have to use the tendon transfer with the same line of pull, the same lever arm, the same tension, the same excursion, transfer for one function, one movement, not two, and normal strength of the donor muscle is the concept for the brachial plexus. So if you respect that, you can expect the better result of your tendon transfer. So if we talk, because it's my topic, if we talk about lower trapezius transfer, is not very recently. You see that is 2009, 2010, 10 years ago, we did a tendon transfer, lower trapezius transfer. And in the same period, Bertilli from Brazil, and I know very well him because he did a fellowship in Paris during 7 years. And Bassem El Hassan in the same period reported the experience of lower trapezius for brachial plexus lesion. And I think that to restore external rotation for paralytic shoulder, this is the best tendon transfer for brachial plexus. And the results are very effective and reliable. The problem is that you have to use a tendon graft, a tendon allograft, to reach the infraspinatus greater tuberosity. So we have to remember the anatomy of the lower trapezius, you know very well. Insertion, dorsal and lumbar spine, tendon to the scapula, and innervation is very important that. And when you do this kind of tendon transfer, you can use a nerve stimulator, it's possible, to locate the spinal accessory nerve, because when you divide the medial trapezius from the inferior trapezius, there is a risk of the lesion of the spinal accessory nerve. It's running in the deep part of the muscle, 2 centimeters medial to the medial part of the scapula, and sometimes it's not so easy in the superior part and you can use a nerve stimulator to locate it. So it's very useful for stabilization of the scapula, and very, very nice tendon transfer, because when you do active external rotation, there is a contraction of the lower trapezius, and it's an ideal tendon transfer to restore external rotation. But it's too short, but you can use allograft or graft. This is a very nice work of Guillaume Herzberg a long time ago, more than 25 years ago. And he analyzed excursion and strength of three tendon to restore external rotation: latissimus dorsi, teres major, and lower trapezius. And if you locate the situation of this three tendon transfer, you see that the lower trapezius is close to the infraspinatus regarding excursion and strength. You see that latissimus dorsi, big excursion, but no strength. On teres major, good strength, but no excursion. And I think that lower trapezius is close to the infraspinatus. So in my experience, I use this tendon transfer since 5 years. I think that I started in 2013 or 15. And I use this tendon transfer when the subscapularis is functional. There is no supra, no infraspinatus, and the teres minor is not functional. It's the reason why I think that there are not many cases for indication of this tendon transfer, because if the teres minor is functional, you have external rotation. The problem is a pain, or the problem is a lack of forward elevation. But if you have a good teres minor, you do physiotherapy and you have hypertrophic and you restore external rotation. And for me, it's not an indication of lower trapezius. So why? You know, this is a very, very good biomechanical study. Arsler was a fellow of Bassem in Mayo Clinic, and Jean-David Bertel did the same biomechanical study. And you have to remember that the lower trapezius is very useful for external rotation 1, when the arm is to the body. When the arm is in abduction, latissimus dorsi is better. It's the reason why when you have no teres minor, you have no external rotation 1. You have a lag sign, you have a dropping sign, you have no external rotation in arm to the body. It's the reason why I prefer to use this tendon transfer in this situation. This is the theoretical advantages. You see that the same vector of action is agonist of infraspinatus. The excursion is close to the infraspinatus, but there's less strength. You see that this is a long study now, it's more than 20 years. So this is a case. Indication depends of the clinical findings, radiological findings, and perioperative finding. You see this patient. Can you do the video maybe? Maybe the video. There is a video of that.
El video, por favor.
Yes. You see that there is a lag sign, there is drop sign. There is no active external rotation. The patient is not able to maintain the arm in external position. There is no pseudoparetic shoulder. And many times you try to do physiotherapy, but it's not possible if you have no functional external rotation, no functional teres minor. This is a good indication. And regarding the imaging, I do MRI, and you can evaluate the atrophy of the muscle. You see that atrophy of supra, infra, and teres minor, on fatty infiltration. And the most important is a good subscapularis. If you have no subscapularis, you have a complete pseudoparetic shoulder. You can try tendon transfer for young people, but classic, if you have a good subscapularis and no supra, no infra, no teres minor, this is a very nice indication of lower trapezius transfer. There is no arthritis, no glenohumeral arthritis. You see that it's another patient with a drop sign. You put the arm in abduction, 30 degrees. You maintain in external rotation, and the patient is not able. On the second, the other one, she has a good forward elevation, but no active external rotation. This is a Hornblower sign. And in this situation, some surgeon does a episcopal procedure. In my hands, it doesn't work very well. I prefer to do lower trapezius transfer. Pascal Boileau published in this situation with a good forward elevation, no active external rotation, an episcopal. I did some cases, but I am not happy. I prefer to do lower trapezius transfer. So this is an excellent case. This is it was a singer, dancer, very athletic. You see that? He has external rotation. He has, on the imaging, no teres minor, no infra, no supra, but he has a very nice deltoid. And with the posterior deltoid, you can maintain in abduction in external rotation because it's the posterior fibers of the deltoid who works. There is no teres minor, but you see that when the arm is close to the body, he has no active external rotation. He has no external rotation. And sometimes with a big deltoid, they don't have any Orbloner sign, but they have a lag sign and dropping sign. So regarding the technique, I show you tomorrow a video, but I try to summarize the different steps of lower trapezius transfer. You see that I do a short incision, vertical or horizontal as you want, in the medial superior part of the scapula, and I fix the tendon graft to the head with the 4 portals with arthroscopic technique. I don't use allograft. I prefer to use autograft. And I have a semitendinous tendon. I have 20 centimeters. And I do a dual graft of 12 centimeters because it's enough. And now I reinforce with the gracilis because I think that is stronger graft. You see that the first step on the left side, the approach. When you open the skin, you have immediately the lower trapezius. It's not very complicated. It's very easy. I think that is easier if we compare to latissimus dorsi. You have to remove fat tissue. And the most important is to identify the inferior border of the lower trapezius. This is a hook technique. And you can put your finger just below the inferior border of the lower trapezius to identify. After you continue to the scapula, and there is a small tendon, very clear, and you detach the tendon from the scapula. And after you divide the lower trapezius from the medial trapezius, and it's risky, and take the nerve stimulator to identify the spinal accessory nerve. And you see that you see the pedicle, the neurovascular pedicle at the deep part of the lower trapezius. So after, it's important to use the graft, and we fixed first the graft on the great tuberosities. And I use 2 anchors, and with a space of 1 centimeter to the great tuberosities in the insertion of the infraspinatus, not too anterior, but to the insertion of the infraspinatus. And after I pass the same direction of the infraspinatus, it's important to open the aponeurosis of the infraspinatus to have a big space to obtain a good sliding of the graft. And after I use a pulver-taft technique for the muscle to fix in maximum external rotation. And now I immobilize the patient with this system. It's a little difficult to maintain 6 weeks, but the patient accepts that. And I prefer to avoid a risk of break my tendon transfer. So I report in 50 cases of irreparable posterior superior curve tear, no teres minor, good subscapularis. And it's very interesting that we have no failure in this series. And I continue now. I did the 25 cases. I have no failure. And it's very rare because with the experience of with Jean Canier regarding latissimus dorsi transfer, we had a lot of failure. But with this tendon transfer, we have no failure. all the patients, the drop sign on all bonus sign was negative. And we win not a lot of external rotation, it's 20 degrees. But before it's negative and after it's positive. Never I obtain 40 or 50 degrees of external rotation. I obtain 20 degrees of rotation. The problem when you ask to the patient, he talk that I have no strength. I have no strength. And I am happy to do that, but it's not very useful. The most important is to do that. And the patient talks that the most important is in abduction. It's not like that. They are happy to do active external rotation, the arm of the body, but in daily activity is not very useful. The patient is useful to have external rotation in abduction. And he is very good for that. And it's a discussion with Bassem, because Bassem told me that with the tendon transfer, you recover strength. It's not my experience. I recover movement, but I don't recover strength. This is an example. You see that 51 years old, is manual worker, and massive curve tear irreparable, no teres minor. And this is the results that we obtain. You see that? We have a good medial rotation. We don't lose any medial rotation with a lower traversus transfer. This is another case. We follow up 2 years and with this result. So the conclusion regarding arthroscopic lower assisted lower traverse transfer is an effective procedure to relieve pain, to restore active external rotation. My indications are selected. I don't use for supra and infra. I prefer to use latissimus dorsi transfer. I use when the teres minor there is a lack of teres minor, and the subscapularis should be good to do this tendon transfer. Thank you for your attention, and I invite you this July in Paris for the Paris International Shoulder course with Marcus Schobel between 7 to 9 July, and I think that the COVID will disappear. Thank you very much.
Muchas gracias, doctor Valentí. Estamos esperando al doctor Alex Stubbs, que está en camino.
Thank you. We're waiting for Dr. Alex Stoops. I don't know if you have any questions. Dr. Toro.
Thank you, Philippe. Very nice presentation.
Gracias, Felipe.
In terms of the fixation in the greater tuberosity, using tunnel or just with two screw, two anchor is fine. It's okay.
No, at the beginning we use a tunnel with Jean, and if you use tunnel, it's difficult not to have a angle when you penetrate into the bone. On this angle, there is a risk of rupture at this entrance in the bone. It's the reason why now we use two anchors like a cuff, and two anchors with a space of 1 centimeter to have a contact, maximum contact to the great tuberosities. And I think that is a better fixation than screw or tunnel. We know that I don't understand the concept of the tunnel, because many biomechanical study proves that the tendon inside the bone disappear. This is the first point. The second point, in the nature, in the anatomy, any tendon are in the tunnel. The tendon is close to the bone, on fixation to the periostom of the bone, and I think that is more anatomic to put the allograft or autograft with a maximum contact to the bone with a little abrasion. This is the anatomy, I think that is better. For example, when you do tendon transfer in allograft, if you do transverse suture to the allograft, you have a resorption. If you use an allograft with a stem tendon, and you suture your graft to the stem tendon on the allograft, you have no resorption. And I think that it's a good example that, and now, for example, when I take tendon transfer, I try to take a small bone, with the tendon. For example, when I do serratus anterior palsy and I take the sternal band of the and I take a bone and I put bone to the scapula, and after you see a good healing of the bone. It's better than a transosseous suture. And with the lower trapezius transfer, I have no problem of rupture for the fixation.
Thank you. Excellent conference. I have a question regarding the strength, because it's the main indication in our practice, patient with weak, especially in external rotation. Do you think the type of the graft make the difference compared with the Achilles tendon versus use the semitendinosus or hamstrings?
I don't know, because I have not the experience personally, but I did a 3 allograft, 1 allograft infection and 2 allograft correct. And Jean-David Bertel did a small series of allograft on semitendinous. There is no difference.
May I make a comment to answer to Paolo? When you make a transfer, Paolo, your tendon is M5, the strength is normal. You take it, you transfer, you lose 2 points. From M5, at the end, you only have M3. M3 is again the weight. So per definitions, a transfer cannot give strength. It just can give movement, but no power. Because of the definition of the transfer, you lose 2 points. 30% of your power you lose.
I think that the problem of the strength depends on the pain. And the patient seems to recover strength because no pain, but it's not that. You use a movement, but if you evaluate the strength, there is no strength.
Throughout all of these years of experience with these transfers, what is your preferred rehabilitation protocol? And what is the time where you expect the final result in terms of motion recovery?
I think that the lower trapezius is faster than the latissimus dorsi transfer in my experience. And after 9 to 12 months, lower trapezius is optimal. And I have some patient after 18 months with latissimus dorsi continue to recover. I think that lower trapezius is an agonist and is working immediately. Maybe it's the reason why the time for the physiotherapy is less than the latissimus dorsi. And you have some latissimus dorsi, the patient doesn't understand nothing. It's very difficult to understand a new movement for the latissimus dorsi for people. And maybe I do a study today about pacemaker. Maybe if you use pacemaker before, and after, if you continue to use pacemaker postoperatively, but very slowly, maybe the muscle doesn't decrease. And Jean Cany says that per definition, they lose 2 points. Maybe in the future with the pacemaker, they lose less, maybe. I think that we have to work with the continuity of the muscle. You have the experience that when you operate an athlete, and you do, for example, after rotator cuff tear, you repair the cuff, you lose all the muscle, and very fast, faster than the people who doesn't do any sports. This is the experience. And I think that if you use a system to maintain the trophicity of the muscle before to do hypertrophy, postoperatively to maintain the trophicity of the muscle with a pacemaker, and after, I think that the result will be maybe better in terms of strength. But I started this study since 3 months and I have not result today. But I hope so that the trophicity doesn't decrease rapidly after the operation and after a long time to recover. If you maintain with the trophicity with the pacemaker, maybe it will be better. I don't know.
is there any case where do you still prefer a lat dorsal transference, or now you use only lower trapezius?
Oh, no, I don't do only lower trapezius. I do lower trapezius for supra infra teres minor, but I continue to do latissimus dorsi. I am very happy with this transfer.
In your experience in the last decade, could you change or extend the age to indicate the transverse tendon?
No, we talk this during the lunch with Jean about the indications of tendon transfer, but sometimes I see patients after 3 operations, 1 rotator cuff tear, a recurrent tear, and he's 60 years old. What are you doing? 3 operations, no arthritis. This is theoretical, a good indication of tendon transfer, but I do reverse. I think that it's very, very difficult to evaluate a clear indication for a young guy, 50 years old, because there is if there is a recurrent tear, 3 operation, there is a risk of infection. Maybe many times the etiology of the recurrent tear is a chronic infection in young guy. And it's the reason why I don't push all the indications. I know that Jean pushed the indication of latissimus dorsi for older man. I think depends if it's an athlete, if it's he does sports, very clever man, I can push the tendon transfer. But sometimes people say, what is the post-operative after tendon transfer? And you explain very well, what is the post-operative after reverse? And the patient say, I would like your reverse, please. And it's the reason why it's very, very difficult to analyze the papers. And I think tendon transfer for me is very useful for a young guy. But after 70, 75, 80, I don't see very advantage because we have 20 years follow-up now with the reverse arthroplasty and with academic rules. There is no notch, good results. And I follow the patient with 10, 15 years. If you have 70 years and you have a good prosthesis until 90 years, it's not so bad. If you do tendon transfer, Jean say, know very well, sometimes you have to do a new operation. I don't
Tomorrow we will a symposium about the tendon transfers with Jean Cany. So I don't want to finish my question but tomorrow. I hope everything comes to the next symposium on Friday in the lunch, maybe aquí in the Barahona one. So thank you so much for the excellent presentations, philosophical presentation, and los estamos invitando para que veamos aquí, estemos aquí en la asamblea de.
We will invite you to the slard assembly.